Hello, my name is Mark Littman. I'm the director of UCL TB, and it's a real pleasure on behalf of myself and Sedona Sweeney.
I am Sedona Sweeney. I'm co-director of the TB Center at LSHTM, together with Toyin Token.
Thank you. To welcome you to World TB Day here, the London School of Hygiene UCL TB event, which is incredibly important. And we thought our title for this year, TB in a Changing World, really does reflect what is going on at the moment, both in TB and, of course, globally. So, what's a great pleasure is to welcome Ibrahim Abubakar, who here from UCL, who is the Vice Provost for Health, who's going to welcome you on behalf of UCL, followed by Liam Smeeth, who will do the same as Director of LSHTM. And then finally, we're going to have Anja Madhvani discussing the lived experience of tuberculosis. So,
Thank you very much, Mark. Good morning, everyone. Really great to be here and great to see so many colleagues. I do quite a few of these. In fact, after this, I'm rushing off to do one in cancer, but I can confidently say this one is home, right? Because I'm a TB researcher myself and built my portfolio in this community. So really great to be here. Thank you very much for joining us for the UCL LSHTM World TB Day Symposium. I'm super delighted that after so many years, this has become such a landmark event in the TB community, recognized both as a national place to have conversations, but also globally with our link internationally with the WHO, as well as the handover we do with UCSF. So it's really great to see how this has shaped up to be a really, really important event. It's also a good point annually as we mark World TB Day, whether the world is changing or not, to reflect on how the field is changing and to think through what we need to do over the year. It reflects, as always, I've looked at the program, the breadth and depth of our work. It's fascinating to see the spectrum of issues that are covered in the symposium, and rightly so, from complex clinical issues, the health system challenges, the emerging technologies and how we use them. We seem to be doing absolutely the right things to shape the future. TB is, of course, a priority, together with infections more broadly, for us at UCL. And we are delighted that our researchers continue to make significant contributions, whether it is in basic sciences, including in microbiology, in applied technologies, using AI and other technologies to make a difference. Across our university, our community continue to make a huge impact. And through initiatives such as the WHO TB Research Collaborating Center at the Institute for Global Health, we're delighted that we continue to work with international stakeholders to influence policy and have impact. We are also proud of the fact that we continue to work closely with the NHS through the TB clinics locally, because TB remains a challenge in the UK. Sadly, after many, many years of progress, some of that progress is reversed, and TB continues to be a major issue in our communities, especially among the most vulnerable. So I'm delighted that we continue to collaborate with Find and Treat and initiatives such as that to access and provide care for the most vulnerable in our society. I am proud of the fact that the work and the pipeline of activity continues, and that I see amazing stuff from our emerging researchers, PhD students, as well as postdocs doing really, really important work, but also internationally with organizations such as the Africa Health Research Institute around vaccines, as well as here in the UK looking at digital technologies to do innovative trials and produce results that influence policy and guidelines. I think TB in a Changing World is an apt title given what we are going through. Everybody in the room would be aware of the shrinking global health funding, the massive conflicts happening, which would mean inevitably displacement of people. And when people are displaced, TB increases. It's a given. So we are going to see a spike in specific places around the world in TB rates. It's therefore right and important that we've convened this meeting. And looking at the agenda, I think the discussions you are having today are absolutely the right ones to have. I think it is the right point in time to take a step back and think, yes, we must do the really high-end science, discover the next therapies, the next short course regimen, the earliest diagnostics, the AI technology to make treatments access to everybody. But we must also take a step back and say, as academic institutions, what's really our place in this? So I'm delighted to see in the program that you have debates to say, what's the UK's position in terms of what we do or what we don't do? How do we contribute to this global ecosystem? And in what way can we be more effective in shaping the future of the world? It is absolutely the right discussion to have, and I'm looking forward to the outputs and recommendations of this meeting so that you influence and have impact and contribute to our partners in the highest burden countries around the world. I thank you very much for your scholarship. I thank you very much for your leadership, and I wish you a very, very productive deliberation today. Thank you very much, and welcome to UCL. My pleasure to hand over.
Hello, everyone. I'm Liam Smeeth, Director at London School of Hygiene, Tropical Medicine. I'm also just here to welcome you. Sadly, like Ibrahim, I have to dash off as well. At the school, as it's known, London School of Hygiene, Tropical Medicine, we talk a lot about health equity as our main concern, meaning people have their best chance of their best health, no matter what disadvantages they face. And I think TB, in terms of its ability to sort of find disadvantaged and poverty-stricken groups of people in any setting, be it at the level of a local community, even within countries and between countries, TB has got to be a kind of global leader at finding and hitting the poorest people. And that gives us two really good reasons to concentrate on TB, because if one is tackling the diseases that are hitting the most disadvantaged groups, they're the people who really have the most to gain. So to improve the health of someone who's already pretty healthy and well off and living a healthy life and hasn't got a chronic infection, it's quite hard to make them more healthy, and it's quite expensive. And that's something that isn't often appreciated. That I think when people have lost so much and are facing a disease such as TB, they've got so much to gain if we can find them and diagnose them and treat them successfully. So there's good reasons to tackle TB, as well as, of course, the moral one, which is we are obliged, I think, to focus on health equity. So the challenge here is TB in a changing world. I think that's a really good one. We certainly are facing changes and challenges. I think many of you will be facing those in terms of funding, and a real political loss of interest in health in many areas, and a loss of interest in equity as well, and that's really quite dangerous for the world. And of course, there are all these other things changing, and many, many people around the world facing increased financial hardship. So I think many of these shocks, as Ibrahim says, will probably lead to an increase in TB and making this work even more important. And I think at times like these, particularly if you're at the beginning of your career and you're thinking, should I really be working in health? Is there really much of a future in health and health research? I'd say it's now more than ever we need people working in health and health research. Now more than ever we need the evidence to drive policy, and we need to make breakthroughs and innovations, whether in diagnostics or treatment or many other areas. So try not to give up. It is a challenging time for many people. It's a challenging time for science. It's a challenging time for health research. But I think it's also a really important time to come together. And at challenging times like this, I think working in partnership is really critical. And that's why I'm so delighted to see this great symposium happening, this partnership between UCL and LSHTM going from strength to strength. And I think that working together in partnership is really going to be the way forward for tackling a complex disease like TB, but also for making progress in the face of so many challenges and in the face of such a rapidly changing world. So I'm sorry I can't stick around. I wish you all good luck today, and keep working together. Thanks.
Thank you so much, Ibrahim and Liam. Really powerful words. And of course, why do we do this all? Well, we do this all because people are affected by TB, and the voice of those people affected really hasn't been heard until quite recently. At UCL and obviously the School of Hygiene and elsewhere, it's become so relevant to ensure that we are finding ways of learning from people who've had TB. And one of those best ways is actually to get people to tell us about the experience. And I'd love to welcome now Anja Madhvani, who's going to come up now and talk to us. Anja.
Hello.
Just hold the microphone close to you.
Cool. Hello. I'm going to read this because I'm not a brilliant public speaker. So I'm Anja. I live and work in Leeds, and I was diagnosed with pulmonary tuberculosis in April 2018. So I'm here to share a bit about my personal experience and to also encourage you to connect with the UCL TB PPI group. So in 2017, I was struggling with depression, and I really needed something to focus on. So I signed up for my first ultramarathon, the Marathon des Sables, a self-sufficient race consisting of 6 marathons over 7 days across the Sahara Desert, because why not? In that year, I took amazing care of myself. I nourished my body, I reduced my alcohol consumption, left a bad job, started freelancing, and I trained really hard. And I became the strongest and fittest that I had ever been, and started to feel a lot brighter in myself, and I felt like I had a real sense of purpose. If we fast forward to Christmas, my mum points out that I'm coughing. And I tell her that I've been low-key run down, but I reckon it's winter bugs and the stress that I'm putting my body under whilst I'm preparing for this race. That cough comes and goes over the next 3 months, along with tiredness, which again I put down to high mileage weeks. My GP confirms that it's a viral bug, likely a cold, and tells me to crack on. So 2 weeks later, I am crawling through the Sahara with excruciating chest pain, coughing phlegm and blood, experiencing night sweats, and struggling to eat. And I put it down to the hostile environment and tell myself that I've not worked hard enough in my preparation and that I'm paying the price. I do complete the race. It's all 156 miles. And I get home and I'm prescribed antibiotics for a chest infection. And as you might guess, those didn't do anything. 10 days later, I can barely walk, my weight has dropped a stone, and I'm sleeping on towels that have to be changed in the night because the night sweats are so bad. So in a total of about 4 months of fluctuating symptoms, I have a chest x-ray that suggests TB, and a week later, sputum tests confirm that diagnosis. Early in my treatment, things got worse, and I was admitted into an isolation unit where doctors found that my liver wasn't coping with the drugs and that I had a 5-centimetre cavity in my left lung. I was alone in that unit for 11 nights, and it's at that point that I realised that things are really quite bad. I'd worked really hard, and I felt like I was being punished for trying. The muscle mass that I'd built was rapidly wasting, and I just felt like all the potential was draining out of me. I came home from my isolation and watched Moulin Rouge, noting that Nicole Kidman made it look a lot better than I did. Treatment lasted just shy of a year, and with that came some really nasty side effects. Nerve pain, joint pain, nausea, brain fog, thrush. Nobody talks about that enough. Digestive issues and bloating. The list goes on, and honestly, what I experienced is half of what a lot of TB patients experience. And the impact was far beyond the physical. It was also financial. 70% of my earnings were from freelance work that I was no longer able to do, and I didn't have cover for loss of earnings. So it really flattened me. And that impact was also social. A lot of my friends were too scared to be near me, and even after treatment, I struggled with fatigue, which made it really hard to go out and connect with people. I had to budget my energy fastidiously. I also infected a number of other people who were treated for latent TB, most upsettingly my mother, who was the only other active case, and her health has been in steady decline ever since, and I feel really guilty every time I look at her, even though I know that that's not my fault. I felt underprepared for life after treatment. You're discharged, and that's kind of it. You're out in the world, you're still weak, you're still vulnerable, and still figuring out how to put yourself back together. We have a really incredible medical system, but it gets you back to a base level of functioning, and it's really hard to rebuild when you want to achieve more than just managing your day and going to sleep. And people around you expect you to bounce back really quickly, and that's really hard to do when your sense of safety and reality has completely shifted. What I wasn't prepared for after treatment was health anxiety, which eventually led to serious panic attacks. I tried to get back into running, but being slightly out of breath made me feel this sense of doom. Hot sunny days kind of threw my head back to the Sahara situation. Crowded tubes with poor air quality would just make me panic. In recent years, I've had the financial means to work with a personal trainer, a physiotherapist, an actual therapist, and I've educated myself on diet and nutrition to kind of get my gut health back to a decent place. And all of that really helped, but that comes at a hefty cost, and not everyone has access to those resources. CBT really helped, but 8 years on, I still sometimes struggle with getting really scared if I'm poorly or tired. Because my lived experience is that being told you have a cold could actually mean that you have something deadly growing inside of you. So I find it quite difficult to know when to go to a doctor, when to take a sick day, when to slow down, when to speed up. It's kind of hard to trust my own judgment. And something that struck me about my own experience is that it's really hard to find advice about TB because there aren't pamphlets about it in doctors' waiting rooms. There aren't local coffee mornings where you share a cake and talk to other people who understand, or where your loved ones can find connection about what it's like to support you. And I think that's because there's a lack of education, and TB comes with this stigma. I joined a Facebook forum with membership from across the globe, and most of the posts are shared anonymously. So even in this space that's designed to provide support for navigating TB, people don't even want to associate their identity with their own diagnosis. And there's also a wild amount of misinformation in there. People are sharing alternative natural treatments. I've lost my place. Yeah, people sharing natural remedies, asking strangers to interpret their test results for them rather than going back to their doctor, and spreading just really poor advice about how TB is spread and treated. And so for a long time, I kind of thought that my story was just a series of unfortunate events. But then I heard about the UCL TB patient public involvement group. And last year at our first meeting, I sat in a room with people who just really got it, which was really validating. But most importantly, we heard from experienced PPI members who have supported vital research in HIV. And we gained an understanding of what can happen when lived experience meets clinical ambition. And I started to understand that these stories aren't just kind of trauma to lug around on your own, it's essential qualitative data. So I really think that hearing from patients and understanding their experiences, not only medically, but how their diagnosis intersects with their identity and their real day-to-day lives, is absolutely vital in TB research. And to have real-world impact, we have to explore these things together. Consulting with PPI can reveal hidden factors in why some patients struggle to comply with treatment regimen, why we often see delayed diagnosis, how cultural pressures shape our recovery, the impact of complex side effects, and what it's like to experience tuberculosis alongside other comorbidities. PPI meets clinical expertise with lived experience, and the UCL TB PPI group is ready. We have the scars, the insight, the curiosity, and the interest to support researchers with essential insights into the experience of TB. And we also have people in our group who have experience of extrapulmonary TB as well. So this is a bit of an invitation to any of you who are conducting work in this area, not to just research for us, but to research with us. So if you'd like to connect with the UCL TB PPI group, please reach out to Conor Tweed, Neil Stoker, somewhere up there, or Kate Sturgeon to understand how lived experience from our group can support your essential work. Thank you for listening.
Thanks so much, Anja. What an incredible way to start today and sort of reflect on why we're all here. So we're going to move into our first session, which is all about TB beyond the lungs. And this is both in the context of extrapulmonary TB and the need for sort of holistic patient-centered care, and the need to be able to plan for holistic patient-centered care. So we're going to start with a recorded talk by Blessi Kumar.
Good afternoon. My name is Blessi Kumar, and I'm joining from New Delhi, India. I'm here today to share my lived experience of a difficult journey of surviving lymph node tuberculosis. I would like to thank the organizers for the opportunity to share my journey and bring the much needed attention to extrapulmonary TB. I was diagnosed with lymph node TB about 25 years ago. I know, it's a long time ago, but it's relevant even today because it was that experience that has driven me to be a global TB advocate today. And also because the challenges of all those years ago remain even today. Diagnosis at that time, even as it continues to be today, was a big challenge. The tools were not available at that time. I was living in a small town in the south of India, and the only medical facility available was a small rural mission hospital. Once diagnosed, I was put on treatment. I also had to undergo a surgery to remove the lymph node. I recovered physically. However, the social and the personal aspects of this experience have laid heavily on my mind and my heart. Of course, it was a long time ago, but I think even today, many of these aspects are very, very relevant, and also the challenges do continue. So why is extrapulmonary TB and lymph node TB such a challenge? My colleagues who will speak after me will give you the data and share with you some of the research findings. But I want to focus on what is considered non-medical aspects, the societal aspects. Extrapulmonary TB and lymph node TB carries a significant burden, both in incidence, morbidity, and mortality. Unfortunately, the attention to addressing this form of TB has been suboptimal. The only difference that I can see is that, yes, pulmonary TB is infectious and there is a concern of public health. But the challenges of both pulmonary and extrapulmonary TB remain the same. In fact, the diagnostic challenges of extrapulmonary TB and the delays are substantially much more and much more severe in EPTB, which is often neglected. But what is same in both pulmonary and extrapulmonary TB is firstly the stigma, which leads to a lot of fear, which then again reinforces the stigma. Many times the stigma around lymph node TB can be much more, because when you have a oozing lymph node, not only is it uncomfortable, it causes a lot of embarrassment, self-shame, and isolation. Many times, due to this, the quality of life also reduces. Secondly, for many, there is also an economic burden because it takes months and several trips to get a right diagnosis. Unfortunately, EPTB is not the first thing that comes to the minds of clinicians. Mental health is affected and is another huge burden. And the challenges of adherence to treatment remain the same for both pulmonary and extrapulmonary TB. Nutrition plays a very important role. Yet we see in our national TB programs at the country level, very rarely do people with extrapulmonary TB get access to the nutritional support as those with pulmonary TB. So what will work? This is also coming from my own experience. What will work is a supportive environment, an understanding of what lymph node TB is and what the treatment is going to be like. There wasn't enough material available that I could access then and even now. Resources, and I mean not just financial. And definitely what didn't work was the stigma around it. The fear of not knowing what the journey was going to be like. When I spoke at the Union Conference last year on lymph node TB, sharing my experience, I mentioned that the TB journey for an individual is like walking through a tunnel with no light at the other end. So information would actually give a lot of hope for people going through this journey. Even while preparing for the Union Conference and for this now, I realize that the information that is available is really very, very little on EPTB. And unfortunately, EPTB seems to be an area that is completely ignored. I would like to use this platform to call to action the different stakeholders in the TB response. First of all, I'd like to call the WHO, World Health Organization, and the Global TB Program to make extrapulmonary TB a priority. While the burden may not be as much as pulmonary TB, the challenges of getting a diagnosis and being put on treatment, living with stigma and fear, there is a lot of burden leading to unnecessary deaths in people diagnosed with EPTB. So these remain the same. To researchers, place EPTB high on the research and development agenda. We need to look at making that journey of people going through it a little bit easier and see the light at the end of the tunnel. And that requires robust research and data that is easily available. To donors, this is an area that cannot be left ignored. Invest and allocate specific and sustained funding for addressing EPTB. Especially now when all of us are moving towards considering elimination in a few years' time. And to our national TB programs, train our clinicians to think of TB and EPTB. Finally, to my civil society and community colleagues, we need to continue speaking about EPTB. We need to continue advocating, bringing this high on our advocacy agenda, whether it is with our country programs, at the country level, our political leaders and other decision-making bodies. We need to make sure that EPTB is something that is heard and addressed. Many of my fellow EPTB survivors ask, why is it that when we think of TB, the only picture that is seen is of the lungs? And I know that we have also made this mistake. But let's try to change those visuals to be more inclusive of all forms of TB. With that, I'd like to say a big thank you and ask that we all join hands together and start thinking, talking, advocating, and investing in addressing this huge challenge of extrapulmonary TB, including lymph node TB that I went through. Let's work towards our united goal of ending TB in the next few years by bringing EPTB into our response. Thank you.
So next we have Conor Tweed from UCL, who's going to present on lymph node TB.
Okay, perfect. Well, thanks everyone for the opportunity to come and talk here today. I'm just going to bang on the lymph node TB drum one more time, and then we can move on to other extrapulmonary TB. But my name's Conor Tweed. I'm a consultant respiratory physician and honorary clinical lecturer, associate professor based between North Middlesex Hospital and the MRC Clinical Trials Unit at UCL. And thanks again for the opportunity to talk through what is going to be, I think, a bit of a whistle-stop tour in 8 minutes to cover what is a very big and important and overlooked and challenging topic. I really do think that lymph node TB is important, overlooked, and challenging. It's important in that there is a huge burden of disease, and as Blessi indicated, while it may not be considered a cause of mortality or an infectious risk, it has a huge impact on the person who actually has that disease, who is affected by the condition. It's very much overlooked in terms of trials of therapeutics. For understandable reasons, we'll very much focus on pulmonary disease, and guidelines tend to extrapolate from evidence generated in pulmonary disease to advise on treatment of lymph node disease, which is perhaps okay, but there are some clear problems with that. And it's also challenging. The diagnosis, treatment monitoring, and assessment of cure are very, very different in quite fundamental ways that have, again, individual impact, clinical impact, and programmatic impact. And then just for fun, there's also paradoxical reactions, which make assessment of cure and management even more challenging. Very briefly, for my last slide, I'm going to touch on some early ideas that I'm having about how I think the toolkit does actually currently exist, however, to efficiently get the answers that we need in trials for lymph node TB, instead of waiting for observational work, extrapolated evidence, or phase 4 studies later on down the line. So to make the case, lymph node TB is first of all important. It is a significant burden of disease, the most common presentation of extrapulmonary TB in the world, at just over 50% of cases. That means a conservative estimate is that 1.3 million people globally are affected by this condition. It's most commonly seen amongst already disadvantaged groups globally, so females, children, and people living with HIV. And as I said, maybe not a cause of significant mortality, but it is a cause of significant morbidity, particularly amongst the adult population. The figure I've lifted here is from an article from Wali et al. From 2024. And while it can be a little bit, can everyone see? Yeah, so while it can be make you feel a little bit reassured at first by the fact that the majority of people with lymphadenitis are reporting minor problems, to define what a minor problem, one or more minor problems were in that paper, it was a difficulty that took substantial effort to overcome on a day-to-day basis. So I think minor is a very, it's in the eye of the beholder, I guess. But you can see here that for lymphadenitis, at least 60 to 80% of people complained of or reported anxiety, depression, pain, discomfort, and interruption with usual activities. So that's at least around about 2/3 of people. We continue to treat it with a minimum of 6 months of standard first-line treatment as a kind of standard approach, which means that we're giving people 6 months of toxic, side effect-ridden treatment that will further impact on their quality of life, with quite a poor understanding about what the best approach to treating a paucibacillary presentation of TB is in this case. As well as that, there's also drug-drug interactions or risk of them with antiretroviral therapy. And the question of what we actually do with the fact that up to 60% of people in some studies also have minimal asymptomatic pulmonary disease on top of their lymph node disease. So there's lots of it around, and it has significant effect on morbidity. Another reason I would argue that it's important is because the lymph node is potentially a supportive environment for persistence and can act as a reservoir for mycobacteria, and this in turn can lead on to increased relapse risk. Again, because the research agenda hasn't really addressed lymph node disease, evidence is not great. But we do know that even though it's a paucibacillary disease, there is evidence of a prolonged state of dormancy for the mycobacteria in the lymph nodes. So in the context of what's becoming more and more of an area of interest for subclinical TB, you've got coexistent culture negative minimal chest disease. Could the lymphatics actually be the source that's feeding mycobacteria in periodically and making this person enter into an infectious state intermittently? There's also evidence of lymph node activity on PET-CT in quantiferon asymptomatic individuals, which in one study resolved completely after 3 months of preventive therapy. Then there's the question of relapse. So there's very little data in humans, but in one macaque model, there was clear evidence of persisting PET-CT activity after what was considered successful treatment of pulmonary disease. So whenever we're thinking about how we evaluate novel regimens and how we declare pulmonary disease cured, are we actually thinking about have we turned off the tap, or is there a risk of relapse driven by mycobacteria hiding somewhere else? Sorry, I did warn everyone this is a bit of a whistle-stop tour, but lymph node TB is overlooked. So I think we've established that it's important. There's a lot of it around. It affects people and could actually be hindering our abilities to develop shorter regimens to treat TB faster. This is then reflected by it being overlooked in trials. Ilaria has conducted a systematic review of interventional clinical trials since 1993, and it's currently under review, and thank you again for the figure. But out of 63 trials, only 5 since 1993 have included people with lymph node TB and assessed treatment effect. That's 5 trials from 4 countries for a condition that is widespread and, as I said, affects a conservative estimate of 1.3 million people per year and may actually be driving our inability to develop shorter regimens that achieve relapse-free cure. So lastly, lymph node TB is challenging. Diagnosis, monitoring, and cure. They are fundamentally different for pulmonary TB versus lymph node TB. And sorry, this slide is quite busy, but it's mostly just to highlight that in the context of lymph node TB, a major consideration is that you really cannot get around the fact that you have to invasively sample. So pulmonary TB becomes the focus for trials, as I said, for clear reasons, i.e. people are producing sputum that can be used to diagnose, can be used to monitor treatment, can be used to declare cure. In the context of lymph node TB, you cannot get away without putting a needle in effectively. And that has huge implications for, one, whether or not someone actually wants to have the test done or not and be diagnosed, two, how the clinician approaches it, and three, how it's approached at a programmatic level, all of which represent significant challenges, both for treatment in the community and for research agendas as well. On top of that, imaging modalities are often much more, there's often a much more complex interaction with imaging in lymph node disease as compared to pulmonary disease. You know, as we all know, in settings, you can get away with in low-income settings, you can get away with a chest X-ray. However, lymph node TB requires many different imaging modalities, and all of which can be complex, time-consuming, and of limited availability. Paradoxical reactions, given that I've got 30 seconds left, the main thing I would say is that this is poorly understood, it causes problems, and it can happen both during and, as you can see here, after treatment in many cases. So assessing cure is difficult. It's 60-fold more common in lymph node disease compared to pulmonary disease, and it could also lend some insights into other long-term sequelae of TB, for instance, post-TB lung disease. Steroids are frequently used, and in this case they were used in people living with HIV who had pulmonary TB, and there was a difference, but extrapolation of that evidence is kind of quite tricky. And the last thing I would say is that I could not find one single study looking at people's experience of paradoxical reactions and how that impacts on their experience of disease and their experience of treatment. So what's this mean for a trial? Here's an imaginary phase 2 trial that I'm kind of in very early stages of thinking about. But the very last thing I would say is that I think we do have the tools to do this with low numbers, low cost, and to generate answers that mean something to the people who, again, are affected by disease. Bayesian methods give us an ability to borrow information. They allow us to enrich populations, and they allow us to re-randomize using techniques such as the smart design mixed with Bayesian methods. So the number of people enrolled are low, and you have a probabilistic output that's interpretable. We have artificial intelligence and machine learning for image analysis, biomarker detection to help with diagnosis. And finally, we have our old and well-tried and tested tool of qualitative methods. What are the outcomes that actually matter in the context of a condition that's a cause of morbidity as opposed to mortality? And how do we measure those outcomes for people in a way that makes sense? So, lymph node TB is important, it's overlooked, and it's challenging, but I was going to put up a picture of Lee Majors here, but I wasn't sure if anyone would get the joke. We do have the tools, and we can do better, I believe, at minimal cost, but with real-world impact, and extrapolating information and knowledge and learning about mechanistic processes into pulmonary disease and other areas of TB as well. The very last thing I'd like to say is I just want to shout out a big thank you to everyone who took part in a Lymph Node TB Symposium that we ran at the Union last year, and in a host-directed therapy and TB trials workshop that we also ran last year. Much of what I've said and a lot of my thinking as it continues to mature comes from the significant input from all the people who helped with those. Thanks, and sorry.
Thank you, Conor. Sorry to be the bad cop. So we go through the second half of this first session. So I invite to the stage Marcello Scopazzini, that is a clinical research fellow, infectious disease registrar for London School of Hygiene and Tropical Medicine. He's going to talk about TB and the heart, updates from the field. And sorry, a reminder of 8 minutes talk. Thank you.
Good morning, everyone. My name is Marcello Scopazzini. I'm an infectious disease and internal medicine physician, and I've just passed my PhD as of yesterday, where I was looking at the relation... Sorry. Where I was looking at the relationship between tuberculosis, pulmonary tuberculosis, and heart disease. And I completed my PhD in Zambia. And I wanted to take you through a little bit of the background research that brought me to this idea, and then a little bit from my research studies as well. So why is this important? When we look at the most populous countries in the world today, we know that this is already a syndemic that's happening. Cardiovascular diseases are the leading cause of death across all LMICs, but TB remains an important cause of mortality across all of these countries as well. What do we know about the evidence so far? Well, from systematic reviews and studies, mostly in high-income settings and low TB burden settings, we know that pulmonary tuberculosis is associated with up to 1.5 increased risk of cardiovascular disease morbidity and mortality, and that 1 in 5 deaths after TB may be related to cardiovascular disease. And we've got more recent evidence from the UK and the US that incidence of cardiovascular disease is also higher in the context of a recent TB diagnosis. Despite that evidence, we still don't really understand what the burden of cardiac pathology is in pulmonary tuberculosis. And if we were to trust the literature, only 2% of incident cases of TB affect the heart and cause pericarditis. But actually, from post-mortem series and more recent observational studies in sub-Saharan Africa, we think that that's probably a gross underestimate. And finally, another important thing to consider is that mechanisms of disease are likely to differ quite significantly across different regions. I only have one mechanistic slide. So at the top, we've got pulmonary TB. At the bottom, we've got cardiac disease burden. I'm going to talk less about on the left, which are indirect pathways that lead to cardiovascular disease. My research really focused on trying to understand how pulmonary TB might be related to pericarditis and myocarditis as a spectrum of disease that contributes to heart failure burden, which in the context of sub-Saharan Africa is an important consideration where heart failure burden is a significant cause of mortality. So what did I look at? Well, I set up a very simple study. It was a cross-sectional prevalence and longitudinal study where I recruited participants with pulmonary tuberculosis who were bacteriologically confirmed and paired to match comparators without pulmonary TB. They underwent a clinical assessment. We took some blood for troponin, BNP, and CRP, and then they had a point of care and a transthoracic echocardiogram. And our main outcome was what was the prevalence of cardiac pathology defined on ultrasound, and that was pericardial effusion, left ventricular systolic dysfunction, or any evidence of constrictive physiology. And quite simply, cross-sectionally, I wanted to determine prevalence and risk factors. And in the longitudinal study, in an exploratory format, I wanted to comment on the natural history of cardiac pathology that we identified cross-sectionally. So what did we find? Well, 4 in 10 people with pulmonary tuberculosis that were recruited to the study that I ran had evidence of cardiac pathology. I'll go into that in a little bit more detail. And this compared to people without pulmonary TB who only had cardiac pathology present in 1 in 10 people. And that gave us an adjusted prevalence odds ratio of nearly four-fold greater odds of cardiac pathology in people with TB compared to those without, even after adjusting for age and sex. What's important to mention is that a third of the people who were recruited to my cohort were living with HIV, but despite that, when I looked at risk factors for cardiac pathology, male sex was the predominant risk factor, and cardiac pathology wasn't associated with prevalent HIV or indeed BMI. And the reason why that's important is that almost half of the people that I recruited were severely malnourished at presentation. It was a very, very sick group of individuals. In terms of the pathology that we encountered, 1 in 6 had evidence of a pericardial effusion, but interestingly, there was also quite a high rate of myocardial disease. 1 in 5 had evidence of left ventricular systolic dysfunction, and constrictive physiology, and I'll touch on this a little bit more in the next slide, was also present in 1 in 5. And briefly, here you can see that CRP, which was our proxy measure of inflammation, was significantly raised in people with cardiac pathology compared to those without, as was BNP, which was our proxy measure of cardiac remodeling, and this translated to a 44% increased odds of cardiac pathology with every doubling of CRP, and 40% with every doubling of BNP. I think it's important to mention what happened at 6 months. The study design was mostly around the cross-sectional, to answer the cross-sectional question, and at follow-up, my study was underpowered to determine a relationship with unsuccessful outcomes. And so at the moment, we still don't know if cardiac pathology that is prevalent at diagnosis impacts whether or not people have a successful outcome at the end of TB treatment. However, what was interesting is that in those participants who had cardiac pathology at diagnosis, in the 77 of 99 that I followed up at the end of 6 months, just over half had evidence of persistent cardiac pathology at the end of TB treatment. And this, importantly, is in a group of participants who overwhelmingly had a successful treatment outcome by our current measures, i.e. they had a microbiological cure at the end of 6 months. On the right, left here, you'll see the distribution and the transition points of this cardiac pathology over time, according to the 3 pre-specified outcomes that I had. And you'll see that largely those with left ventricular systolic dysfunction and pericardial effusion had a regression in that cardiac pathology over the course of 6 months. And in those people with constrictive physiology, we found actually that 40% of people had evidence of persisting constriction at TB treatment completion. And this led me to hypothesize as a future step in research, is there a group of people with pulmonary TB who may benefit from closer follow-up and additional interventions to reduce their risk of going on to develop significant constrictive pericarditis and therefore potentially heart failure, despite having had successful TB treatment. So finally, just to leave you with a couple of slides about why I felt this was important. Well, from my work, very early exploratory, but certainly in sub-Saharan Africa, there does seem to be, or certainly in Zambia where I worked, mechanisms of pulmonary TB disease-associated cardiac pathology are more likely to result in perimyocardial pathology. And this is in contrast to some of the evidence that we have so far around TB in the heart that is focused predominantly around the relationship with atherosclerotic cardiovascular disease. Thank you. I also have some evidence that prevalent cardiac pathology does seem to improve substantially with treatment, but there may be a small group of people in whom it doesn't, and perhaps we need to investigate that further. We still don't really know whether it affects outcomes in terms of mortality, and I think that's also an important question that we should ask. Just in terms of future directions, looking at trying to see whether, I think we really need to optimize detection of cardiac pathology, particularly in resource-restricted settings that are reliant on, we're reliant on imaging, and I think AI has a role to play in this to try and optimize echocardiography and increase its availability. And finally, a question that perhaps we can discuss, is there a role for studies looking at NSAIDs or adjuvant treatments to reduce the risk of cardiac involvement in people with pulmonary tuberculosis? And I think I'll stop there, and thank you very much.
Thank you, Marcello. So let's move on. Next is a recorded video by Katherine Hill. She is a clinical research fellow from the University of St. Andrews, and she's doing a PhD with Ellen Stagg here at London School of Hygiene and Tropical Medicine, and she's going to talk on multimorbidity in TB, and she will later join online the panel for the discussion.
Good morning, my name is Dr. Katherine Hill and I am a Wellcome Trust PhD candidate at St Andrews University, researching multimorbidity in patients with TB. I'm going to present the results of a systematic review and meta-analysis where we looked at the effect of multimorbidity on the risk of post-TB lung disease. Non-communicable diseases and multimorbidity, which is defined as 2 or more coexisting long-term conditions, are increasing in lower middle income countries. This is being driven by economic development, urbanization, and lifestyle change. Shared biological and social determinants drive overlap between TB and several NCDs. Studies evaluating multimorbidity in patients with TB in LMICs report prevalences up to 45%. but the patterns of multimorbidity in TB and its effect on outcomes from TB treatment remain poorly understood. Around half of TB survivors are affected by post-TB lung disease, or PTLD. This was defined at the first International PTLD Symposium as evidence of chronic respiratory abnormality with or without symptoms, attributable at least in part to previous TB. We conducted a systematic review and meta-analysis to explore how the coexistence of either single or multiple long-term conditions alongside TB affects the risk of PTLD development. 5 databases were searched on the 7th of March 2024, and studies evaluating participants of any age with a diagnosis of TB involving the respiratory system, in which an assessment of PTLD had occurred, and presenting a description of either multimorbidity or single comorbidities in the study population were included. Random effects meta-analyses were performed where 3 or more papers defined and measured both PTLD and either the single comorbidity or multimorbidity uniformly and had extractable odds ratios. Where there were enough studies for a meta-analysis, we then went on to assess the certainty of evidence for the association using the Grading of Recommendations Assessment, Development and Evaluation, or GRADE, framework. 10,324 papers were identified from our search. Following deduplication, title and abstract screening, and full text review, 41 papers from 40 studies were retained. PTLD prevalence in TB survivors ranged from 14 to 91% across included studies. No papers analysed multimorbidity, despite 22 papers measuring and analysing more than one comorbidity. In this presentation, we are focusing on the 20 papers which use spirometry to assess PTLD. 14 papers studied the effect of co-infection with HIV on odds of PTLD. 10 of these were included in a random effects meta-analysis, and overall there were reduced odds of developing PTLD if living with HIV. Grade assessment of this association, however, was downgraded due to limitations in risk of bias, inconsistency, and possibility of publication bias in included studies, and this resulted in very low certainty of evidence of this result overall. In the remaining 4 papers, 1 paper found that people living with HIV had better lung function at 3 years following TB, but the other 3 papers found no evidence of an association. 5 papers reported on diabetes. 3 were included in a meta-analysis, and whilst all 3 reported odds ratios above 1, no overall difference in odds of PTLD with diabetes was demonstrated. The certainty of evidence was rated as very low using GRADE owing to high risk of bias, inconsistency, and imprecision. Additionally, no association was demonstrated between baseline HbA1c and PTLD in 1 paper. The final diabetes paper found no evidence of an association with airway obstruction, but increased odds of restrictive spirometry pattern with coexistent diabetes. 9 papers assessed the association of undernutrition. 3 were included in meta-analysis, and in these, undernutrition was associated with increased odds of PTLD. However, again, the certainty of this evidence is very low due to limitations in risk of bias and inconsistency. Additionally, 4 papers assessed BMI as a continuous variable, and 3 of these reported worsening lung function with reducing BMI. 1 study was in children and adolescents and found undernutrition greatly increased the odds of abnormal spirometry at the end of TB treatment. Conclusions regarding the effect of other long-term conditions on PTLD are greatly limited by inconsistency in definitions and small study sample sizes with few participants with the comorbidity included. 3 studies examined the association between pre-existing respiratory disease and PTLD. 1 found increased odds of PTLD, the other 2 did not find an association. Relative risk of both mild and moderate to severe lung impairment reduced with increased baseline hemoglobin in the 1 study which assessed this association. No evidence of an association was demonstrated in the other long-term conditions studied, but these conclusions are greatly limited, as already noted. This systematic review was greatly limited by a lack of consistency in PTLD definitions in use, and we hope that the refined PTLD definition that was published in 2025 will facilitate research into its determinants. There may be increased odds of PTLD in adults who are HIV negative, but the evidence is very uncertain. This finding is in line with prior meta-analyses. However, the mechanisms of this relationship need exploring. Whether analysed categorically or continuously, decreasing BMI is associated with increased odds of PTLD, though again, the certainty of this association is very low, and the predominance of cross-sectional studies and potential confounders in this relationship greatly limits determination of causality. We found no studies which assessed the risk of PTLD in patients living with multiple long-term conditions in LMICs. Patients with TB are more likely to have multimorbidity, and those that do have worse outcomes. The lack of research testing the association between multimorbidity and PTLD is a research gap that demands attention. And at the bottom of this slide, I've put a link to the protocol of a prospective cohort study in Uganda that I'm leading on, which aims to address this. The results of this study are expected to be published within the next 12 months. Thank you very much for listening. I welcome your questions and comments on this work.
All right, and for our last speaker in the session, we have Madriz Montero from LSHTM, who will be presenting on a cost function for estimating the costs of TB service scale-up and integration.
Morning, everyone. So today I'll be presenting a method to improve cost estimates for TB service scale-up and integration into primary care services. So this research is part of the CAPTURE project, which aims to improve efficiency of TB service delivery. And in that context, we really need good, accurate, reliable cost data because they actually go into economic evaluations that happen alongside trials, that happen alongside infectious disease modeling, and ultimately they will inform what are the best strategies for integration, for scale-up, etc. So we are talking about integration into PHC services. However, there is an issue. Depending on the setting that you're collecting the data, the costs of any TB intervention that is being assessed will vary in terms of platform capacity, so the ability to provide services given the resources available, scale and scope, so the volume of the program, the breadth of services that are provided, and how efficient is the program implemented. So basically what I'm saying is that the unit costs, so the costs of providing, let's say, screen or treatment for one person will differ between settings. And you can't simply just transfer costs from one setting to another. So in general, they are not generalizable. And it gets trickier when you're talking about integration of TB services. There's different levels of verticality that you can just simply transfer to another setting. There are shared costs that are blurry. You can't disentangle them and assign them neatly to different services. So what often happens, and in addition there's TB costs in general are very scarce, researchers often assume constant unit costs, constant average costs in their models when they're modeling expanding coverage, expanding a scale of services. And this is an issue because it ignores what's called economies of scale and scope. Instead of seeing constant costs with expanding coverage, you would expect to see decreasing cost when scale increases, or decrease in cost where the breadth or types of services increases. And this happens because you have fixed costs, so costs that do not change with scale, and those will get distributed into more and more and more services or volume of services. So that's the economies of scale and scope. So how to improve on this? So we've introduced a mechanistic cost function to estimate the costs of adding or integrating TB or HIV interventions within PHC. that explicitly accounts for capacity constraints, and I'll talk about why that's important. But basically, if you remember what I said about economies of scale, where we have fixed costs, so basically our approach allows total costs of providing TB services to be split into fixed, I'll explain this, fixed, semi-fixed costs, and variable costs. And this is to be able to capture those effects of scale and scope. So let me explain to you how it works. I didn't say before that, that we explicitly account for capacity constraints. And that is the first thing that we'll do here. So if we're able to get capacity constraints of the system, so for example, if we're able to get the maximum visits per facility in a year, this is just an example for family planning. If we're able to bend maximum visits per staff in a year, and then we have the costs of the TB services. We have fixed program costs, so this is the fixed program costs, costs that happen above the facility level. We have fixed facility costs, let's say maintenance, utilities, capital, rent. We have fixed costs, salaries, fixed staff costs, salaries, and then variable costs. So as scale increases, so the number of visits increase, coverage increases, you'll see that the fixed program costs, it remains the same, it doesn't change. The same thing will happen with the semi-fixed costs. So fixed facility costs will remain the same until we reach, so this 500 will be the same until we reach the maximum capacity of the facility, and at that point we need to add more facilities, which adds to the cost. The same thing will happen for the salaries, where we will have this same cost, this 700, and until we reach the 900 maximum visits per staff, and then we start adding more staff, and then we have the variable cost, which is simply the variable cost, which is supplies, drugs, etc., multiplied by the number of visits. So we have the total cost, which is the sum of all of these at each level, and then we have the average cost, and as you can see, as scale increases, we have a downward trend in the average cost. And that happens because we're disaggregating into this fixed and semi-fixed cost. And this is compared to a linear or a constant average cost approach, where you just have an average cost, which doesn't change, and you multiply by the number of visits. And you can see that as scale increases, we're actually getting savings if we do the approach. And you can see the downward trend in the cost curve if we use this approach. But the important thing here is that both this constant average cost and all of these costs come exactly from the same data. It's just that one is aggregated and the other one is disaggregated. So we applied this to two relevant TB and HIV policy objectives, so use cases. The first one was the scale-up of a new service, introducing a new service within the PHC platform, in this case, using expert testing as the main diagnostic tool with intensified case finding. So basically, all PHC visits would receive a WHO screening tool, and a percentage of that would receive expert. And the key here is that we disaggregate the WHO screening tool and the sputum collection, and we also disaggregate the expert test into their fixed and variable cost components. And you can see here, this is the curve of the cost using our mechanistic cost function compared to the shaded area, which is using a linear average cost function of expert test costs found in the literature through our range. And even in the lowest, we are getting these savings, which basically we're arguing that is capturing those economies of scale. And you can see the average cost curve here compared to a linear cost approach. Integration, so we applied the function to an integration of services as well. In this case, integrating cervical cancer screening into family planning visits. Again, we disaggregate the cost of the integrated service into fixed and variable, but the key here is that the capacity of the staff is actually lower now because the delivery time of the integrated service is higher. Again, this is the curve using our function, and this savings as scale increases is actually capturing both economies of scale and scope. And some of the data that you will need to do this is the capacity variable, so maximum visits per facility, per staff, per equipment, fixed program cost, fixed facility cost, staff cost, and variable cost for all of the services that you are modeling. Yep. So just to end, so who can use this? Basically, any researchers doing economic evaluation alongside infectious disease modeling, alongside epidemiological modeling that would like to improve their cost or cost effectiveness estimates, analysts, policymakers involved in priority setting processes. This is not meant to replace detailed costing exercises or detailed budgets, but it's actually an addendum that analysts can use to off-the-shelf tools, to secondary data that they already have, secondary data internationally, and it's actually fully flexible. You can add any service that you want to the tool, but if you don't have any data, you can actually use the pre-populated data that came from the Integra project, and we actually developed a web app that people can use. It's not fully finished, but it will be soon. So yeah. Thank you so much, and thank you to everyone involved as well.
Thanks so much. I'd like to invite all of our panelists up to the table. We've got 2 in person and 2 online. So we've got about 15 minutes for a discussion and questions. Would anybody like to start us off?
Thank you. Harsh Sharma. One question on lymph nodes and one question on heart. On the lymph nodes, on the HIV people, did you see any difference in disease state, for example, bacterial load, pathology, or symptoms compared to non-HIV people? And the point there being, many of the symptoms and histopathology is given to us by the functioning immune system. And a question on the heart, can I ask? Yeah, and question on the heart. Did you look for other diseases like recent viral infections, chronic viral infections, other things that may be affecting cardiomyopathy?
I'll go first. So I think the first part of the HIV, the lymph node question was whether there's a different presentation in HIV-positive people living with HIV. I think the short answer would be no, in some ways. There is an increased risk and increased prevalence of lymph node disease in people who are living with HIV, as we all know. But to be honest, whenever I've been looking through the evidence, I think more and more we're just seeing that we very poorly understand what's happening inside the lymph node in terms of the immunology. The prevalence in terms of anatomical site, as far as I can tell, is more or less is similar for HIV, people living with HIV and people not living with HIV. But I think that's based on some very scanty evidence, to be honest. So I don't think I feel comfortable making that statement. What was the second part of the question? Sorry, I forgot.
For example, the bacterial load or presentation symptoms.
Yeah, so with bacterial load, I mean, the main thing I can say is that consistently, what you can see is that lymph node disease is a paucibacillary presentation of TB. So, including HIV, people living with HIV. The thing which makes it slightly tricky is, as I hinted at in the presentation, while it's paucibacillary, the mycobacteria do seem to fall into a more prolonged state of dormancy inside the lymph node, which has implications for treatment effect, cure, and ultimate relapse from pulmonary disease as well. But as far as I'm aware, caveating based on scanty evidence, I can't think of any significant differences that I've seen in terms of bacillary load.
Sure. Yep. Oh, great. That seems to be working. Thanks for your question. I think you were asking me if I'd considered any other chronic viral conditions as. Yeah, absolutely. So the premise of the work that I did was to look at associations, and so I can't claim any causality with any of the outputs. But certainly when I was looking at the background research, I think you make a very pertinent point that there are many other contributing underlying infectious diseases that may contribute to cardiomyopathy risk, particularly across sub-Saharan Africa, but in other parts of the world. And those definitely warrant further investigation. I didn't look at them specifically. In my cohort, we did recruit people who were living with HIV, with variable, some who were established on treatment and some who weren't. And the numbers were too small to be able to derive any conclusions. There certainly seemed to look like there was an increased prevalence of cardiac pathology in those who were living with HIV. And I think you ask a very important question that I think is very important to investigate. I didn't do it myself in my study.
Thank you very much for a really engaging session. My question is for the Lymph Node TB. I would like to know if it's exclusive. I mean, do you have people with active pulmonary TB that also have Lymph Node TB? And in your trial design, how will you account for that? And yeah.
Yeah, I mean, I think the first part of your question, the answer is yes. We do see concurrent pulmonary disease. In the kind of range that I've seen is between 5 to 60% with asymptomatic, minimal concurrent pulmonary disease. But there are multiple studies which have looked at PET-CT imaging in pulmonary disease in humans. I mentioned the macaque study in terms of the reservoir, but in humans, pulmonary TB does have lymph node involvement in a lot of studies. I guess the question is, what do we think about that in terms of a trial design? I mean, for me, I think we're very much at the point where if we want to start exploring lymph node TB treatment options, we want to do it in a phase 2 environment, so an early phase trial rather than looking at a larger scale phase 3 trial. And I think I would probably have relatively strict inclusion criteria for such a trial, so trying to focus very much on exclusive presentations of lymph node TB to begin with, and maybe have minimal, like, cut-off criteria for what would be considered minimal acceptable pulmonary involvement. Yeah, I think the reality is we don't really know what's going on inside the lymph nodes in terms of how even standard first-line drugs interact with mycobacteria in that environment. And really, to my view, in terms of therapeutics in a trial, we're kind of starting at scratch and trying to work forwards both mechanistically and thinking about treatment effect.
We have one question online for Katherine. Katherine, can you hear me? Yeah, okay. The question is, apart from undernutrition, what other multimorbidities would be interesting to consider in children and adolescents?
Yeah, absolutely. Can you hear me okay?
Yeah, perfect. Yeah.
Yes, there was also, I think, one paper that looked at HIV in children, but other comorbidities were lacking. So it was really just, I think the one paper looking at HIV and then undernutrition. But it would certainly be interesting to look at, I guess, the whole premise of multimorbidity research is thinking a little bit less about individual long-term conditions and more as like holistic care and the combinations of conditions, because recognising that increasingly our patients don't come with just with one condition, they come with a bunch of different things going on, so just thinking about that as a whole parcel. So yeah, there's definitely a lot of scope both in children and adults to look at multiple overlapping long-term conditions.
Thank you. And maybe one for Andres, because it's been related on the pediatric. Your analysis would also apply in a setting of pediatric care in terms of primary health care for pediatrics. So would be major difference to look at.
I would say it would apply quite easily if the country or the analyst already has a process of collecting costs. But then I would say that the difference would be if it's happening at the facility level or at the community level, and that's where there are opportunities for further research using my cost function. Yep.
Thank you.
Thank you. My question is towards Dr. Marcello and Katherine. Is other vectors like pollens, microplastics, etc., was been considered during your researches? And another question is towards Andres. The model you have shown, I need to know the applications. Is it been applied yet? So if it would be so helpful if you let us know about the application. Thank you.
So the question was pollutants and plastics as a contributing factor in the research. I have to say I didn't look at that in the research. It potentially feeds in as a confounding risk factor. I mean, certainly we have evidence from other studies that indoor air pollution, for instance, does have a relationship with risk of TB and risk of cardiac disease. I didn't adjust for that in my study, so sorry.
Blessi, I'm so sorry. I just noticed that you've raised your hand online, so we'll pause for you to chime in here.
I just wanted to answer the question about the lymph node TB and pulmonary TB, and this is coming from experience of working at the country level. Because we are all so geared to diagnosing pulmonary TB, sputum tests, extrapulmonary TB often is overlooked. So while the person gets better with pulmonary TB, the same person could have extrapulmonary TB, which is not looked at till the very end. And this is what we see with patients coming to us towards the end for support because the extrapulmonary TB hasn't been diagnosed. So I think I just want to reiterate that we need to think of TB in all forms and look at, when we look at people, actually EPTB should come to mind, and that should also be one of the first diagnostic tests that should be offered to people who are coming with signs and symptoms of pulmonary TB. Thank you.
Thank you, Blessi. There are actually two questions for you. I'm going to merge, but basically are what have been one or two things that really helped in your journey. These come from a TB nurse and also a bit linked to for lymph node TB, like system like buddy system, shared lived experience, how these helped or help.
Thank you so much for that question. So the two main things were, you know, in terms of support, because it's very stigmatizing, and you know, you self-isolate, because with lymph node TB, like Conor showed in his presentation as well, there is a oozing a lymph node. So many times I would have persons with lymph node TB coming to me with a scarf around their neck, because it's really embarrassing to have this, and to go from pillar to post, because that isn't the first thing that's coming to the clinician's mind, that it could be TB. Takes a very long time, and I think information is power. So we talk about empowering people with TB, and part of that empowerment is actually to make simple messages available in the hands of the people and the community to understand what could it be. You know, if you have a swollen lymph node, that's oozing, that's painful, you know, it could be TB. Go to your doctor and even suggest for tests that could diagnose this. So I think two things, stigma reduction, and, you know, to really put in place mechanisms to address stigma, and information. And information, the correct information, will also reduce stigma, because you understand that it is not communicable, that your family is actually safe, you're not living in fear and driven to guilt, that you may be infecting someone, but actually EPTB is not infectious that way. So, you know, information will bring the stigma down. So when I say supportive mechanisms, these would be the top two that would come to mind to help people go through this journey of EPTB, lymph node TB.
Thank you.
I hope I answered your question.
I think so. Thank you very much.
I think we have time for one more question.
There is also one more online, but yeah.
Let's go with the one online.
Is for Conor again. At what time it was? At one time, it was thought that for lymph node TB was associated with vitamin D deficiency, and measurement in patients was advised. Is this still carried out?
Yes, so short answer is yes. We still check vitamin D levels. I think the vitamin D question, as I'm sure everyone is familiar with, or most people are familiar with, is very much one of, causation versus association. And it's true that there is, again, some evidence from research that I saw from a good few years ago now that lower vitamin D levels are associated with extrapulmonary TB. I'm not sure if I would say the link between lymph node TB specifically was as strong, but I think there is some association with low vitamin D levels and extrapulmonary TB. I mean, I think general practice is still to check vitamin D levels and, if low, replace. But we do that with kind of a poor mechanistic understanding as to why we're doing it. So yeah, I think it's the short answer is yes.
Thank you. Any final burden? Otherwise, we have to go for.
I think we're going to go ahead and close, but thank you so much to all our panelists and speakers.
A couple of, now as you see from the program, there's a break. Coffee is, you will find in both level, 2 stations on each. There's going to be for the panel, there's going to be Mentimeter questions. So during the break, you're going to see here the link to access. Also, you're going to see outside the stand from the sponsor. So please feel free to visit them and use this occasion also to thank the sponsor that are contributing to this event. And so we will be back here at 11 sharp.
Thanks so much.
And thanks to all the speakers. Sorry.
Good morning, all. And it's a really great pleasure to be here in person. I'm Leopold Chenche. I'm an assistant professor at the London School of Tropical Medicine and a senior scientist at the MRC unit in the Gambia. So I flew here for this session. So we'll be co-chairing the session on TB, global trend, and health system. So just a synopsis, this session will be exploring how global changes, including climate stress, population mobility, border policy, and constrained resource is reshaping tuberculosis epidemic and challenges existing health system response. It also will examine how this pressure redefining TB disease state, accelerating the need for public health policy rooted in justice and innovative drug formulation to sustain progress in TB control. I'm co-chairing the session with my colleague.
Hi, I'm Lucy Bell and I'm a clinical lecturer at UCL. So like the last session, we will be going through all 4 talks and then we'll have a panel at the end, so save up your questions for then.
Good. So to introduce the first speaker, we have Finn, who is an associate professor at the London School of Tropical Medicine, working with the modeling team. Over to you, Finn.
Thank you very much. Yes, so we're going to be talking here about global trends, and what bigger global trend could we have than climate change? This doesn't seem to be coming through right. Okay, hopefully the slides will be okay. So we know climate change is going to be bad for health for a whole plethora of reasons. We know in 2024, over 20 million people were internally displaced due to weather-related hazards. 733 million people faced hunger, many again as a result of weather-related hazards, and 3.5 billion people lived in areas highly vulnerable to the effects of climate change, with direct consequences for their access to healthcare. Now, all of these are critical structural drivers of TB as well, increasing risk of TB infection, of progression to TB disease, and of poor TB health outcomes. At the same time, many high TB burden countries are also incredibly and extremely vulnerable to the effects of climate change. So in 2024, we led the development of an analytical framework on TB and climate change, which has since been published as a WHO policy brief. And the intention of this was to expand our knowledge on the interactions between climate change and TB and the potential effects of climate change, to provide actionable information to stakeholders on these effects, and ultimately to raise awareness about the need to consider TB a climate-sensitive disease and to consider TB in climate mitigation, adaptation, and response mechanisms. To develop this framework, we convened a working group to identify some of the principal mechanisms by which climate change might affect TB. And here we looked at some of the principal structural drivers of TB, and then considered which of those might be sensitive to the effects of climate change and the mechanisms by which that might occur in the pathways. We developed a series of hypotheses and a priori framework, and conducted a series of literature reviews to gather evidence and synthesize the best available evidence on these different pathways by which climate change would affect TB. And then in late 2024, we held a meeting at WHO with civil society, national TB programs, funders, researchers, and other global stakeholders to update this framework. So this shows you the framework, and one of the things that I want to stress is the importance that we placed on this framework being both pragmatic and parsimonious. So acknowledging that there's an awful lot of complexity here, how can we simplify this and take it away to really get at some of the principal pathways by which climate change would affect TB. So over here you can see we have on the left-hand side climate factors such as changing temperature and rainfall and extreme weather events, then what those mean for structural and environmental determinants like ecosystem changes, poverty and inequality, and so on, and the effect that those then have on key climate and health links. And here by climate and health links we mean things like migration and displacement, food and water insecurity, and health system disruptions. These climate health links then in turn affect social and health determinants, changing things like living conditions, comorbidities, and nutritional status, and then ultimately having consequences for TB infection, TB disease, and TB outcomes. So what we found in our literature reviews was that there was a whole wealth of data and evidence and models linking climate change to each of these climate health links. So for example, a lot of evidence linking extreme weather events to migration and displacement. At the same time, there was a lot of evidence, data, and models and so on linking each of those climate health links to their consequences for TB. So again, if we think about migration and displacement, there's a lot of evidence linking migration and displacement to changes in TB infection risk, in risk of progressing to TB disease, and in terms of treatment outcomes as well. However, what we found was lacking was a body of research bringing these two fields together. And what I want to do for the second half of this talk is just very briefly outline for you how we might begin to go about addressing that gap. What I'm going to focus on here is food and water insecurity. So I'm sure many of you have seen headlines on an almost daily basis linking climate change to food and water insecurity. At the same time, we know that undernutrition, which is a direct consequence of food and water insecurity, is a critical driver of TB disease, with nearly a quarter of TB disease directly attributable to undernutrition. So we brought this together in a modeling framework to try and look at how we might quantify this whole pathway. What we took here was a TB vaccine model, which had been used extensively for national and local policy making, vaccine policy making in India. And to this model, we then included an explicit consideration of BMI as a critical indicator, or a very standardized indicator for undernutrition. We then used this model to look at the effect of energy shocks and export shocks as a result of the war in Ukraine on TB in India, and also to look at the effect of a nutritional support intervention for TB-affected households. So this shows you a very simplified schematic of what this modeling framework looks like. So we have climate change scenarios on the left-hand side, which feed into a food systems model, which takes into account things like changing land use decisions, food prices and diets and so on. This then helps us get a handle on what that means for changing nutritional status in the population. And we use this in a TB transmission model to look at how TB disease and TB treatment outcomes might change and what that means for the TB epidemic in India. The kind of climate change scenarios we explore, this is just giving you an idea of what these look like. So we're talking about everything from a sustainable future where we have policies focused on sustainable development and effective international cooperation, low levels of consumption, up to much more a bleaker future with barriers to international trade, high levels of inequality, slow economic growth, and so on. But one of the critical things here is that the way that the climate change research world thinks about climate change scenarios is not just in terms of changing emissions, but also changing socioeconomic conditions that lead to those changing emissions. So this is some work by colleagues up at the universities of Aberdeen and Edinburgh, looking at, in those different scenarios, what did we think that might mean for the population in India? So how does the population change over time? And how does the mean and BMI and distribution of BMI change in the population over time in these different scenarios? So now, this is the food systems model. So now we have an idea about how nutritional status in the population changes over time. And we can bring that together with our TB model, where we know that there's a negative dose-response relationship between BMI and risk of TB disease. So essentially, as you have very low levels of BMI, your risk of TB disease is very high, and then as your BMI increases, this flattens off a little bit and you have a lower risk of TB disease. Now, unfortunately, I can't show you the results of this, but I hope this gives you an idea about how we might bring these two different models together to get an understanding of how changes in BMI at a population level because of climate change could then be reflected in changes in TB in the population. So just to conclude, currently there's very little to no evidence on linking climate change directly to TB, so we can't quantify this link directly, but I hope that I've given you an understanding or an idea of how we might go about filling this research gap, and ultimately how critically important it is that we fill this research gap and start to think about TB as a climate-sensitive disease. So thank you for that, and I'll just end by thanking a whole wealth of collaborators.
Great. Thank you very much, Finn. So it's a pleasure to introduce our next speaker, Jess Potter, who is a respiratory physician, a qualitative public health researcher, and a tireless advocate for migrant rights and the fight to end TB. So thank you, Jess.
Thank you. Today I want to talk about the politics of policy making as it relates to TB. Oh, going the wrong way, hang on. Here we go. Today I want to talk about the politics of policy making as it relates to migration and TB. As these images show, particularly in higher income, low TB incidence settings, TB is more common among people born overseas. Nancy Krieger has shown how we embody disease risk across our life course. The pathways of embodiment, a cumulative interplay of disease exposure, susceptibility and resistance are shaped by who we are and where we live. We've all seen this before from Poonam Davin and colleagues who have illustrated how migration itself is a determinant of health with myriad mechanisms that drive both disease risk and shapes experiences of healthcare access. With more people on the move than ever before, driven out of their homes by climate instability, geopolitical instability, war, famine, globalization, TB among migrant populations is an important policy consideration, not only for high-income countries, but across the world. Governance mechanisms and policies are not constructed in a political vacuum. There has been a rise globally in
in authoritarian rule and far-right political power, and an increasing focus on the health security agenda that translates into exclusionary policies and practices. In health, we may have evidence that border policies are experienced as harmful by people who are the target of them, or that exclusions from state health systems delay TB treatment, which harms the people affected as well as the communities they live in. But evidence is just one small part of the policy-making process and its function to care. Illustrated here by Bourdieu as the left arm of the state, it's frequently undermined by the right arm, its fiscal grip and focus on border security. To illustrate this, a public health policymaker told me in an interview once about pre-entry screening for TB. That is a normal policy, to prevent people from having active infectious pulmonary TB to accessing the UK. So the policy is not for exclusion, but rather to ensure that people are treated properly, end quote. Within public health, the power to govern is often presented as the power to heal. Such framing of policy concerns using the language of healing directs inquiry towards questions of how policies might govern better, think cost effectiveness, for example, or heal more, such as screening uptake, rather than asking why govern, who is governed, and what is the impact of such government. When we centre our research on questions such as who is healed and who is harmed, and listen to the people affected by these policies, the paradox between care and security becomes clear. Posters in a pre-entry TB screening centre warn people not to hide anything and highlight the fact that this is not a substitute for seeing your usual doctor. The fact this is not care is underscored further by the head of the clinic who told me clients, we must not call them patients. During one consultation, a panel physician, Dr. Latif, said, "This is your x-ray. You can look at it if you like. It's fine." "I don't have a problem," she said, getting up to glance at the computer. "Sign here," he said. "I do not have any problem," she repeated, "not with the x-ray." The client has asked for the physician's clinical judgment. His response, "not with the x-ray," clearly demarcates his job within this consultation to not categorise the patient as fit to fly or not. Contrary to the assertion by the public health worker that pre-entry screening is to ensure that people are treated properly, I question whether these exchanges could be conceived of as care at all. Furthermore, as we know, TB exists on a spectrum between latent infection and active disease and may grumble along in lymph nodes or other nooks and crannies within the body that are not apparent on an x-ray, chest x-ray. After migration, people in my TB clinic described feeling their certificate pre-entry meant they were free from TB. This shaped how they then interpreted their symptoms when they became unwell. Other people I interviewed pointed out that if you come as a tourist for up to 6 months or more from another EU country with a high TB incidence, you're not obliged to undertake the test. And when we look at which Indians we were screening, where a year's salary not far off a return flight to the UK, they are not at risk of TB on a national scale, but an international one. In 2024, over 700,000 people were screened pre-entry by the UK government, and 338 had active TB. That's an incidence of 47 per 100,000 population, just above that of Newham down the road here in London. Of course, these decisions about who to screen are pragmatic, but who it is possible to screen is shaped by unequal global economies, which were themselves shaped by colonialism and the racism that underpinned them. If we continue to focus our policies on effectiveness as it relates to reduced TB incidence in recipient countries, we fail to see how we could have a better impact with the same resource, reducing global TB incidence through overseas investment or facilitating truly universal care provision. Contrary to this large poster from the waiting room, clients described how the process placed their lives on hold. University places were lost and marriages cancelled. One woman got left in India, separated from her family, while she completed her 6 months of TB treatment, despite the fact that she was smear negative at diagnosis. And so, through the biosecuritization of some, but not all offshore bodies, some, but not all offshore TB, some, but not all infectious diseases, pre-entry screening becomes a selectively permeable border force, reinforcing global inequities and racialized hierarchies, placing UK lives above those of others. These border-related policy concerns do not solely reside at the boundary of nation-states. A good example of this is the UK hostile environment. Policies and practices that make life in the UK difficult for people racialised as foreign or without legal documentation. They function to exclude from many social determinants of health, including housing, healthcare, and education. These exclusionary practices are bolstered by big tech and capital interests which permeate our systems. No firewall against the right arm of the state as it interferes with our duty of care. And while I've focused on examples from the UK, an exclusionary politics of care applies to people on the move all around the world. Many of us in this room are here because we want to improve the lives of people affected by TB. In its 2024 publication on the subject, the WHO states, to effectively address TB among refugees and migrants, we need innovative solutions and proven interventions, supported by strong governance and policies that are sensitive to refugees and migrants. Today, I have not tried to argue that TB screening policies are ineffective or should be abandoned. Instead, I wanted to invite you all to question the logics at play behind our policy making, the often invisible powers that shape what is possible, to ask who is healed and who is harmed by our decisions. And finally, when our systems create inequity and cause harm, I call on you all to speak up and take action. Thank you.
Great. Thank you very much, Jess. It's a pleasure to introduce Nicky McCreesh, who is an associate professor at the London School, an epidemiologist and mathematical modeller who looks into the role of heterogeneity in tuberculosis. So take it away, Nicky.
Today I'm going to talk about whether reported TB symptoms are an adequate classifier of TB disease state. So in recent years, we've seen lots of work out of London School and elsewhere highlighting the potential importance of asymptomatic or subclinical TB, driven by the recognition that a substantial proportion with prevalent TB do not report symptoms on symptom screen. This work led to a 2025 WHO report on asymptomatic TB, following a technical consultation. The report defined the division into asymptomatic and symptomatic TB based on whether people reported TB symptoms during screening, and it's that definition that I'm referring to during this presentation. The report also outlined a programme of work around asymptomatic TB. Now, some of it focuses on the potential impact of symptom-based versus symptom-agnostic screening. And here the distinction is clearly meaningful, as the yield of symptom-based screening is going to be inherently limited by the proportion of people with TB who report symptoms. The report also goes further, however, for instance, expressing a need to identify the optimal treatment for asymptomatic TB. And in doing so, the report implicitly treated asymptomatic and symptomatic TB as distinct and broadly meaningful disease states. But to what extent is this justified or helpful? Firstly, to what extent is asymptomatic TB less severe than symptomatic TB? We don't have a single agreed measure of disease severity for TB, but one thing we can look at are CRP levels, which are a non-specific measure of levels of inflammation. Here are data from 3 studies that compared CRP levels between people diagnosed with asymptomatic or symptomatic TB in clinics or during active case finding. It's a busy slide, but what we can see is that CRP levels are consistently substantially higher in people diagnosed with symptomatic TB in clinics versus symptomatic TB during active case finding. Comparing CRP levels between people diagnosed with asymptomatic versus symptomatic TB in the community, however, the results are much more varied, ranging from no difference to a substantial difference. We can also look at expert results and CAD scores as a measure of disease severity. So these are unpublished results from KwaZulu Natal, South Africa, limited to HIV-negative people. And in this particular study, there's little difference in the expert results or CAD scores between people diagnosed with symptomatic or asymptomatic TB in the community. but in line with the other studies, substantially more severe disease on average for people diagnosed with symptomatic TB in clinics versus the community. Using data from the same study, we can start to try to unpick a bit why there's so much heterogeneity between the studies and the relative severity of community-diagnosed asymptomatic or symptomatic TB. So one possible contributor to the heterogeneity is there may be more difference if everyone is tested versus if a screening step is used. In the community study, people were only tested if they had a CAD score of 25 or above of their reported symptoms, meaning it's likely with some people with lower CAD score, asymptomatic TB were missed. When we estimate what the results might have been like had everyone been tested, we find that symptomatic TB is likely to have been slightly more severe on average than asymptomatic TB, though the confidence intervals were wide and overlapping. On the other hand, though, had parallel CAD and symptom screening been used with a much higher CAD threshold for testing, then people diagnosed with asymptomatic TB would have on average had higher CAD scores than people diagnosed with symptomatic TB. And if CAD had been used as the only screening tool, there's no evidence for any difference between asymptomatic and symptomatic TB, regardless of the CAD threshold used. So that was severity. What about infectiousness? Here are data from two studies. On the left is a review of transmission to household contacts, which found that the odds of infection were 1.2 times higher for contacts of people with symptomatic TB compared to asymptomatic TB, though the confidence intervals ranged from 0.6 to 2.3, compatible with no difference to a more substantial difference. On the right are data from two papers looking at transmission in prisons in Brazil. Odds of Vigra positivity in cell contacts were 1.6 times higher for people diagnosed with symptomatic TB, but again the confidence interval was wide, ranging from 0.9 to 2.6, compatible with no difference to more substantial difference. And looking at whole genome sequencing data and using several different genomic measures of transmission, there was no difference in transmission between people diagnosed with symptomatic versus asymptomatic TB. So this raises the question, why aren't reported TB symptoms a better measure of disease severity or infectiousness for people diagnosed through inactive case finding? And I think one reason comes down to the fuzziness of symptom reporting. In these plots, from 4 studies that conducted TB screening, each point represents an interviewer. On the x-axis is the proportion of their respondents without TB who reported symptoms, and on the y-axis is the proportion of their respondents with TB who reported symptoms. And even though many of these analyses are underpowered due to the rarity of TB, there's still a substantial correlation in all 4 studies. And what this means is that whether someone with TB is diagnosed as having asymptomatic or symptomatic TB is heavily influenced by who their interviewer was. And it's worth stressing that these are data from well-conducted research studies with standardized questionnaires, robust interviewer training. It's likely that the variation between interviewers could be even higher in programmatic contexts. So we've seen that reported symptoms often aren't a great indicator of severity or infectiousness at the individual level. So we definitely shouldn't ignore ATB when it comes to morbidity or transmission. Is the proportion of people with TB who report symptoms more meaningful at the population level? This plot shows the proportion of people diagnosed with TB who reported a cough each year in the intervention arm of the Act 3 trial of community active case finding. The proportion goes down over time, which seems promising. It suggests that the successive rounds of case finding are reducing the severity of undiagnosed TB in the population. The problem comes when we add in the data for the control arm, however, who were tested for the first time in year 4. We would expect the proportion of people with TB who reported a cough will be similar to what it was in the intervention arm in year 1, when they were tested for the first time. Instead, it's more similar to the intervention arm in year 4. It's when we add in the proportion of people without TB who reported cough that it starts to make sense. In every year, a higher proportion of people with TB than without reported a cough, but the two things were very highly correlated. And therefore, the lower reporting of cough in people with TB in years 3 and 4 probably just reflects the lower symptom reporting overall. So where does this get us? Firstly, we shouldn't neglect asymptomatic TB. While the available evidence suggests that in some settings, prevalent symptomatic TB could be more severe and possibly more infectious, in other settings, there's really not that much distinction at all between asymptomatic and symptomatic TB diagnosed in the community. It therefore may not make sense to view asymptomatic TB as meaningfully different when it comes to prevention, treatment, or the potential benefits of detection. Part of the reason for this is likely to be the very substantial variation in symptom reporting between interviewers, blurring that distinction between who gets diagnosed with asymptomatic versus symptomatic TB. While the internal validity of research studies incorporating reported symptoms could potentially be improved, for instance, through robust interviewer training, that's likely to come at the expense of generalizability to more programmatic settings. Secondly, the screening setting and approach can have a large impact on the spectrum of TB disease diagnosed. Symptomatic TB diagnosed passively in clinics tends to be substantially more severe on average than symptomatic TB diagnosed actively in the community. And so we can't assume that data that are collected from people with presumptive TB in clinics can apply to all people with prevalent symptomatic TB. And in community screening, the relative severity of disease in people diagnosed with symptomatic versus asymptomatic TB can vary substantially with the screening algorithm used. And finally, we need to be very careful when generalizing or comparing data and results related to reported symptoms between different settings, between different contexts, and as we saw for Act 3, even between different rounds of the same study in the same population. And I would just like to thank some of the many people who have contributed ideas or data to this work.
A big thank you to our speakers so far. To close the session, we'll have a talk from Simon Tiberi. Simon is from GSK, he's clinical director in GSK and professor at Queen's Mary. He will be talking to us about long-lasting injectable as innovation to address all these challenges that we have been hearing about.
Thank you very much. I'd like to really thank the organisers, Leopold, for the very kind invitation today to talk to you about long-acting injectables. First of all, my conflict of interest, I am an employee of GSK, and I also have to say that at this current moment in time, GSK is not currently developing any long-acting injectables at this moment, but that may change. And why long-acting injectables? So for this brief talk, I'd like to really just talk to you about this potential option that is emerging now on our landscape, on our development landscape. And we need to understand as a TB community, you know, is this something aspirational? Is this something that can change the way we treat people with TB? We've seen that long-acting injectables can change HIV medication, and we've seen that recently. We've been using long-acting injectables for mental health issues, for neoplasia, for other things. So is this something that can fit in with TB despite funding cuts, global health critical issues? Is there a place for this? And possibly. So, you know, we know that these drug regimens could be prolonged. They could cover some of the issues that we have in TB, which is basically really prolonged care. It takes months to treat people with TB, poor adherence and pill burden, and one-shot cure could be possible. So you've got TB, here's a shot, bye-bye, you're cured. That would be amazing, wouldn't it? So long-acting injectables are particularly attractive for latent TB, drug-resistant latent TB, and populations where people have challenges with adherence that could be due to fragile healthcare systems or due to social issues. So this is, I'm not going to go through all of this, but it's just to show you that some of the drugs that are currently in development are also being currently considered as long-acting injectables. And therefore you can see there's not just one drug, but there's several drugs also from different classes. And therefore there's a hope that potentially this could be something that could help us for TB prevention, but also for TB treatment, where you could potentially combine long-acting injectable drugs together for treatment. This is the current state of play with the long-acting TB drug pipeline that I've been looking at. There's University of Liverpool with longevity looking at isoniazid, rifapentine. There's the University of North Carolina looking into rifabutin. There's TB Alliance with 2 of its drugs. There's Otsuka that's considering it. And there's a few other drugs as well that are under consideration. So bedaquiline at the moment, bedaquiline long-acting, this was presented at a late breaker at the Union last year. It's the most advanced. This currently, it's in phase 1. The interim analysis has shown no safety concerns, and the preclinical mouse models demonstrate that it has anti-TB activity for more than 12 weeks with a single injection. And this obviously could show great promise. But obviously, more needs to be done, and it needs to be developed, and it could take several years for us to understand this. And obviously, as a lot of people in the room are infectious disease specialists, we know that generally we don't like to prevent with what we use also to treat, so that there could be some challenges there. TB Alliance is looking at 4 drugs, protominid, TBAJ 876, 587, which are next generation daraquinolines, and Q203 atelasibec. These are in the preclinical stage, and so far the later generation daraquinolines have shown to show sustained drug exposure and hold promise for extended release TB regimens. There's also macrozinone, which is a DPRE1 inhibitor, and this is currently being developed by Medincell and with Innovative Medicines for TB, and currently supported by EU's ERA4TB consortium. There's also something called in situ forming implants, which are great. So you inject a liquid subcutaneously into a person, and this forms a solid drug delivery device, which then leaches into the body. And this could be great. It's a single injection could last up to 4 months. It's aimed at LMICs already. It would avoid surgical removal because it's biodegradable. And currently, rifabutin is the drug that's being developed for this with Gates funding. Obviously, rifabutin might not be the most safe or the least toxic drug known to man, and therefore some monitoring is probably required, unfortunately. But possibly it could be used for other drugs. So long-acting, primary focus at the moment is for TB prevention, TB preventive treatment, so this would be a one-shot cure, and then potentially active TB treatment at a later stage. And TB Alliance has already presented this in other conferences, the 1x1, which is 1 month of intensive oral treatment followed by injections with a continuation phase. And real-world implementation. So we know this has already been done for psychotic illnesses. We know this has been done for HIV. And therefore, we know that potentially what this long-acting injectables could bring is reduced clinic visits. It could reduce the need or remove the need of DOT. It could simplify community delivery strategies. And therefore, you know, this could really radically change some of what we do in the clinic. Already, but there are challenges, and one of the challenges is that none of this is cheap, and it will take time, and this could take a decade or longer, especially when you're thinking about treatment where you may need to combine long-acting injectables together. There could be drug-drug interactions with antiretrovirals. The suspensions all have pros and cons. The injection volume, depending on the drug, not all drugs are great candidates for injections. So if you're looking at a drug that needs 2,000 milligrams a day or 1,000 milligrams, that's an enormous amount of volume to inject into somebody. You may need more frequent injections. Not all populations around the world accept injections. So we know that in West African populations don't like injections. So that needs to be also considered around injection hesitancy. Cold chain requirements could be a problem. Manufacturing costs as well. So when we go to payers, where they're saying, well, it costs $20 to treat somebody for 6 months with TB, and now you're asking me for hundreds to give them an injection, you also need to also have that conversation there as well. So to conclude, LAIs could really transform the way we treat and prevent TB. We're not very good at preventing TB because people generally are given these tablets to take. They start taking them, they go, these people are crazy, I feel completely well, and I'm not going to take them. So a lot of people just don't adhere to TB preventive treatment. So this could change with long-acting injectables. There's a growing pipeline, and therefore there's hope that we may be able to see some of these drugs in our lifetime. And HIV, long-acting injectables, have already shown us that it is possible to bring these to low middle income countries and really change the way that we manage HIV infection. But is it realistic? And how much money is it going to cost? And in this funding crisis, do we have the money to do this? And it's clear that oral only at the moment is likely to be the main focus for the foreseeable future. So I'd like to thank you for your attention. Happy to take my questions.
Great, yes, thank you. So we'd like to invite all of our panelists back to the stage for our discussion and questions. So we're going to alternate questions in the room and online. So if there's any questions in the room, please put your hand up and Leopold will call on you and then we'll move to some online questions.
Thank you. Several questions. If I can ask my first question and then give away for the long-acting therapies. You mentioned a lot of challenges. And one of the challenges which we need to discuss is if the patient develops toxicity to this drug, how will you withdraw it?
That's a great question. So I think for long-acting injectables with particular suspensions, it'll be impossible to withdraw that. So if it's an intramuscular suspension, then you won't be able to do that. So it would need to require supportive management. However, with the in situ forming injectables, so the University of North Carolina with these polymers, which are subcutaneous, you could be able to inside the skin and remove the solid drug delivery device. So it would be possible. But only with some of the long-acting injectables. So only the polymers, the subcutaneous ones, you can actually remove. So if somebody all of a sudden develops agranulocytosis with rifampicin, which could happen, you'll be able to remove the solid device from the subcutaneous area. No, it hasn't gone into first-time in human studies as yet. It's being done in animals at the moment, but we're hoping that first-time in human studies will start with these polymers with the University of North Carolina. Thank you.
Great, thank you. We've got another question online for you, Simon, actually, which is from an anonymous attendee, how do the long-acting injectables compare cost-wise to standard oral antimicrobial therapy for TB?
It's a really good question. So I think for drug-susceptible TB, it's unlikely that a long-acting injectable is going to cost less than $20, from my understanding. Never say never. But I think we're very far away from knowing exactly how much a long-acting injectable would cost on the market. And pricing may be different from different areas of the world based on whether they're high income or lower income. So all of that needs to be factored in. And obviously there will be some cost savings, which I believe your groups here are world experts in cost effectiveness studies. So you would then be seeing whether, programs could save costs from resources, etc., because it's just a one-shot treatment.
Thank you.
Any other question in the room?
So my question is to Finn. Did you guys included heat exposure in your scenario? Because I come from Pakistan and we're seeing that we're working with miners, we're working with bricklaying workers, and I'm yet to prove it, but I'm seeing quite some link.
I think that's a really good question. So we focused in the framework that we developed on just a couple of key priorities there. So the migration and displacement, food and water insecurity, and health system disruptions. But I think there's a lot of other pathways as well. Heat exposure is certainly one of them. What that means for people, in congregate settings, potentially with air conditioning. Air pollution is another potentially important pathway there. And we sort of see what we've done as the kind of the first step in trying to think about how we might address this. But I think there are so many different pathways and so many different things going on that, there's a lot of unanswered questions.
Any question online?
We have a question online, which I think is probably for Simon, but maybe just be able to also comment as well, which is why is Protominid not kept under the WHO A, B, and C grouping of drug-resistant TB drugs?
That's a really good question. I think the classification is used for XDR-TB. But currently, because of BPALM and there's another 4 regimens that are recommended, so there's 5 MDR regimens, they don't really use that classification anymore for MDR-TB. So I think that's a reason. But it's a good question. I think protominid, in theory, is, but officially the guidance hasn't put it in yet. And I think guidance may be updated in the next year or two, so they might decide to do that. But good question.
I mean, any other question? Yeah. Okay, good.
Got a question at the front here, I think.
How long is the in situ? Does it last? Does it biodegrade, or does it stay within the? Yeah. So how long does the in situ formation stay, or does it degrade within?
We believe up to 4 months, 16 weeks.
Oh, okay.
So a long, long period.
Thanks. Message for Jess. There's a tendency to feel quite gloomy about the politics of TB care. Can we find some good news anywhere?
We met with the all-party parliamentary group on TB yesterday, and I think if you engage with your parliamentary representatives, and actually we see this with the Global TB Caucus as well, which is a kind of global APPG, then people are interested and they do care, because people living in their communities are affected by TB, but they just need to be shown the way. And you all have a powerful voice and you can use it. And there are people who will listen. You've got to tell the right story so that they can hear it best.
Yeah, we have a question.
Thank you all for a fantastic session. Just a question for Nicky. So we've heard a lot about asymptomatic TB in recent years and how that's being adapted into global reporting, etc. So we sort of appreciate the views that you've raised and the sort of with regards to limitations. What do you think the best approach is moving forward about how we use those symptom-based definitions whilst acknowledging their limitations? You know, what does your counterpoint sort of mean for the best use of those definitions moving forward?
So generally I would move away from symptom-based definitions wherever possible, but I think if you want to stick with symptom-based, I think acknowledging that this, the WHO 4 symptom screen was developed as a sensitive screening tool for HIV, for people with HIV, living with HIV, right? It was never designed as a classifier of disease states. My suspicion would be that maybe when you get nearer to this more severe symptoms end of things, maybe that's a more meaningful classifier of disease state. But I definitely think we need to separate out symptom definition for screening from symptom definition for definition of disease state.
Great.
Great, we've got another few online, so we might just take one of those before we move back to the room. We have a question online for Jess, which is, what about the community response to TB? Are there any plans for large-scale community mobilisation, especially with the expected rise in cases due to climate change and other factors, which not only depends on policies, but also how people can support each other?
So I won't necessarily speak about the global situation, but there are many people in communities around who are organising to raise awareness about TB, to support people into care, and many of you are involved in research that looks at how that work supports earlier diagnosis. And more holistic approaches and patient-centred approaches to care. Again, we heard from Anja earlier, it's so important that people affected by TB and the broader communities affected by TB are centred in our research and our policy making and also our advocacy, and that we all work together to raise awareness about TB so that we can lift it up people's agendas.
why? Okay, another question.
Hi, my question is to Jess. You have hinted at, the rise of the far right, here and Europe. How the far right, in politics, intersects with, TB care and health and, climate in general around immigration policies and access to health care for migrants.
So the point that I made at the beginning is that policy is not constructed in a political vacuum, and the policies that are made possible because of the overall kind of where we are on the political spectrum, and what becomes possible changes depending on what is going on outside in the wider world. And if we've got a large, powerful, authoritarian, right-wing, racist agenda, then that shapes the policies that are implemented, but also the conditions in which people live and the discrimination in which they experience, their fear of interacting with institutions, particularly because institutions are representative of that overall power. And obviously those experiences will be different depending on whether you live in an authoritarian state or a democratic one, but even in democratic states, there is significant power that isn't just held by the majority, but by, for example, the media and how they construct and overlay, frame crises like, for example, the migration crisis and the NHS crisis, which again narrows your opportunities for inclusive policy making.
Any question online?
We have another couple of questions online for Simon. A lot of excitement online about the long-acting injectables, I think. So I'll just bundle two together. What feasible time frame are we looking at for these to come through? And then how does the injection compare with the 3HP regimen in terms of effectiveness?
Great questions. So timeline-wise, that's a good question. So how long is a piece of string? So drug development can take a decade, 2 decades for a drug from discovery to approval. So obviously it also depends on how much resource is put into that particular program, whether that's a company on its own, whether that's an academic institution like the University of North Carolina, or whether that's a group of people funded by the European Union or by NIH. But probably about 10 years, I would think, plus or minus 3 years, depending on that. And how it with the first time in human study from Janssen, from what I could see on internet, or what's available, common knowledge, in theory, is that the long-acting bedaquiline could compare with 3HP, so that there's good PK, that drug is at therapeutic levels for 12 weeks and could compare with 3HP. Obviously, asymptomatic TB could be a challenge, and obviously, the use of bedaquiline in prevention could see higher increases of bedaquiline resistance, possibly. So, do you need to combine that with another drug? And then bringing into Conor's great talk on, lymph node TB, potentially one injection of 2 drugs could potentially be a treatment for non-severe lymph node TB, for example. So, how much is that worth investment? Would people go and invest resources into that? That I don't know.
We still have time for some questions. I have one for Nicky. Or you
I've got a question for Nicky.
Yeah, we both have questions for Nicky. You go first.
In the UK, we often look at time to, we collect data on symptom onset. And as we know in qualitative research, that narrative is a construction between 2 people, and how we process our symptoms is shaped by the context of our lives. How valid is that data? And we do a lot around worrying about what that data means and reducing time to diagnosis. What should we be collecting something instead?
So we know if we look at prevalence surveys, people have TB for a long time, a decent proportion of that time period is with symptomatic TB. If you compare that with the how long have you had symptoms, and everyone seems to answer like 2 weeks, right? Those two things don't match up. So it's obviously not a valid measure of the total amount of time someone's had symptoms for, whether it's a measure of the duration of their latest episode of symptoms or how long have they had the most recent severe symptoms. I don't know, but yeah, I wouldn't put a huge amount of trust in that data.
Good. My question for you, Nicky, is you showed a model of classifying different types of TB, really focusing on latent TB and unpacking asymptomatic. I wonder if the model could be applied in active TB, because also we find a lot of heterogeneity there, and that stratification could inform treatment options.
Sorry, can I?
I wonder if the model that you develop in classifying the different the asymptomatic TB and latent TB could be applied in active TB, because we also find a lot of heterogeneity during active TB, and that could be, stratification that could inform treatment options.
So I think we definitely should have different treatment options for different kind of severities of TB. I don't think that should be based, or at least not primarily based on symptoms, because I don't think it's a particularly informative measure. I think things, bacteriological load, CAD scores are probably going to be more informative rather than reported symptoms. I'm not sure if that's your question.
Yeah. I was actually talking about those parameters, like the bacterial load, site of disease, things like that.
So a couple of last questions online, and then we'll maybe take a few minutes before the panel session for people to do the Mentimeter if anyone's not done it yet. So we've got a question for Finn. With the relatively recent withdrawal of USAID funds, are there any initial consequences already being seen for how that's affecting TB patients' incidence?
Yes, so for TB patients, I'm not necessarily the right person to ask for, but there's definitely been a lot of work, including some from our group, from Rebecca Clark and Catherine Horton, looking at what some of the consequences of this might be, both in terms of things like TB incidence and burden and so on, but also what that might mean for costs for TB patients who are now, struggling to access care, or maybe having less access to some preventive therapies and those kind of things. So there definitely are some very serious long-term consequences with major repercussions, and I can point you in the direction of some people who know more about that than me.
Great, thank you. And last question for Simon online. Any insights into the risk of acquiring drug resistance during long-acting monotherapy?
We don't know that yet, no. There's no evidence of that so far, but it would be interesting to know that before we create more resistance, yes.
Sounds sensible.
We still have 5 minutes. We have to leave some time for the panelists to sit, but if there's one last burning question. Yeah, please.
Thank you. A question on the symptoms and classifiers of TB. When we are diagnosing TB or classifying any disease, we need two important sets of data: sensitivity and specificity. And more you look, harder you try, sensitivity increases and specificity decreases. Would you like to comment on that, please?
Yeah, so I think, actually, one of the advantages of this kind of very fuzziness of symptom reporting is that we could almost train it in the way we choose our CAD score based on what the sensitivity and specificity we want and how many experts we can afford to do. We could tailor our approach to asking about symptoms in the same way, right? If we've got a very limited number of tests available, we could ask only about the most severe symptoms and not really probe much. Whereas if we want a much more sensitive approach, then the more we probe about symptoms, the more sensitive it's going to be and the less specific.
So with that, I would like to really thank my co-chair, Lucy, and all the speakers for really engaging a session, nice presentation, all the audience and online for really nice questions.
Great. Thank you, everybody.
Hello. welcome to this last session, I think before lunch. If you are feeling sleepy, we hope that this is going to wake you up a little bit. So let's have a conversation. We have chosen a very deliberately engaging topic. Should high-income country institutions have a declining role in TB research? This is not chosen to make anyone feel uncomfortable, although we realize that that was perhaps the first thought, that this is perhaps provocative. And I chose to say deliberately engaging rather than deliberately provocative, because then I have to then say, who is feeling provoked? What is exactly so triggering? Anyway, we have a group of experts today, TB researchers, and we hope that in the next hour, they can help us unpick what declining role means. We hope that we can together reflect on what roles still remain legitimate and perhaps what roles should be declining. And at the end, we hope we can try and find out ways of moving forward. How do we transition? We're not here to try and agree. It's okay if we do not. But disagreements as well are okay, in that it's through those disagreements that we can realize what it is that we need to work on. So I hope you've all done your Mentimeter. I'm just going to give you a couple more, seconds to press submit if you haven't, before handing over to Helen to introduce the speakers.
Thank you, Lele. So I'm actually going to dive us straight in with the first block of questions, which is around decolonization. So there's going to be two questions that I'm going to ask the panel, and then we'll go to the Mentimeter to kind of get your audience reactions in this space. Just to say, we would like this session to be quite engaged from you folks in the audience. I actually slightly disagree with Lele. I do want this session to be provocative, and I want you to all examine your deepest, darkest souls and take something away from it for the future, whatever that may be. So for the panel, I'll just say Sedona's very helpfully helping us out with the Zoom online rather than being part of the panel, just to flag that. But for the panel, perhaps when you first speak, can you just say something about what we call your positionality? So your position that you're coming into this, rather than us taking a while to do introductions. So the first two questions that I'm going to awkwardly ask the panel together in a way that you're always advised not to do. What impacts do you feel colonialism and neocolonialism have had on academia, and what does decolonizing global health mean to you? Let's start with you, Toyin.
All right. Thanks, Elaine. I would like to start, as you said, about positionality. I'm an African diaspora researcher, and I'm a senior researcher at an institution here in the UK at the London School, where I'm the co-director of the TB Center. So I come into this conversation with my own privileges, which I always want to declare up front. My experience, my privileges are not the same as those of researchers, African researchers who are based in Africa and working in institutions in Africa, many of whom are amazing researchers that I work collaboratively with. So with regard to your question about what has been the impact of colonization and neocolonialism in academia, without a doubt, it's the same thing in economics, where colonial powers, even after the independence of the countries, still have these extractive practices in which resources are moving from the colonized countries to the colonial powers. We are seeing the same thing being replicated in academia and in research with extractive data practices, extractive research practices, and that essentially is what, to me, decolonizing global health means. It means changing, confronting, recognizing, confronting, and changing or disrupting that power dynamics that, prevents such the continuation of such practices. shifting the power imbalance that exists, that keeps the power with the former colonizers and takes it away from the countries where the challenges might be. Thank you.
That's brilliant. Thank you, Dhyan. I'm going to jump to Tim. See if your microphone's working.
Can you hear me? You can now, yes. I was hoping I might be forgotten on the end. So I'm Tim McHugh. I'm a medical microbiologist, so my position is from the laboratory, but backed with many years of collaboration with colleagues, mainly in East Africa, but across Africa as a whole, where we've been involved in capacity development through a variety of schemes, often associated with the delivery of clinical trials funded by the EU and the TB Alliance. You can see the other features of me. I'm white, quite old, and European. So that's another important factor in my position. I did ask for us not to use terminology. My terminology is all microbiological, so some of the terms that Helen tends to use are quite sociological, and I get lost in them, and then I'm anxious that I might misuse them. So that's another feature that you might consider. So, impact of colonialism and what is decolonising. I think you'll hear much the same messages from everybody, I imagine. I think it's decolonising is about the shift of power. We come from a setting, so for me, starting my career in the 1980s, we see a shift from the truly post-colonial era when the European countries were pulling out of Africa, and that sort of colonial service model still existed, through to a situation where the power organisation infrastructure has changed, has had to change over that time period, and with that we see too slowly a shift in power from the colonial forces, the colonial powers with resource and people, to that being switched to our partner states. I think the real area, though, that we need to think about is the agenda setting. So regardless of the infrastructure, the finance, how that's all organised, it's about who sets the agenda, and whether the agenda is set from my position as a microbiologist working in central London, dealing with a low incidence TB population, as opposed to my colleagues in East Africa sitting with a high incidence population with very different settings. I'll finish there.
Thank you, Tim. I'm just looking at the Mentimeter and what's come up. So the word kind of funding is there, and I'm sure I saw rebalancing funding at some point. I slightly lost it in the cloud. And so I wonder if we could switch to you, Refalo, with the question, in what way can research funders and donors help reframe conversations around decolonisation and move the transition along?
Thank you, Helen. And my name is Refilo Machi. I'm with the Gates Foundation, and I'm based here in the UK. So when we initially started the discussions and you mentioned the word decolonization, I had to go back to the dictionary, because the last time I heard of that word, I think it was in history. Now, to talk about it today and in the space where we are, I think there are several factors that we need to think of, even from the foundation's point of view. The first one is in relation to leadership, that we are talking of a disease that we know still kills many people in low middle income countries. So the first one, when we talk of decolonization, we need to think of where the burden of disease is, and also the power sharing. That would be the first point. And also secondly, we need to position partners in the global south as agenda setters, not just the delivery arms, because quite often you find the research topic is set up somewhere, but those that live with the highest burden of disease more or less are part of the delivery. The discussions have to be around the table, and everyone has to be part of those discussions. And I think the last point, still again talking about decolonization, we need to look at it. In TB, decolonization is not rhetoric, and it is about who defines the questions, who benefits at the end of the day when the answers come up. It will be unfortunate, really, that at this age and era we can come with beautiful research topics, and yet the people who need to benefit are not benefiting. We are not making an impact in reducing the morbidity and mortality towards TB in this age and era.
Thank you very much. So going back to Tim's point, we did promise to Tim that we wouldn't use terms that were then a bit incomprehensible, but I deliberately wanted to jump into decolonizing or decolonization as a term without defining it, because I wanted this to represent your actual opinions. So Dana, I'll come to you to see if there's anything in a minute. But just to pick up on statements we've got up here in the word cloud. So we've got this idea of equity, equality, justice, and we are kind of going to be talking about equity, equality, distribution of roles in a later question in this session. And we've got ownership and agency, but there was definitely an historical justice, which is really important because we know the universities were essentially formed under colonial systems and are still creating colonial structures today. But I was also fascinated, there's a point in here somewhere about essentially it just being a key word that people throw around without any intent of action. I think that's what you were alluding to there, Rifalo. It's got to be something that we do intentionally and don't just bash around. So are there any reactions from the audience in any of the three questions we've asked? So the impacts of colonialism and neocolonialism that they've had in academia, what does decolonizing global health mean to you, and in what ways you think research funders or donors can help reframe conversations? Yeah.
So just one comment online from Gail Morgan, which is that it's a classic example of how structure automatically controls the conversation. She uses the example of how the NHS's ethnicity categories are out of date and need updating.
Thank you. Anything else online, Sedona? No, okay. Anything from the audience? Ooh, silence. We don't want, anyone to feel as though they can step wrong in this session and be embarrassed about word usage. We really want to know what you think.
Is that on now? Thanks very much for convening this panel and for being here on this panel. I think this is really nice to see at a TB event. I think this in itself marks a big change from some of the previous TB symposia I've attended. I wanted to just talk about, we were asked, what does decolonization mean to you? And clearly on this word cloud, we've got equality, equity, and justice, which all mean really different things. And I think there's a large body of decolonial thought that we as academics don't often engage with very strongly that really only aligns with the justice conception that's up there. So my question to the panel is, how do we prevent a surface level understanding of decolonization entering our work, saying it's done, and moving on?
Thank you so much, Dan. Anyone want to react to that? Toyin. Yeah, or from the audience. But I think Toyin's reaching for his mic.
Yeah. Again, to answer the question by the gentleman, the answer is, before you say it's done, before you declare, it comes to who is setting the agenda. Who's defining what is decolonization? In what context is it actually defined? Because all that needs to be taken into consideration. Often we have an agenda being set, as Tim mentioned, by people who actually do not have the lived experience of what it means to work in the setting of where the power imbalance really impacts your work. That's why in my opening statement, I mentioned appropriately that, I worked for more than, as a clinician across West Africa for more than 20 years before I, moved to North America and UK for as part of my research. My experience right now and my privileges is different from that of colleagues who are based in South Africa, Zambia, Ghana. And if we are talking about decolonization, I should not be the one setting the agenda, even though I'm African diaspora. So I should not say, yeah, I should not be the one saying it's done. We need a sort of like a global collaborative agenda setting where the people who live and work under such conditions are part of setting the agenda and determining whether we've made progress or not. Thank you.
Dhyan and Refilou, I think both of you mentioned agenda setting. We have been talking about agenda setting, I think, for years. That we are bringing it up again in 2026 seems, yeah, ludicrous. Clearly there's a problem. What is stuck? Why have things not shifted? Do you want to give maybe some thoughts on why that is?
Again, I don't want to be like the only person talking.
Refilou, this goes to you as well.
Yeah, the reason is simple. The power is still overwhelmingly resting with those who probably control the resources. And it's inconvenient, to sort of like change that power dynamic, because that will require people giving up privileges. That is why we've not really made much progress. We need to confront what is inconvenient, and people usually don't want to change that.
Tim mentioned a slow shift in power. Tim, you've been around, you've seen things. What's so difficult to shift? What is exactly? Can we unpick that one? Is it the money?
I think it's easy to say it's the money. It's most likely not really so, well, it is the money, but it's about the decisions as to how that money is distributed and who makes those decisions. So if those decisions are made by panels of people based in the high-income countries, focused on around the research agendas of their institutions, then that's where the power lies. We see it change. We do see it changing. So not so much of my money comes from the EU, from the EDCTP, which is specifically tasked with trying to change that agenda. But even so, because it's EU-funded money, it's driven by the priorities of the EU. And I have less money from the States, but I see the same sort of pattern in the States without going down the recent history. But can I just say something else on the agenda?
Please.
And one of the things which worries me is that we choose and I get caught in the idea where we think that high-income countries are good at fundamental science. We've got resource, we've got facilities, we've got lots of high-quality institutions, and that low and middle-income countries are very good at science, but what they really need is translational science. And so, and particularly in this sort of forum where we're talking about TB and people who've got the lived experience of living in worlds with high instance of TB, there's a danger that we accidentally ignore the fact that the academic lives of these places they're producing academics who are not only talking about translational science, but are talking about other aspects of the academic environment, and we need to be aware that creates a financial balance, that creates a funding issue, but we need to be aware that we shouldn't be setting that. Every country needs a full cultural balance of science, the arts, and what else is there? Science, the arts, and something else. But everything that needs to be covered, and we can't just say, okay, well, we'll do the fancy, clever stuff in high-income countries because we can afford it, and low and middle-income countries don't get to do that because they can't afford it. They've got to deal with living with this challenge.
You're doing a really nice segue to talking about roles. But Tiago, did you want to comment? Seems like you wanted to comment on maybe on what Tim is saying.
I need to introduce myself.
Yes, so, please. That would be great.
I'm Tiago Silva. I'm a Brazilian, and work here in London School of Hygiene and Tropical Medicine. So I have the same privilege of moving to a high-income country. And one of the things I think this agenda is not to change is like the incentives is the same all over the way. So it's still got funding people with the same type of structure. Like it's this incentive for research is the same if it was 50 years ago and now. So how are you gonna change people think, oh, I can try to help to do capacity strengthening in the low and middle income country, but they are not like have any privilege or any benefit of doing that in the academia. They're not gonna change the way they are exploring the low and middle income countries because they have no benefits for them. So it's like you need to change how is the incentive to the research in the high income country in the institutions to try to change how it's gonna go over all the way. It's like these incentives between funders, promotion, and other things is still the same way as like 50 years ago, 40 years ago. It's not changing.
I want to bring Trin on this as well. So before we leave the conversation around agenda setting, and people have been talking about we would need to inject some equity in how we are setting the agenda. Do you have maybe some thoughts on that? Yeah.
Yeah, thanks, Lele. First of all, thanks so much for the invitation to this panel discussion, which is obviously a very important topic. This also has a personal angle for me, just because although I grew up, spent a lot of my time in the UK, I was born in, at the time, a low-income country that had been colonized as well. And coming to the UK made me very aware of the opportunities and, sort of inspired me to contribute to public health. But saying that, I slightly have mixed feelings about, and this is probably where, going back to what you were saying, Helen, about being controversial. I have mixed feelings about using decolonization term in this context, and I suppose I understand, the differences in resources and the high-income settings, institutions having what I see as a head start in developing their research capacity, and I think it's about thinking how we can now focus on the lower middle income setting and how the research capacity in those countries can be developed. And there's lots of different barriers to that. It's not just the role of high income settings. And going back to what Liam said earlier in his introduction, that more than ever, we need to work in partnerships. So I think it's important that whether it's unintentional or not, that we don't present a perspective of them versus us. There were disparity before, but going forward, we need to do it together, and we need to work, effectively together and think of how we can utilize the expertise that's available across all settings. And I think, most of all, it needs to be founded on trust and mutual respect. And I think a lot of the challenges is where there is a lack of trust or there is a lack of respect and acknowledgement of the different contributions that different groups bring. Having talked to various colleagues at the MRCCTU where I work, who obviously have a lot of experience in working with overseas partners, one thing that I think is really potentially for us to consider is that when we are approaching research projects, we plan it and we cost it and we do it in a certain way. But when we're looking at longer term sustainable development of research capacity, perhaps that needs a different approach. and also I don't think it's a one-size-fits-all. We need to have different models that work for different settings and engage different stakeholders and think about, the outcomes of research capacity as important as the outcome of a research project. And those outcomes need to last and beyond the lifetime of the individual projects. And I think that's how that would help us to think of how do we build up systems within different countries.
So before we move on to the next session, can I just probe a little? What is so uncomfortable with calling it decolonizing? Where is the discomfort?
So I suppose for me, and perhaps I'm odd one out here, but I think it might create a sense of a them and us unintentionally. And perhaps going from, for example, experience that I'm not going into many details, but we were, for example, involved in discussion of a project last year that was around TB. And for the first time, I noticed there was sensitivity between low and middle income setting and high income setting. And there was very much a sense of people wanting to protect ownership of their work, which can happen the other way around. So I think there has been disparity. I think it's important not to swing to the other way and create, kind of borders around our institutions, whether we do it intentionally or not, and to make sure that we bring in expertise and work collaboratively together and be transparent about where there are gaps in expertise, be transparent about that so that we can, effectively not just deliver the project, but effectively develop research capacity.
You brought in capacity strengthening, and in there as well, I hear you talk about delivering excellent research versus whatever the outcomes are that we want to see to do with capacity strengthening. But almost seem like you're suggesting that there would be different, or the approach of achieving excellence versus capacity development should be different.
Yeah, not so much achieving excellence is different, but I think the way we plan research projects and the way we cost for research projects might not necessarily always align with if we're looking in a longer term to develop research capacity.
We'll leave it there for a bit. Let's see, Mentimeter. What we wanted the audience to do, and us, is to unpick the roles a little bit. Like, what are we talking about when we are talking about specific roles that perhaps, high-inc institutions should have a declining role in? So for this question, we asked, where do you think the following roles are most commonly held during TB research studies? And we have about 2, 4, 6, 7 questions. And it seems like majority of people say these roles are currently held in high-income countries. So roles such as the originator of the research question, the institution that is holding the grants, the leader of the analysis, and possibly the first author on outputs and the last author on outputs, ownership of the arising samples, data, and platforms, largely also is in high-inc, delivering capacity strengthening. That seems to be a task that falls with high-inc. So it's a lot of roles currently that are held in high-income countries. And with the next question, what we wanted to then see is whether there should be any of these roles that high-income countries do less of, perhaps, going forward. Where should these roles most commonly be held? And here we're getting quite interesting responses. For the same roles, people suggest somewhat in the middle, both. Yeah, delivering capacity strengthening is still with high-inc. So that's interesting. To those who have most money, resources, etc., it seems like people are expecting a lot from high-inc as far as delivering capacity strengthening. here I just want to bring in the panel. What do you think? What do you think of these roles? Should they be in the middle? Should the responsibility be, with both low Inc. and high Inc. Institutions in the way that it's been written here? Would that be then equity or equality achieved? Is that what we're trying to go for, Toyin?
Yeah. Okay. The devil's in the details. I'm willing to sort of like flesh it out. Should high-income country institutions have a declining role in TB research? That's the overarching question. And if you ask me that, I will say no. High-income country institutions should not have a declining role in TB research. Why? I mean, I'm the co-director of the TB Center at the London School. A few days ago, I was contacted by the BBC London, via our press office. They were interested in finding out to interview somebody about the rising incidence of tuberculosis in a particular borough in London, which I will not name for obvious reasons. Don't want people packing out. But that is the thing. Tuberculosis is a disease of inequality, as brilliantly showed in one of the slides by Jess Potter. Even in a high-income country like United Kingdom, we can see that those in the lower rung of the ladder are the ones who are probably bearing the burden. So high-income country institutions and researchers should not have a declining role in TB research. But when we talk about within the global collaborative partnership of TB research, should high-income country institutions and researchers have a declining role in leadership of TB research in TB endemic countries, in low and middle income countries? Hell yeah. It's about partnership. But where we are now, I mean, I'm fortunate to work in that sort of setting. I'm part of a consortium of more than 30 institutions across Africa and Europe, funded by EDCTP. And I know that with regard to capacity strengthening, with regard to the capability of researchers in African countries, in terms of like research methodologies, epidemiology, statistics, and even advanced methods like genomics and bioinformatics, where we are now is not where we were 10, 15 years ago. People are able to conceptualize research questions, lead research, because these are all about leadership. So, but we also understand that high-income countries have the capacity, have the funding and the knowledge. So in that partnership, it's important for there to be a shifting of the role in terms of leadership of research to researchers and research institutions in TB endemic countries, low and middle-income countries, to take ownership. All these functions that we have here, they all fall under one single terminology, and that is leadership. It's the leader. Whoever is leading the research will determine all these components. So that leadership needs to shift to the low and middle income countries. But it's also important, also as I said, I'm an African diaspora researcher originally from Nigeria. It's important also for institutions in low and middle income countries and researchers to also, and the governments of some of the TB endemic countries, to also take ownership and responsibility. There's a need to build capacity, not just for those methodological aspects, but also of grant management. How to manage resources with proper trail for audit. Those are issues that might hinder the shifting of the research leadership to those areas. But countries like Nigeria, India, South Africa need to increase their contributions to TB research in terms of financial contribution and stop buying bombs and jets and so on. So it's really important that it's two ways. But within the collaborative partnership, there should be a shift of leadership to researchers and institutions in low and middle income countries. And the funders have a very important role to play in that. I'm glad that we have Refilo with on the panel. Sorry, I'm not setting you up.
So I'm going to come in here because when you were saying declining Toyin, I really thought my epidemiologist brain came on. And I was like, but what's the denominator there? So are we saying that the denominator essentially stays the same in some way in terms of this pool of research? And so by declining role, we mean high-income country institutions take a smaller percentage? Or are we saying we need to increase this pool of TB research and therefore... yeah, essentially that pool is increased and therefore there's a rebalancing effort that way. So I'm going to go to Refilo, put you on the spot and say, what's your take on that as a funder of research?
I think as one is listening to the different people responding to this topic, maybe even taken forward beyond decolonization, is how as funders, when we work with countries, we engage the people affected. Because the fact that a topic for research might be generated from a specific country, the people who generated that topic might not understand the root causes of some of the things we're talking about. So if for any research moving forward when we talk of TB, I think what one would ask, whether it's on delivery or taking some of the innovations, engage with the people affected to understand what questions do they have and what we want answered. I think also coming from a high burden country on a personal basis, when talking to a patients at times who have TB, you ask, what is your biggest problem? At times they'll say it's food. They're not interested on these beautiful drugs that you've told them they will cure them in 6 months. It says, I'm here because I do not have food. So how can we also, as we move forward, high income, whatever terminologies we use, let's make sure we make a difference to the current situation that we have with TB. Yeah. Sidona?
We've got a few comments online. So first, just picking up on the capacity strengthening question. A comment from Katie Hill saying, I'm just going to read it out. I'm currently in the final stages of a Wellcome Trust PhD through St. Andrews University, but based in Uganda. One aspect of a lack of decolonization that I've been struck with during my time in Uganda has been the imbalance of PhD opportunities between UK and Uganda-based colleagues. There are lots of opportunities for funded PhD programs for UK applicants with good research budgets and salaries, which allow focused academic time. And now the majority of my UK colleagues who wanted to do a PhD have been successful in getting into a PhD program. Yet there are lots of colleagues from my Ugandan partner institute who are eagerly searching for but struggling to find PhD opportunities. And those that do get into PhD programs typically have to do this alongside full-time clinical work due to restricted funding. She said, I'd be interested to hear the panel's thoughts on what we can do as UK academics, PhD students, funders, et cetera, to decolonize academic training opportunities in global health research. And just to editorialize, I think this really speaks to, we say that we have a lot of capacity and so we need to deliver capacity building, but then the reason we have a lot of capacity is we give ourselves capacity by allowing ourselves by funding PhD programs, whereas that opportunity isn't really available.
Tim, did you maybe want to come in just on that before?
Yeah,
before we carry on? Yeah.
What was that term you used? You term of positionality. So I've got another element of positionality. So within the Faculty of Medical Sciences, I'm one of the graduate tutors, so I'm responsible for PhD students, as well as mainly taught course students, but PhD students. The issue of PhDs is really quite interesting. So fee levels for overseas students coming certainly to UCL and also to the School of Hygiene, is so high that it makes an imbalance in availability of PhD studentships within our institutions for people outside the UK as a whole. That now includes Europe, I hasten to point out, which is a big problem. But it actually, there's something else which has come arisen as an aside to that, or not as an aside, but is the importance of people doing their PhDs in institutions in their home countries or in their regions. So if you constantly train people to do their PhD level in London or in New York or Paris or wherever it is, then you create a situation where people don't perceive the PhDs that are being done in their own countries as being equal to equal in standing. And you create, I'm trying to avoid using the phrase brain drain, but you create an environment where a good or high quality academic education is seen as being outside your home country. And so I think a good side effect of our high fees is that people are having to do their PhDs in their home institutions, and that leads to strengthening of those home institutions as academic institutions. I'm not sure that's the way we should go about doing it, but it is an aside. And I think there is something about, and in many of the collaborative awards that I'm involved in, they often include, particularly the EDC-TB ones, often include PhD studentships, but they just don't come to Europe. And I think that's not just because of the fees, I think it's because of the investment in the academic structures within those countries. And possibly not just within the country, but within the region, so people move often between countries. And I think that's really important because that builds the academic environment in that community.
Tim, I can see one hand over there in response maybe to Tim. Yeah, I'll build on what Professor Tim was saying. So we started with decolonizing global health per se. If you just like, there was a research done by one of the students at University of Milan recently that showed that 90% of the global health institutes are basically in the north. So even if a person wants to pursue a PhD in global health, or someone like me, I'm doing a PhD in University of Geneva, I would have loved to do it in my own country. However, there is no institute really offering a PhD in global health on that matter. And if I want to go for my topic, which is AI and advanced diagnostics, like I won't be able to find a supervisor there as well. And then going on the funding stream and going there, still, there was a lot of improvement that happened. We were seeing grants coming out, really seeing, leads from Global South will be appreciated, so on and so forth. However, if you see the recent post, the ODA cuts and everything, the narrative is basically changing without naming countries, but we are seeing stuff. So and so first, you need to put our technology out there. So and so first, you need to put our technology out there. So actually, we are reversing like a local. Initially, we were focusing on developing products that are cost-effective within those countries. Now, the narrative from major donors is changing, and you actually, the chances of your proposal getting through is higher if you are putting the institutes from those countries, etc. So, yes, we were somewhat towards decolonizing global health. We made some progress. However, it's going the other way around now, I'm afraid. I think I know what you mean by things going back to the dark old ages, because I must say some of the latest, I guess, grants or announcements seemingly suggest that the IP and the samples, etc., need to go back to the institution that is holding the grant or managing the grant. So there's always been this kind of tension in terms of where the value is added the most. Tiago, I know you're quite passionate about this sort of point of, how do we move away from the value only being added in high ink? What are some of maybe your experiences from where you've been working in Latin America, and maybe suggestions on how we move?
Like one example very clear is like what happened with COVID-19. It's not TB, but it's very similar infectious disease. And a lot of research has been done in low and middle income countries. And if you go and see the publications, the outputs, first auto, high income country, last auto, high income country. And that's perpetuated this cycle once you get funding, because they're gonna judge the procedures, the number of publications. And for low and middle countries, authors are in the middle, they have less chance of getting the funding, and they're gonna rely to partnership, quote unquote partnership sometimes, with high income authors, and keep going. And there is no reason for have a first auto and last auto for high income countries if the research has been done in low and middle income countries using because most of the time we already have people with expertise enough in those countries to do the research. You don't need to import people from high income countries to do this type of things. So in this question showed high income country institutions have declined. I agree with Toyin is more change the role, not instead like leading things, but like providing technical support to provide the support so the research has been going like good quality and everything else, but the ownership of the research question, because I think the main aim of the research is to improve people's quality of life and save life. Those who better understand what is the problem is those who live there. It's not like someone from Europe researching things in Brazil or any other women. So if the main aim is to improve people's life, the people with most capacity to do this is like people who live there and understand what happens. Because even in each country have like difference between region in the country, and someone who is not from there not gonna understand this difference. Like Brazil is the same thing. You have like south-north inequalities. Like people from south go to the north to like exploit the north. So even internally have this conflict. If think people from outside the country gonna understand this change in power inequalities, for me is very unreasonable. So I have very strong feelings about ownership of rising samples data platform should be from the country who has originated the research. Not any way could be outside that. Like, and
it doesn't sound controversial, but
yeah, but yeah, that I'm very strong.
Yes, that this sort of practice or expectation is still going on.
Yeah, I'm going to be very quick, and I just want to go back to the comment and the question about capacity strengthening, PhD training, and so on. The approach to address that is by being intentional, and there are examples of good practices in that area about, sort of like equity in PhD opportunities between researchers in the UK, where we are, and maybe in Africa. And the approach is essentially to be intentional and to integrate this within sort of like collaborative capacity strengthening initiatives. A very good example of, I think, what's a successful model is the one that's probably led by one of my colleagues at the London School, Professor Rashida Ferrand, and that's a CREATE Fellowship Program. This is funded by a Wellcome Trust, but within that program, it's a UK PhD program, but the leaders of the fellowship program insisted that for us to have PhD students, from the UK go to multiple institutions in Africa, we must have a paired PhD by Africans who will be paired to each of these UK PhD. So that created, the funding was for 25 PhD UK fellows, but that created opportunity for 25 Africans to have PhD training. So we need to, it was not intentional, quite a lot of battle, but they persisted and they achieved that. That is one method. Another approach is to integrate it, as I mentioned, within capacity strengthening initiatives. Like we have a program that is specifically tailored to training female West African scientists at MSc and PhD level. Because apart from, the West Africa is a region that particularly suffers from huge gender gap in clinical research capacity. So you have to be intentional in doing that. And that is where researchers, African diaspora researchers like ourselves, are probably in a unique place to work with colleagues and, not even African diaspora, any researcher, for us to know that it is actually the moral thing to do to sort of like build capacity where we are working, and we need to be intentional in doing that. Thank you.
Can I just add very briefly, we've touched on capacity strengthening a lot for essentially kind of academics, all in that research space. It is so hard to get funding for anyone to capacity strengthen their professional services staff. It's very, very rare that you're allowed to budget that in, and I think it's a massive issue because they're just as important as everyone else.
Before we move on to the next session, which is going to explore a bit more about allyship, and Helen, you'll explain what all that is. I want to talk about something maybe that's a little bit also uncomfortable, especially for people who, coming from low-income countries, we move to UK, and then we move back to low-income countries to go do research, and sometimes almost seemingly perpetuating some of the, practices that we've been complaining about. Helicopter research. So, helicopter research done by someone from middle-income country is still helicopter research. What are your thoughts?
He's going to give me your thoughts. Leopold's reaction. Or Leopold's reaction. Yes. Tony's like,
Thank you very much. Really, thanks to the panelists for a very nice discussion and really putting across your idea on somehow controversial topic. I had a question really based on this. I mean, you talk a lot about, creating opportunity for PhD students, masters, and so on. I don't think that is lacking a lot of opportunity in that space, but to really drive research that bring change and impact is the next level. How is this effort creating conducive environment for even those that are going through those PhD to then stay in the continent and continue to lead research? I mean, research is done when you are closer to the site. I mean, you talk about helicopter research, I don't want to repeat that. There is a knowledge that is based on the observation of what you're seeing rather than reading or just supervising. And again, I'm not pointing at anyone, a lot of us, doing research in the continent, at some stage of our career, then we end up here, and that's where the problem is. Maybe because, the initiative to actually empower the lower income country do not really think about it holistically. Some of the initiatives that were funding research at level of, post-PhD, helping research leader to transition to independence, really stop abruptly, but maybe also engaging the local government to participate in creating those conducive environments so that people that are really, that are leading the research will have conducive environment to continue to stay there and train people on site. I think that is really will be transformative, and the Wellcome Trust and EDCP call now are really, driving the research lead to be from the continent. Those are really good, but I think more of that needs to be encouraged, but especially engaging the local government, because I think all of these initiatives I've done, I'm putting them aside. Thank you.
Much. We're not going to have any more follow-up questions on that one or comments on that one. I think we can move on to the next session. On allyship? Yeah.
So just moving us on to this topic of allyship, being a good ally, being in solidarity with people from other institutions. I just wanted to start by saying something really uncomfortable, which I think is that there's a lot of fear around decolonization for people based in high-income institutions, partly because our promotions criteria haven't shifted, and so we're still rewarding first authorship, last authorship, CI on grants, and it can be seen that if we then give up power, then we're not going to get our promotions, we're not going to get our tenures. But also, we've talked in the panel about sort of equity and equality, and I would argue that we probably have to move through a period of equity almost to reach equality, and that can be seen as relinquishing power for the high-income institutions if there's only a set pool of resource going around. So, any reflections on kind of those points in terms of what does allyship look like for each one of us? What can we actually do? Because everyone in this room is an active person in the TB research infrastructure globally, and this is what I mean about examining our souls. What can we do to be good allies? And also, just how can we distinguish between solidarity and allyship versus self-preservation at the institution level? So just ticking that box to look like you're ticking it versus actually meaning it. Let's pick someone from the audience first. Any reflections on that? Jess, I hoped you were going to talk at some point. Oh no, is there somebody else? Wow.
Okay. I think
oh yeah, great. Hazel.
Some of this conversation, I think I'd be really surprised if there are many people in this room who do helicopter research, But I think the elephant here is we need more money. We need a lot more money. I mean, if the southern institutions had the funds that historically the northern institutions have had and could invest in training, I do think we would make more progress. And I mean, Tim is talking about how more of the southern labs should be doing their own research. Absolutely. But I mean, I come from an institution which complains about how much it costs to run our labs, you know, and you have to have modern equipment and maintain it, etc. So, I mean, I think what we need is a lot more money, and some of what I've heard in this discussion, it suggests that training means getting a PhD. It doesn't. I mean, to become an independent researcher who is going to be competitive at the highest level internationally, I mean, you're going to need another 5 or 10 years. So I think we need not only more PhD training programs, we need programs that will allow people to do them in a sandwich way with their home institutions. And we need a lot more funding for people after they've done that training so that they can continue to be mentored and supported and helped, not in a colonial way, but just helping people for the next 10, 20, 30 years. And some of the most successful southern researchers that I've seen have had that sort of support through their careers. So I think we just do need an awful lot more money. And of course, the problem is we're in a terrible situation for it at the moment. Because, I mean, both what's happened in the US and even the UK cutting its overseas aid budget, and some of that budget is funding research. So, you know, I think it's very difficult, but I think we've got to have solidarity. And I think, you know, the feeling that sort of almost we are the bad ones, we're not. You know, we won't help sort TB if all the people with their experience in this room go home. So we've got to sort of find a way to keep people on board, keep them engaged, employed, and to do it together somehow.
Thank you, Hazel. And I'm just going to get Refalo's reaction on this point about, you know, you can train all the PhDs in the world, but if they drop out of the system, say, mid-career, then that's not very helpful. So what's the perspective from Gates in terms of shoring up people mid-career and making sure that they're still around to do good research?
So maybe the starting point, the focus again on the foundation is on innovation. I'm sure you all know that the time is limited, and we're hoping within this next coming 20 years, we'll be talking about a drop in mortality to a level that we've never seen before. And again, I think what is exciting is that what we would have talked about, let's say 5 years ago, today things are different. So anyone in the room should not go back thinking it's doom and glooming. We are hoping in the next, 3-4 years we'll have a new vaccine. I think we've heard from the previous presenter. Soon we'll be having a new near point of care test at a much lower cost. And all of that is through research. And again, as we talk of research, not related to PhDs or not, it will be ideal to have a treatment regimen that would not take so long. So as we move forward, we need to make sure that any research that we contribute to makes a difference in eliminating TB. Thank you.
Thank you. Do you want one thing?
Yeah, just one more before I give it back to you. Just thinking about, you know, sometimes we come up with, say, money. I'm just reflecting on Hazel's point about money being the thing that we need right now. Certainly, we'll end this conversation right now. But by simply just saying money will solve everything, we ignoring quite a whole host of things, that they're cultural, systemic sort of, you know, issues that we do need to deal with. That it's not just money that's going to solve all this tomorrow. So I think, you know, it is good that we think about those steps, deliberate steps, to get us to shift things away from the status quo. But for now, I feel we can't just say, oh, money will solve it, or TB is going to end tomorrow, because that, for me, is like nirvana sort of argument. It's you know, we need those kind of tangible steps of how we change and shift away from the status quo.
So I have to tell you about lunch, which I think is far more boring than this conversation, and I'd rather we just sat here and had another conversation for an extra hour, to be honest. So perhaps I can just say to each of you, I would love it if, as you left this room, you kind of did examine your soul and you thought, what does it mean to me to be a really good ally in this space? What does it mean to me to exhibit solidarity? And the question we didn't get to, which I would love to have got to, is what does success look like in 5 to 10 years for you and for the people around you? So I'd love for you to have a chat about that as you go over to lunch. And okay, so there are 2 lunch stations downstairs and then 1 upstairs plus 1 coffee station. The special diets are supposed to go to the cloakroom desk on the ground floor, but just to say all the food is veggie and halal. So enjoy your lunch and thank you very much for your time and attention this morning.
All right, thank you everyone. Welcome back from lunch. If you will, please find your seats. We are going to go ahead and begin this next session right on time. This is our next session. It is Early Career Researcher Turbo Talks. My name is Katherine Horton. I'm an epidemiologist and modeler at LSHTM, and I'll be one of the co-chairs for this session.
And I'm Frank Klopbrugge. I work at UCL. I'm a pharmacologist and will be co-leading the session, or co-chairing, sorry.
Fantastic. So, you know, one of the real privileges we have at our institutions is to work with and have the opportunity to support a lot of early career researchers. And so this next session will highlight some of the many doctoral students, research assistants, and research fellows across LSHTM, UCL, and affiliated overseas sites. The talks that you'll hear today, there are 10 of them in this next session, and these were selected from 24 submissions across institutions. And I do want to thank all of those who submitted an abstract and expressed an interest in this session, even those who were not selected for presentation today. We really appreciate your interest and the time that you took to submit an abstract. The talks that we will hear today really highlight the diversity of research going on at our institutions with a whole host of topics and methods that range from bench science to mathematical modeling, case control studies to stakeholder engagement, and much more. Now, to fit 10 talks into an hour, our speakers have a real challenge, which is that they are meant to deliver their talks in 3 minutes. So these really are turbo talks. But we recognize that this is a particular challenge to be able to describe your research and share your findings concisely and clearly for a general audience. And so we will be awarding prizes to 3 of the speakers in this session. And I would just like to take a moment. We have a jury of judges who are helping us with this task. So if I could just introduce them. Priya Arun from the UCL TB PPI group is here with us. Thank you very much. Dimitrios Evangelopoulos from UCL. He's a lecturer in microbiology and is also part of our judges. And then Liz Corbett, who's a professor in clinical epidemiology at LSHTM. So thank you very much to the 3 of you. You have quite a task ahead of you with some really great speakers. They will be sort of evaluating and judging the talks as they happen, and then we will award prizes in the closing session of today's symposium. With that, I think we will get started. One note is just that unlike the other sessions today, we will be taking questions after each talk, and we will be trying to stick to time on this. So if you have a question, if you're joining us online, please do go ahead and enter it in the Q&A so you don't miss a chance. If you're in the room, we'll have some mic runners. Please put your hand up and we'll try to get a mic to you. I think that's it.
Okay. I would like to invite Chaelin from LSHTM to deliver her talk. Thank you.
Good afternoon, everyone. Today I will be presenting our research on the impact of fluoroquinolone resistance on the cost-effectiveness of empiric treatment for multi-drug resistance and rifampicin-resistant TB. MDR and RRTB has been a global health challenge with an estimated 400,000 new cases and 150,000 deaths globally in 2023 alone. To replace previous injectable-based regimen, WHO recommend using 6-month oral regimen PPAM to treat MDR and RRTB. WHO recommend using PPAM with moxifloxacin, which is a fluoroquinolone antibiotic for everyone, while switching to PPAL, dropping moxifloxacin if fluoroquinolone resistant is identified. However, fluoroquinolone-resistant drug-associated testing coverage is often limited, around 50%, and therefore, in actual practice, patients are treated with BPAM regardless of resistance status. This raises an important question. What if a great proportion of strains are already resistant to moxifloxacin? So we try to answer this question. Does fluoroquinolone resistance affect the cost-effectiveness of empiric use of BPAM? To answer these questions, we extended the previously developed Markov cohort model by Dr. Shahida Rafique to assess the cost-effectiveness of empirically treating MDR and RRTB patients using provider perspective over 20 years horizon. Our results show that in all 4 country settings, incremental cost-effectiveness ratio were well below countries' cost-effectiveness thresholds. Also, our cost-effectiveness acceptability curves show that even with a high fluoroquinolone-resistant prevalence, BPAM had a high chance of being cost-effective. In conclusion, BPAM is cost-effective replacement for BPAL in all 4 country settings, even at high level of fluoroquinolone resistance. This finding provides an important economic evidence supporting the current WHO guideline. But what if moxifloxacin is more expensive and less effective drugs? So our sensitivity analysis showed that it would have amplified the impact of fluoroquinolone resistance. Therefore, it is important for future studies to continue to assess the cost-effectiveness of empirical treatment across varying resistant patterns for different drugs. Thank you for listening.
Thank you, Chaelin, for this very interesting talk. Do we have any questions in the audience or online? No online? Okay. I have a question.
Sure.
I was curious, this is very interesting research. Is this going to make its way to inform policy in form of WHO or country guidelines? Can you
yes, so WHO currently recommend using BPAM as an empirical treatment that's based on the current WHO guideline, but this research actually supports current WHO guideline for empirical treatment.
Okay,
yes.
Thank you. A question there.
Thank you for the. My question is, as BPAM, you have tested in India and other countries as well. What would be the cost in India for per person? Have you checked that?
Oh yes.
For the regimen.
Thank you for the questions. I don't have a specific number of cost for BPAM with me, but you can also check the research, and also is available online, and I will talk to you after that. Thank you.
Okay, thank you for answering our questions and delivering the presentation. Claire at UCL is going to present to us her work.
Good afternoon. The host immune response is critical to controlling MTB infection, but can also contribute to pathology. However, the mechanisms underlying protection versus pathogenesis remain poorly defined, limiting progress towards effective TB vaccines and host-directed therapies. To address key knowledge gaps, my PhD investigated macrophage T-cell interactions at the heart of the immune response to TB. MTB is a facultative intracellular pathogen of macrophages, and T-cell responses are generally considered to be protective via the production of cytokines that augment macrophage restriction of MTB, and by killing infected macrophages believed to reduce MTB burden. However, today I present data that challenges this paradigm. I show that while T cells do indeed kill macrophages, the net effect is to increase, not decrease, net bacterial growth. To undertake this work, I used a lab-based experimental model in which fluorescently labelled macrophages were co-cultured with MTB-reactive lymphocytes generated by stimulating lymphocytes with PPD, a mix of TB proteins. Macrophage survival was measured by high-content microscopy and flow cytometry used to measure MTB growth. Consistent with previous studies, I found that TB-stimulated but not unstimulated lymphocytes killed infected macrophages. Unexpectedly, macrophage death was associated with increased TB growth over the 96 hours, alongside a relative shift of bacteria from the intracellular to the extracellular compartment. Together, these findings suggest that macrophage death does not kill TB, but instead releases viable bacteria that then preferentially grow free from macrophage restriction. Together, these findings challenge the assumption that T-cell responses are uniformly protective in MTB and can contribute instead to TB pathology. Defining the underlying mechanisms could further inform TB research in two main ways. Firstly, I went on to show that in TB-stimulated lymphocytes, CD4 cells upregulate expression of cytotoxic granules and are the main drivers of increased MTB growth. Previously, CD4 cells have been the focus of vaccine-induced immunity, and thus further defining protective versus pathogenic responses could inform future vaccine design. Secondly, I found that multiple cell death pathways were activated within macrophages downstream of lymphocytes. Chemical inhibition of these pathways did not rescue macrophage survival, but targeting specific effectors reduced MTB growth. This suggests that distinct cell death pathways have differential effects on TB growth versus restriction, and targeting these may suggest avenues for future host-directed therapy.
Thank you, Claire. Fascinating work. We already have a question here.
Really interesting work. I would like to know, I guess you do co-culture of the macrophage and the T-cell to look at the effect. Are the macrophage differentiated in a specific way? And depending on their differentiation, does the outcome remain the same?
So in this current work, we only differentiated macrophages in one way, specifically MCSF differentiated macrophages. Obviously, you are very right. We know from in vivo and in vitro studies that can infect it, and that's one of the future aims to go forward, is to look at this, whether this is generalizable to different macrophage cell types.
Okay, I will now push it.
Very much. You imply that having TB released, MTB released from macrophages is a bad thing. I can envisage reasons why it would actually be a good thing, and particularly, because one of the things we want to do is to avoid latent bacteria. So this is quite a complicated situation.
Yes, completely. I think that the thing with a lot of the T-cell responses and T-cell macrophage interaction as well is also thinking about at what point in the disease process this occurs. We know, however, that TB transmission requires TB to be extracellular. We know that necrosis at the centre of the granuloma is related to pathology. So I think it's plausible that this does drive pathology, but whether the exact balance between pathology and protection varies at where it occurs in the TB disease course is, I think, still up for debate.
Okay, thank you. Oh, do we have time for one more? Or? Okay.
Thank you. I think, talking about time, the issue there is that what happens when you go further along in time. I think the idea here is to kill off the macrophages that are already infected, but then the new macrophages will have been primed, and they will not allow growth of the bacteria inside. So with time, there will be TNF and interferon action on the macrophages that are coming in new to attack these new TB bacilli, and they'll be able to kill them off.
I think potentially, yes. I think that obviously it's a limitation of this model that there is no cellular recruitment in an in vitro model. I think, however, the fact that there is evidence that that macrophage death in itself can specifically drive TB growth, both in this work and other studies, would suggest that this could still be a pathogenic response.
Thank you. The next speaker is going to be Constantine from the University of Zimbabwe.
Thank you. Good afternoon. I'm going to present demographic and clinical characteristics of participants in a prospective multi-country African tuberculous meningitis diagnostic study, which was nested within the SURE randomized control trial, SURE+DP. Sorry, something wrong with my slides. I think they jumped forward a bit. Okay, sorry about that. Tuberculous meningitis remains one of the most difficult central nervous system infections to diagnose early, especially in children. The SURE trial was a phase 3 multi-center, partially blinded, factorial randomized controlled trial of TBM treatment in children, comparing long course versus short course TB treatment and aspirin versus placebo in India, Vietnam, and Africa. Nested within it was the SURE+DP study, which was recruiting children undergoing lumbar puncture for suspected CNS infections across 4 hospitals in Zimbabwe, Zambia, and Uganda. We classified cases using established TB meningitis definitions, which included clinical, radiological, and microbiological diagnosis. Controls were classified based on microbiological diagnosis or being alive at 4 weeks without TB treatment. In Zimbabwe, we also used the BioFire panel to enhance diagnostic yield. We recruited 75 TB meningitis cases. 36% had definite and 29% had probable TBM. And we recruited 117 controls. HIV prevalence was similar. On univariate analysis, TB meningitis cases showed significantly more prolonged symptoms, night sweats, poor feeding, and reduced consciousness. CSF findings also differed. TBM cases had higher cell counts, elevated protein, and lower glucose levels. A preliminary multivariable analysis using logistic regression examining the TBM symptoms showed night sweats, neck stiffness, and reduced consciousness were the 3 strongest predictors of TBM. And all remained statistically significant on multivariable adjustment. Of those 3, only neck stiffness was not part of the study case definition criteria. These results are statistically significant and clinically relevant, but overlap remains, highlighting the diagnostic challenge. Despite these clinical and CSF differences, reliably distinguishing TB meningitis from other CNS infections at presentation is still difficult. This is made even more difficult by the low rates of LP completion in these settings. This underscores the urgent need for novel diagnostics, especially in resource-limited settings. The SURE+DP study provides a valuable platform for testing and validating these new tools, which could transform TB meningitis diagnosis and outcomes in African children. Thank you.
Thank you, Constantine, for your beautiful presentation. Are there any questions online or in the audience for Constantine? No online? Okay. Constantine, I have a question for you. I think this is very interesting and beautiful research. Could you enlighten us a bit on how you're going to take this forward, or the research group you're working with?
Yes, so there's work currently underway to further analyze these samples that were collected in the SURE+DP study. And some of the work includes transcriptonic protein biosignatures and CSF metagenomics, which will hopefully tell us more about ways to diagnose TB meningitis in children. Thank you.
Thank you, fabulous. So with that, I would like to invite Dhyan to the stage.
Hi, I'm Dhyan, second-year PhD student from UCL, working with Frank Clover and Timothy McHugh. Today, I would like to talk about phenotypic heterogeneity as mechanism of persistence in MTB. So phenotypic heterogeneity, it might appear as maniform. Some of you may be familiar with these terminologies, but phenotypic heterogeneity that I'm going to talk here is, it refers to different phenotype of TB, in this case, within isoclonal or population of bacteria with similar genetic profile that several studies suggest that it's harder and it's longer to treat. And it's very familiar and it may be contribute to the longer treatment of TB. So I started by doing systematic review by screening over 15,000 articles and identified 4 major responsible factors. They are metabolic downshift, cell wall remodeling, lipid modulation, and regulatory. And then by using flow cytometry to study single cell activities of early antibiotic exposure, we used 3 dyes, calcium phyllate to study metabolic activity, cytoscreen to study membrane integrity, and lipid spot to study lipid storage. And then this is the result, the flow cytometry response to drug exposure. So we can see each cloud here, it represents different subpopulation of bacteria with different characteristic. The both of x-axis here are metabolic activity. On the left side, it's lipid spot or lipid body. And on the right-hand side, it's the membrane integrity. And then we can see the pattern. There are 2 major patterns, the difference between the non-cell wall versus the cell wall targeting drugs. The problem with the current available application, it's difficult to distinguish the subpopulation, which one is which. It's basically these 2 pictures on the left and right, they are the same population, but it's difficult to identify. That's why we develop an application to show it to 3D viewer. That's the example. For example, maybe we just see just 2 subpopulations like this on the right-hand side on bottom, but we move it, it becomes 3 subpopulation instead. And then the problem with this type of work, the single cell work, it's a big amount of data. So each dot here, it represents 1 cell, 1 row of data. So in total, I have 33 million of data. Just from this experiment, I have over like almost 100 million rows of data in total with the failed experiment. But with the picture, for example, I will have over 2,000 pictures. That's definitely 2,000 too much for my supervisor eyes. So yeah, that's why we develop machine learning, the unsupervised machine learning. And finally, a plot that makes my supervisor happier, because now we don't have to classify it 1 by 1. It develops so we can identify 4 different clusters that different the percentage between different drugs. And then for the future works, yeah, possibly the microscopy, cell sorting, so we know which one is which. Yeah, that's all. Thank you.
Thank you, Dhyan, for delivering this beautiful presentation. Of course, I'm biased, but there is already a question here.
Very nice work. I think cell wall in mycobacteria is very unique and complex. Yes. So I was wondering which drugs that you have used, targeting lipids or carbohydrates or peptidoglycan, and what was the rationale for you to choose those drugs?
So we use all bactericidal drugs. At this stage, I have 4 drugs, isoniazid, rifampicin, bedaquiline, and also ritomanib. Because the background is to study about the tolerance at first, that's why I use all bactericidal drugs. And these drugs, you probably see the comparison or the drugs between drugs that working on the cell wall like isoniazid and other type of drugs. So you're right, we can see the, the comparison between the cell wall versus non-cell wall targeting drugs. We are, at this point, I'm currently working with the microscopy so to confirm whether it's really just computationally cluster or it also biologically relevant. Yeah, thank you.
Okay, there is no further questions. Thank you, Dhyan. And I would like to invite Dan to the stage. Dan is at LSHTM and will present to us his work.
Hi all, I'm Dan. I'm a social epidemiologist at LSHTM, and I'm here to tell you that social protection for TB works. There's been a growing body of evidence showing this. A recent meta-analysis showed a small, consistent positive effect, and it's entered the WHO guidelines. But what do we do now? What questions do we answer now that we know social protection works? We need to ask some different questions. We need to ask how best to deliver it, and we need to ask for whom does it work? Often when we try to answer if a policy works, we try to mimic a randomized controlled trial using observational data. I'm going to focus on a particular example looking at the state cash transfer in Brazil, Bolsa Familia, and its impact on TB treatment success using linked admin data. If we mimic a randomized controlled trial in these linked data, we find that any receipt of Bolsa Familia compared to if nobody were to receive it, we get a risk difference of 5% for treatment success. So this implies that social protection works to improve treatment outcomes. But now what I do in my work is try to look at some different questions we might be able to get at by simulating different policies for Bolsa Familia. The key finding of this is that more money doesn't improve treatment success, but more coverage does. We find that in fact doubling the amount doesn't improve treatment success at all. But we do find that even if we did nothing but improve the targeting of the program, we'll see an increase in treatment success, an increase in coverage. But who do we have to cover? If we look at the effects of this cash transfer on TB treatment success by income, we find that the effect is strongest in those who are poorest. We also find this effect is strongest in white populations. And in fact, in black populations in Brazil, the cash transfer estimate crosses the null. There's a finding not on this slide that is even more striking. Amongst that poorest segment of the population, the poorest income quintile, we find that that entire effect is driven by white populations. The risk difference jumps to 10% in white populations, and the estimate for black populations is 0. So it's really important to ask, who does cash transfers work for? How can this help us to target our interventions most effectively? So what we see here is that we might need to use some different methods, ones that don't mimic trials, and that this has relevance for not only social interventions. We need to think about who is excluded from interventions, even when we move to thinking about the distribution of biomedical tools. The same structural positioning applies. We heard earlier today that money is not enough, and this echoes this finding. Social protection does work, but it doesn't work for everybody. So our question is now, how do we get it to work for those who it does work for? And how do we find those who are excluded and think about why they might be excluded, why this isn't working? We clearly have more work to do. Not just does it work, but how much, how delivered, and for whom. Thanks very much.
Thank you, Dan, for this lovely presentation. Do we have any questions online or in the audience? Maybe if there is any online, they should know. Okay, I think you were first, Mark. Oh, okay, sorry, someone. Okay.
Okay, should I start?
You were first, right? Yeah.
No.
Sorry.
Who's going to ask? Who's going to ask?
Where are you?
Right.
Yeah.
Okay, I'll ask. Thanks. Sorry. One thing, have we left out one completely usable approach? Rather than black and white, poor and rich, we use diabetics, people on kidney dialysis and so on. Those kind of groups who are defined to be high risk of LTBI, who are at defined risk of LTBI turning into full-blown disease, and who are defined to have a disease which will be much more severe pathology.
Yes, so we could look stratified by different comorbidities, for instance, but what I would assume would occur is that we'd find, which we haven't done, in fact, we could look at this, but assuming that diabetes and TB are both structurally produced in the same way, we would probably find similar structural positioning in this regard. So I think there's one thing to taking a social or structural lens and trying to look at people with TB in general, and there's another to try to understand how different conditions intersect. So here the aim is to try to understand structural positioning, not necessarily to understand just differences, not to understand the real and meaningful differences by different conditions that intersect with TB. So I don't have an answer to this question. I think in general we should be better thinking about how do we disaggregate our data, who is important to us, and there's definitely an alternate version of the study that does this with diabetes, with HIV, with mental health, etc., etc.
Thank you. There is one in the back.
I'm Paul Sommerfeld from TB Alerts, a civil society organization. I'm wondering, in terms of your concern about how is social support delivered and maintained, have you looked much at how is it supported? And notably, have you asked about, is there an involvement of some civil society, local organization? Because my expectation is that that difference between black and white cohort groups in Brazil would tend to disappear if there were effective civil society support for the black patients that you're dealing with.
Yes, so many good insights here on this. I think one of the things to remember is that this is an administrative data study, so a lot of these questions cannot be answered. We can't use administrative data to understand what other forms of support not from the state individuals are receiving. But generally, people with TB will know their communities. They will know how to look after each other in some sense. And I do think this kind of solidarity might be stronger in black Brazilians than white Brazilians, to generalize. And I think there probably is this kind of support giving and networks that people are building for themselves that are not captured in these administrative data. I do think civil society has a strong role to play. This is a state cash transfer system, and people may not see themselves reflected in what that state cash transfer does. There may be better forms of support for different communities that aren't simply the material given by the government. And I think this points to some of this. The idea that the amount finding didn't show anything suggests it's not just about material impacts of social protection or cash transfer, but about something about being included psychosocially or something like this. We know very little about these mechanisms. There's lots of exciting research to be done still. Thank you.
Thank you, Dan. Next, I would like to invite Ellen from UCL to present her work.
So, hi everyone, I'm Ellen, a research assistant from UCL Respiratory, and today I'll be providing an overview of the TB BioAtlas project, prioritising use cases for TB biomarker and test development. So, the rationale behind this project is that use cases for TB biomarkers and tests are currently really scattered across various guidelines and target product profiles with no real synthesis of sources. And these use cases span across TB infection to disease, all the way to treatment and post-TB care. And just to give an example of a use case, so in the TB infection category, you've got will TB infection progress to disease? And the problem is, because there's such a broad range of use cases for TB biomarkers and tests, it's currently really unclear which should be prioritised by developers. So to combat this, we had two aims. First, to identify and define viable use cases, and secondly, to prioritise them. So how we did this, so first of all, a scoping review was carried out of target product profiles and international guidelines, and this provided us with 13 use cases. 88 stakeholders then carried out a Delphi-style survey where they first rated their agreement with each use case, which told us what's viable, and then the importance of each use case, which gave us our priorities. So for aim 1 of identifying viable use cases, we asked stakeholders whether they agreed or disagreed with each use case, and anyone who disagreed or who was neutral was asked to explain why. So this figure here shows the percentage of people who put somewhat agree or strongly agree with each use case, and the red line indicates the 70% consensus threshold. So you can see here that 2 use cases didn't meet that threshold, and the first one was, is there evidence of exposure to the bacterium? And one stakeholder pointed out that this is what existing tests do, and they don't really help with decision making. The second use case that didn't meet consensus was, does asymptomatic TB require treatment? With someone pointing out that would you realistically not treat asymptomatic disease? So 11 out of 13 use cases did reach the 70% consensus, and this brought us on to our second aim of which of these should be prioritised. So stakeholders rated the importance of each use case, and this allowed us to form rankings, both by stakeholder group and then also overall. And the take-home message here was that the highest priority use cases were drug resistance detection, TB progression risk, current infection status, and evidence of disease. And this was pretty consistent across the stakeholder groups. So this was just one stage of the Delphi process. So after this, results were taken to an in-person stakeholder meeting where all of the borderline use cases and below threshold use cases were discussed in more detail. I'd just like to acknowledge the team. Thank you for listening.
Thank you, Ellen, for the lovely work and presenting that to us. Is there any questions online or in the audience? I don't see any, I think. No. So I think it's very interesting results. What's the next step, so to say?
Yeah, so the step after this was the stakeholder meeting, which has already happened. And in that meeting, I think all of the use cases were discussed in more detail, particularly these two and then others that were close to the threshold. And 2 were removed from the list. Exposure was renamed. And yeah, I think and then there was another stakeholder meeting later on after these had been refined for another discussion. So it's kind of an ongoing consensus threshold until, yeah, the final list is complete.
Great, thank you. The next presenter is online, if I'm correct, Fatou at LSHTM.
Good afternoon. Can you hear me?
Yes, we can.
Yeah.
1 second. Can she start? Yeah, okay. You're free.
My name is Fatou Faal, and thank you for the opportunity to present today. My project is looking at the differential responses of Mycobacterium tuberculosis complex lineages to tuberculosis treatment regimen. TB is caused by the genetically diverse Mycobacterium tuberculosis complex, while some lineages like the tuberculosis lineage 4 is globally distributed. Others like the Africanum lineages are restricted towards Africa. But importantly, multiple lineage co-circulate within the same region. Previous work from our lab have shown that patients infected with lineage 6 saw poor treatment responses to the standard regimen compared to those infected with lineage 4. Therefore, the aim of this work was to investigate how the West Africa circulating MTBC lineages respond to TB treatment regimen. To address this, we harness and transform representative of MTB lineages to enable real-time growth monitoring. We then apply a direct drug assay to assess the individual anti-tuberculosis drug and determine their inhibitory concentration using the CD4 platform. In this first graph here, I'm showing the bacteria growth in the presence of culture media only. Here, M. tuberculosis lineages grow faster than that of the Africanum lineages. And when exposed to different anti-tuberculosis drugs, differences in IC values were observed across lineages. President mine here saw little activity against bovis, and this is consistent with its non-K resistance. This inhibitory concentration then guided the concentration of drug use in the combination assay. In this graph here, I'm showing the response of the different MTB lineages in the presence of the standard regimen and the new SURE regimen. Under the standard regimen, Africanum lineages and bovis were less controlled compared to the tuberculosis lineage 2 and lineage 4. However, under the new SURE regimen, Africanum lineage 5 and lineage 6 gain improved control, especially for the lineage 6 at the latest days. Analysis of the area under the curve over this 20 days period reveals statistically significant difference between M. tuberculosis lineage 4, M. Africanum lineages, and that of bovis. In conclusion, MTB lineage diversity significantly influences TB treatment regimen efficacy, and this diversity should be considered in regimen design and optimization. Thank you for listening, and I would like to acknowledge the following people.
Thank you, Fatou.
Is there any questions for her online or in the audience? Yes, there's one in the audience. Yes.
Thank you. Sorry if I missed the point. When you select these lineages, do you make sure they have not been exposed to drugs beforehand?
Thank you for the correction. Yes, we use whole genome sequencing to identify these lineages, and they were all drug susceptible strains.
Okay.
Yeah.
Thank you. Yes. Okay. Then thank you, Fatou. We are moving to the next speaker.
Good afternoon, everyone. My name is Peter Velikovic, and I'm working with the CPT group here at UCL. And today I'll be discussing the PK/PD modeling and translation of HTT compounds. So, despite the array of antitubercular compounds that we currently have, TB remains a global health challenge. A little bit closer, yeah. A global health challenge with lengthy treatment times. And this is in part due to the resistance seen in TB. So we have resistance from MDR TB to first-line TB drugs, and XDR TB to even second-line antitubercular drugs. Now, a way to circumvent this is through a new class of compounds called host-directed compounds, or host-directed therapeutics, hereby referred to as HDT or HPI. And so these modulate or engage the immune system, and previous studies have confirmed that these compounds reduce lung inflammation, reduce treatment times, and improve drug penetration. So, what this project aims to do is firstly characterize which compounds have HDT properties, and secondly to use a PK/PD modeling and translation framework to assess which of these HDT showing compounds has clinical potential. So we received a bunch of in vitro data here, and the first thing we had to do, as I just said, is distinguish which drugs display HDT properties and which drugs display antibiotic properties. And we did it in this fashion. So drugs which display a higher extracellular bacterial clearance were deemed as antibiotics and therefore excluded from this modeling and translational analysis. Drugs which displayed a higher intracellular bacterial clearance were included here. And now, among these drugs, we assessed the EC80s, and we determined the drugs which have the lowest EC80, which were the ones which were the most potent. And this would be, in this case, for this batch of drugs, imatinib and doramapimod. So, integrating the in vitro data here, which is the drug effect, really, the drug efficacy, in combination with established human PK models to model systemic exposure, we were able to determine the dose required in humans to produce a concentration at steady state above the IC80, which was used here as the efficacy threshold. So, essentially, by using this framework, what we're doing is we're determining the dose of this new class of compounds which would be efficacious in humans for its HDT properties. So what dose would be required, for example, of doramapimod or imatinib to produce HDT properties? Thank you. And what we can see here is that this also kind of acts as an early triaging method because, for example, for imatinib, which is currently used as an anti-cancer drug, the required dose for it to produce HDT effects would be 10 times greater than the maximum dose which is currently approved in the clinic, which is 400 milligrams once daily. I think the required dose here for HDT effects was 14,000 milligrams once daily. So whereas you have drugs which look very promising in vitro, again, imatinib looked, well, like one of the most promising drugs from this batch, when we do this translation, we can see that it would not be viable in the clinic. So just quick summary, the project looked at first characterizing HDT drugs, and then secondly, this translational analysis, see would they be viable in the clinic. Thanks for listening to me, and I'd be happy to take any questions.
Thank you, Peter, for sharing your work with us. Do we have any questions? One here, please.
Thanks, excellent work. Did you consider drugs that have both ability, I mean, with both HT and antibiotics, because you have few. I mean, we have a pattern on imatinib having direct effect on the bacteria. So, I mean, some of the previous work had challenge to demonstrate this because of the sensitivity of the platform. My student just presented before you, because we're able to transform the strain, we can see them growing in real time. You increase the sensitivity. So maybe you want to also talk about how do you actually detect this effect? Is it using CFU, for example, or other method?
That's a really interesting question, actually, and a great point. So one of the next steps of this project is that's what we're really trying to focus on. How can we systematically model and discern, okay, there are some drugs, for example, like doramapimod here, where you can clearly see no extracellular effect, only intracellular effect. But then, as you said, for imatinib, for example, you can, at very high concentrations relative to the intracellular effect, you can also see extracellular bacterial clearance from this assay. So how do you determine drugs which have maybe, let's say, even closer, IC80s between extracellular and intracellular? And that's something that we're trying to model and determine. So we're working with ERA4 TB, which is this big consortium, and that's a big question. Okay, so for example, this drug, it's an antibiotic. Does it just penetrate cells well, or does it engage the immune system? And I think that that's something that relies more on classifying the mechanism of action there. So for example, with imatinib, we know that the mechanism of action from previous studies is that it engages, I think, or enhances phagolysosomal formation, and that clears bacteria intracellularly. So in this case, for these specific drugs, we knew the mechanism of action, hence why we call them HPI drugs. But you're right, absolutely. I mean, it gets very complicated when you get in. Yeah. Okay, any other questions?
Thank you, Peter. I think it's time for the next speaker.
Sorry.
Kathy, we're with our next speaker, the LSHTM.
Great. Okay. Hi, everyone. I'm Kathy Thomas. I'm a research assistant at the London School of Hygiene and Tropical Medicine. And today I'm presenting our research on preparing for a new TB vaccine in South Africa. And so just to provide some context of where TB vaccines are at and why we need a new one, we know that the TB burden is predominantly concentrated in adolescents and adults. But despite that, we currently only have the BCG vaccine, which is licensed among infants and young children. Also thinking specifically about the context of South Africa, BCG has a contraindication among people living with HIV, and we know that South Africa has a high HIV prevalence. But despite this, we know that there are several adolescent and adult vaccines that are in late-stage trials. Most promisingly is the M72 vaccine, which demonstrated a 50% efficacy in phase 2B trials. But despite this, we have very limited evidence to understand how these vaccine programs among adolescents and adults would be rolled out in practice, particularly considering that they are not the usual target population for vaccine programs. And so the aim of this research was to understand what the implementation priorities would be of a novel TB vaccine for adolescents and adults among key stakeholders in South Africa. So in terms of the methods for the research, we conducted interviews with 26 stakeholders. And as you can see on the right-hand side, they had a range of expertise and backgrounds. The interviews asked a range of questions on the country interest of a new TB vaccine, what the introduction timelines would likely be, who the target populations would be, and also questions around regulatory and financing. And then we conducted a deductive analysis, and this was based on the predefined themes that were in the interview guide. So just to give a very high-level overview of some of the findings, as you can see in the figure on the right-hand side, price and efficacy were the two most important factors for vaccine rollout. A broad population-based approach would be preferred, but if the resources were limited, then target populations would be prioritized. And in South Africa, these target populations for a new vaccine would likely be adolescents, people living with HIV, and healthcare workers. And so these findings provide insights to ensure that a TB vaccine implementation in South Africa would be both successful and equitable. And the QR code on the screen will take you to the paper that gives a lot more detail on these findings. Thank you.
Thank you, Kathy. Are there any questions for her online or in the audience here? Yes, two. Okay.
On the question of target populations, I'm a bit worried that why have a target population and not potential targets? Because you say adolescents, then there are children who are soon going to become adolescents as well. So why not take it back to that age group who will then become the new target in a few years' time?
Yeah, so I think what I can say on that is that we know if the TB were to be licensed, it's likely to be licensed for adolescents over the age of 15. And so that would be the target group that we would be aiming at, is age 15 to 17 years old. I'm not quite sure that answered your question. So I'm happy to clarify it after the presentation.
Because the question is, why not immunize young children who will then become adolescents anyway?
Well, so I think we know that young children are being vaccinated with BCG, as I mentioned, but that this immunity wanes as they get into adolescence. And so that's really why we would be targeting the adolescent age group.
Sorry, apparently I was muted. A question online, are there any contraindications of people who receive the childhood BCG vaccine then receiving this vaccine in adulthood?
That's a good question. I am not sure about that. I imagine that is something that is being looked at in these vaccine trials. As I say, there are many vaccine trials that are currently ongoing.
Thank you, Kathy. I think it's time to go to one more. Yeah, one more. It's going to be Shahida from UCL.
Hello, everyone. I am Shahida from UCL, Arnvik group at UCL. So mostly we target proteins in tuberculosis, but what if the real control point lies in RNA? So one mechanism that Mycobacterium tuberculosis survives in the host is through RNA-based sensing. Riboswitches are metabolite-binding regulatory RNA elements that sense the small metabolites such as vitamin B12, magnesium, and glycine. So upon binding, they undergo conformational changes that switch the gene expression on or off. I will discuss the glycine riboswitch in detail. In Mycobacterium tuberculosis, there are two GLY-A genes. GLY-A1 ensures basal glycine for metabolism, and GLY-A2 is only expressed in high glycine levels through glycine-responsive riboswitch. So during infection, because of the breakdown of extracellular matrix, a lot of glycine is released that is toxic. When there is low level of glycine, then the riboswitch keeps the GLY-A2 STA operon off, whereas at high glycine, the switch is in the on state, and it enables the bacteria to cope the glycine stress and detoxify the glycine. So first we ask the question, is glycine really a stress that bacteria needs to adapt to? So you can see growth at increasing concentration of glycine. So at high glycine, the growth becomes dependent on GLY-A2. So glycine is not just a metabolite, it's a stress that bacteria needs to adapt to. So to understand that how this adaptation happens, we performed RNA sequencing comparing high glycine to low glycine. So just in 2 hours, we see a massive response. Around 330 genes were differentially expressed. And we see many of these genes persist least in 4 hours that show that the shift is rapid and sustained. So at high glycine, we see that the high glycine levels push the bacterial, it drives the amino acid metabolism, stress adaptation, and efflux systems, and it suppresses the dormancy, virulence, and respiration. So how the glycine controls the riboswitch at molecular level? So you can see the inline probing of the glycine riboswitch. So in the presence of glycine, we see the site-specific changes in the cleavage pattern that reveals the structural rearrangement of the RNA. So findings suggest that riboswitches are potential novel class of drug targets that are distinct from protein-based targets, which are prone to mutations. If we can design a molecule that can lock the riboswitch in the off state, then we can block the glycine detoxification. We are now testing the frontline drugs in combination with the glycine to see if glycine can increase the drug susceptibility. Thank you.
Thank you, Shahida, for this very interesting work. Is there any questions? Yes, here, one please.
So what do you think is an advantage of targeting riboswitches as compared to any other traditional protein target that we know?
So normally the protein targets, they are prone to mutations and they get the resistance quickly. But if we have the protein-based target, then maybe they are less prone to resistance mechanisms. That could be one advantage in comparison to protein-based targets.
Thank you. There's no further questions.
Okay, thank you.
Thank you.
All right, thanks everyone. That was a really full session, but could we give a big round of applause to all of our speakers for their talks? And with that, we have a coffee break, so half an hour. There should be refreshments on the top layer and the lower level outside. Please do be back in half an hour at 3:30 for the next session. Thank you.
Welcome back. I think I always saw more than 100 people joined online, so welcome back everyone who joined us online. And I know from my Indian collaborators and Malaysian collaborators, it's 5.5 hours or 7.5 hours ahead of us. So, and well done on making tea, coffee, or maybe had your dinner. And those who had fantastic tea, coffee outside came back. We saw a huge amount of energy from the morning and really highlighted the diversity of the sessions. Now, I think with this, I'd like to introduce myself first, Sanjeev Bhakta. I'm representing Institute of Structural and Molecular Biology, a joint institute between UCL and Birkbeck University of London. And I have my amazing co-chair.
Thank you, Sanjeev. So I'm Maria Ruperez. I'm an assistant professor at LSHTM, physician, TB researcher with special interest in AI-supported tools for TB screening and diagnosis.
Great. So, I mean, it's just a silly question to start with, but maybe it will give an excuse to do a little bit of exercise. How many of you believe that AI is here to stay? Raise your hand. Brilliant. Set the scene. Very, very good. So actually this session, we have a lineup of expert speakers. They will be exploring how, I mean, they already have explored, but we will be exploring through their presentation that how AI, including traditional machine learning and large language model and et cetera, how actually that help accelerating the control of tuberculosis and how that take us to closer to the end TB situation. So with that, I think I'd like to welcome our first speaker, Professor Mark Lipman from UCL School of Pharmacy. Mark, the stage is yours.
Matt Todd.
Matt Todd, sorry. Oh, well, that gave you an excuse to laugh.
Yeah.
Sorry,
Yeah.
Professor Matt Todd from UCL School of Pharmacy.
No worries. Yeah. Do we look similar, Mark? I'm not sure. All right. do I control the slides? Okay, great. So this talk will be a mixture of protein science and machine learning. If you're not in those two fields, don't worry if you have a little 8-minute nap. I won't take it personally. It's also a plea to become involved in what is a large-scale global open science collaboration. So for many years, we've been working on open source drug discovery, which is where anyone can take part and all the data is shared and no patents are taken. And we've done this with TB also, mainly in collaboration with GSK Tres Cantos. And it's been really fun to do. And you, as with all these projects, you get a lot of inputs from the community because everything is open to the public. But a lot of the projects have necessarily been phenotypic drug discovery, which means you don't know what the molecules are doing. And you tend then to start to identify the same, molecules against the same targets over and over. And so the alternative to doing that is to take a more target-based approach where you decide that some protein targets, let's say, in TB are important, and we should then direct efforts to find molecules to hit those. So I'm a professor in the School of Pharmacy, but I also have another hat on, which is I manage the Structural Genomics Consortium for UCL. This is a biomedical research charity that was set up after the Human Genome Project finished in order to put structural biology information in the public domain so that industry didn't duplicate efforts. So with all of the information that was available, what do proteins look like, what kind of molecules bind them? And it was formed at the Wellcome Trust by GSK about 25 years ago. It's got sites around the world, and UCL is the new site. And it does open science research in chemistry and biology. All right, so what they do is to, apart from crystallizing proteins and figuring out structures, so a huge percentage of the crystal structures in the PDB are deposited by the SGC, the Structural Genomics Consortium. But of value to drug discovery is that in addition to that, they find molecules that bind those proteins and then optimize those molecules so that they work inside a cell and are selective for the target protein and are potent. So by virtue of those molecules, you can figure out what the protein is doing, which is ultimately the aim. So these are dose-dependent things, so they have advantages over things like CRISPR knockouts. And the priority is to try to get people to work on understudied or never studied proteins, so the stuff that no one's looking at. These molecules they're not optimized to be drugs, but they can be turned into medicines very easily, even though they're public domain medicines. So on the top here, 4 examples of many of these chemical probes against certain targets in the human proteome, which are public domain and unencumbered. And then underneath are the clinical candidates that have been taken into clinical trials by a company. And you don't have to be a chemist to see that the probe inspires the clinical candidate. So the openness and lack of IP of the probe is no better. In fact, it's an incentive for the company to invest money in converting the molecule into a drug candidate. Don't need IP to start drug discovery projects, despite what anyone tells you. The aim of the SGC is to find one of these probes for every protein in the human proteome by 2035. That's 20,000 proteins, roughly. So at the current rate, which is 200 probes in 10 years, that will take us a millennium, and that's too long. So we need to speed this up a lot. And current technologies will not do that for us. So what do? Well, in order to do this, you have to make as much of the process as possible computational, because that scales. And a great model here is the creation of AlphaFold, which won the Nobel Prize 2 years ago in chemistry, which is that you can build a great tool from machine learning based on high-quality public domain data. In this case, the data in the PDB. So decades of work by biologists to put data in the public domain in the PDB led to a machine learning model called AlphaFold, which is incredibly good at predicting protein structures. So what you need is the public data set, high-quality, curated public data set. We don't have that for small molecules binding proteins. It doesn't exist. There's the academic literature, but it's a mess. So what you need is a high-quality data set of thousands of proteins versus billions of molecules so that the machine learners can do their magic and develop predictive algorithms for molecules that should bind novel proteins. Everyone in drug discovery is calling for this data set, and no one's doing it. So we got this grant to kickstart this, and it started a few months ago, which is a public-private partnership to do just that. So you get or make proteins, you do some screening, which I'm not going to talk about in detail, but it's billions of molecules against these targets. You put the data in the public domain, annotated for machine learning, and then you have teams around the world try and figure out algorithms that will be predictive and which you can use to predict new molecules, and then you measure those, and you put the data back in the public domain. So cycle after cycle of this should help the worldwide community get really good at accelerating that first step of finding a small molecule to get a drug discovery project started. That's the idea. So these work. So one technology, for those of you who are fans of drug discovery, is DNA-encoded libraries where the molecules are attached to a piece of DNA, and you do this incredible experiment. You have a little bit of liquid, and there's billions of molecules in there, and you put your protein in, you fish it out, and you see what binds, and you can figure out what binds, because every molecule is attached to a piece of DNA. You just sequence the DNA, it tells you what the molecule is. And that allows you to do a billion compound screen in an afternoon in a regular lab. So as an example here, a screen was done like that, and billions of molecules were screened. The data are horrifically complicated because some bind a little, some bind a lot, and you get this sort of normal curve of enrichment. And you have to decode all that DNA, and then you have to have an algorithm that tells you what it was. But what you can do from that is be predictive about molecules that are commercially available that should bind the protein of interest. And here, billions of molecules were screened, but 48 were bought and tested in a one-by-one screen, and of those, 15% bound. So this is a world away from what we're used to in terms of high-throughput screening in pharma companies, where you had these enormous labs with millions of pounds worth of equipment screening millions of molecules. This is very different from that. It's a much faster way of getting binders of novel proteins, which are then validated by crystallography and everything else. In another, even simpler experiment, you have pots of 1,000 molecules at a time. All of them are commercially available. And you dunk in your protein, you fish it out, you wash it, you denature it, and you do a mass spec of what's there. And you see enrichment of binders over background. It's called affinity selection mass spectrometry. And it's very simple. We can do it with the mass spec in the basement of the pharmacy building. And this, again, is a very fast way of doing it. Lab scale, pretty fast way of doing it. And again, the hits that you get, they're simple. They're not particularly potent, but they're starting points. And many of them can be crystallized, and you get an understanding of why those molecules bind. So two methods that are fast and reproducible, which we will be running against 2,000 proteins to develop this data set. That's the idea. Just one very quick example is from our collaborators in North Carolina who were interested in avian flu and wanted to find an inhibitor eventually of this protein called PB2. So the screen was done on the left, and there's the molecule which was found to bind this protein and not the others that are shown on the x-axis of that graph there, which are other proteins which are not related. And it's confirmed as a binder by something called surface plasmon resonance. And then 8 more compounds were purchased. Another 50 were made by a graduate student. And then you're suddenly in the nanomolar inhibition range in a biochemical assay. And this led to the team getting a grant from the US Department of Agriculture to pursue this more. And this is about 6 months. It's pretty fast. So how to get involved in this? So this is where the appeal comes in. If you have a lab, and in the lab there are samples of proteins that you have recombinantly made, which are present in MTB. And if you would like to find small molecules that bind that protein so that you can kickstart a project to optimize that binder, we will screen that for free and give you the data back. So try and use your fridge to generate more grant income. If you are a machine learning expert and you want to get involved in these benchmarking challenges, just let me know, because there's going to be an absolute waterfall of data in the next 5 years of small molecule protein binding. So please do come and see me if you like. So my pitch then, which is the last slide, is that we would love to know what are the high priority targets for MTB drug discovery so that we can either make or secure those from the community, do the screens, find the binders, and kickstart drug discovery projects against novel targets. Thanks.
Thank you very much, Matthew. So our next speaker is Sacha Wright. She's a research fellow at UCL with research focus on the host and pathogen biomarkers of TB, and she's going to be talking to us about the BioAtlas project. Thank you, Sacha.
Thank you so much, and thank you for having me speak today. It's an honor to be amongst such brilliant researchers. I'll just wait until my slides come up. Oops. I'm not sure these are my slides. There we go. Okay, wonderful. So hi again, I'm Sacha. I'm the project coordinator and a research associate for the TB BioAtlas project, which is a landscaping review of tuberculosis biomarkers. I'm currently based at UCL Respiratory. And today I'm going to be talking about a large language model enabled systematic review of tuberculosis biomarkers, henceforth called an LLM. So just as a brief introduction to TB biomarkers, I'm sure a lot of you are familiar with biomarkers, so I won't dwell on it, but biomarkers are characteristics that can be measured as an indicator of a biological process, pathological process, or as a response to an exposure or intervention. And we know that biomarkers may have an important role to play in improving detection, predicting progression, and also for treatment monitoring and optimization. Just briefly, this is the landscape that we're foraying into with the TB BioAtlas project, bravely. As you can see, a lot of other people think that biomarkers for tuberculosis are interesting as well, with an exponential rise starting in the 2010s. And so the TB BioAtlas project's main aim is, as I said, a landscaping review of TB biomarkers. But what we're hoping to do is prioritize use cases and biomarkers across the different disease states, moving towards this aim of supporting the development of a more coordinated global pipeline. So really making sense of the massive landscape, as I just showed you on the last slide. So we have three overlapping objectives for this, but today I'm going to focus on the second one, which is all about evidence synthesis. So the overview of biomarkers and development, and how we used a large language model to enable the systematic review portion of it. So for the systematic review, we were very fortunate that we had a lot of brilliant people, some of whom worked in our team, who had done a lot of this evidence synthesis before, so we weren't starting from zero. You can see up here 3 systematic reviews pertaining to the 3 use cases that I described a couple slides back. And so what we did first is we did an umbrella review, or a review of reviews, so to speak. And through this, we were able to identify 40 existing systematic reviews that fell into our inclusion criteria. And then we went to the primary literature after that to really fill in the gaps from the primary research that weren't met by that umbrella review. And as you can see, we had a lot of publications that we were managing and some very complex inclusion-exclusion criteria. And so this, to us, was the perfect opportunity to look at evaluating an LLM to see if it could increase the speed and the pace, but also the quality of a systematic review. So that's what I'm going to be speaking about. So briefly, just on the systematic review itself, so the goal was to synthesize data to prioritize the most promising biomarker candidates for future research and development. And then kind of underneath that was identifying the biomarkers and biosignatures for the 3 use cases, but also really, as usual, evaluating the evidence regarding things like diagnostic performance, technical feasibility, and implementation potential as well. Alongside this, the goals of our LLM evaluation were to see if we could increase the speed and pace of the systematic synthesis of evidence. We're also keen to see if we could facilitate something like a living review for the TB BioAtlas project, because we can see how many new publications are coming out every year. And then hopefully as well, this can create a framework that could be extrapolated to other evidence synthesis projects, maybe you. And the things that the LLM and the humans both had to contend with in the complexity of this project were all of the inclusion-exclusion criteria, especially based on the existing systematic reviews we'd identified in the umbrella review. And then, as I described, the 3 different use cases, each of which had different eligibility criteria, multiple biomarkers per study design considerations as well as we applied our quality filters. So suffice to say, it was quite a complex review to start with. So how did we do this? I'm not going to dwell on this, mainly because I'm not the software engineer behind it. But what we did is we assessed the candidate pipelines using application programming interface access to just existing off-the-shelf LLMs like OpenAI GPT-5 and Google Gemini 3 for the screening and extraction tasks, and then compared them to human performance. So the way that this looks is, as you can see, this is the systematic review process that we know and love on the left. So we have our systematic search, our screening phases for title and abstract, and then full text, and then our data extraction. In the center is the conventional human role, so running the search and then having 2 human reviewers review independently for the title and abstract and for the screening phase, and then finally the human extraction. What we did a little bit differently this time is we used the human as the reference standard, sort of how you would in assessing a diagnostic test, to compare to the LLM review, which we did in parallel. And how we did this evaluation was we split all the papers into 4 parts, quarters, henceforth called Q1, Q2, and so forth. And we used Q1 as the evaluation and development phase with the hope to implement the LLM for Q2 to Q4. So I'll get into a little bit more detail about this, starting with title and abstract screening and full text screening, because we used a very similar process for the 2. So we started by developing the screening pipelines on GPT-5 and Gemini, creating the prompts and so forth based on the inclusion and exclusion criteria. Within Q1, we then piloted our pipelines with 10% of the papers, and this allowed us to optimize the prompts and tweak them to make sure that we were getting an output that made sense and aligned with our understanding. After that, in Q1, we had 2 independent human reviewers, as you normally would for a systematic review, and this allowed us to calculate human-to-human positive percentage agreement and negative percentage agreement, after which time we ran the LLM pipeline for Q1, and then we were able to calculate positive percentage agreement and negative percentage agreement for LLM human consensus versus human-to-human consensus. And then finally for Q2 to Q4, if LLM human consensus positive percentage agreement was non-inferior to the human-to-human agreement, then we were able to proceed with the LLM as the second reviewer and then have any of the discordances arbitrated by a second human reviewer again. Data extraction was a little bit trickier because we had a lot of fields to extract from these very complicated papers. So we started by developing the extraction pipelines to actually mirror the human extraction schema, so the data extraction forms that were used by the humans. After which time we did a similar approach, so piloting it with 10% of the papers, allowing us to optimize the prompts, making sure that we were getting the outputs that we wanted. And then for Q1, we had a single human reviewer and an LLM independently extract, and a second human reviewer adjudicated any of the discordances within the fields. And then the agreement proportions for the human and LLM extractions were calculated and compared to the final adjudicated reference standard. And then again, if seen to be non-inferior to humans, then for Q2 to Q4, the LLM could be deployed as the primary extraction approach, with all of the extracted fields validated by a human reviewer in the end. So, how'd it go? These are our results, our simplified results. So here you can see the LLM human consensus positive percentage agreement, which is similar to sensitivity, and LLM human negative percentage agreement, similar to specificity for the title and abstract and the full text screening, and then also the median number of LLM extraction fields that were in agreement per study for the data extraction phase. And the main takeaway from this is that it worked really quite well. So the LLM performed as well as, if not better in some cases, so quite favorably compared to the humans, and so we were able to implement the sort of human-in-the-loop LLM and human evidence synthesis process. So reflections and implications from this, just off the bat, LLMs can reduce time on repetitive work, especially in evidence synthesis. They help most when tasks are structured and constrained, and also when they're evaluated, so that we make sure that it's working. It does require prompt development and evaluation, so it's not just a matter of pressing go to enable that fine-tuning that we had to do along the way. For our work, we were very happy that it compared favorably to human performance, so we were able to have 2 entities, humans and LLM, work on our project, and it enormously accelerated our review of TB biomarkers as well, while maintaining the high quality. And then implications for future work, this could enable future updates to our review, which is really exciting. And then also, we hope that it could also help to the development of review-agnostic pipelines to accelerate evidence synthesis in general. So I'd like to say thank you to the project team, the funder, for their continued support.
Next speaker is Asad Zaidi. I think he will join us online. We have a recorded video.
Hi, everyone. My name is Asad Zaidi. I'm doing my PhD at the Institute for Global Health at UCL, and I'm also a visiting scholar at the National University of Medical Sciences here in Pakistan. Now, I really regret not being with all of you there in person, but since you've made the virtual flight all the way to Pakistan, I'll take you a little bit further to the village of Bika, which is a couple of hours away from Islamabad, to help contextualize my talk. Now, this is a really beautiful part of the country. It's located next to the Indus River. Most of the community here is involved in agriculture. And because it's off from some of the major highways, it's often been neglected by the government. So if you came here a few years ago, there would be several problems that the villagers were facing. First, there was intermittent power that was affecting irrigation for the crops. There weren't enough customers here for the main retail banks to open up branches. So people didn't have access to finance. And most of the profits in the agricultural supply chain were actually taken up by the middlemen, leaving very little for the farmers themselves. Fast forward to today, and most villages in Pakistan are being powered through solar energy. In fact, the country's had one of the largest uptakes of renewables anywhere in the world. There's been a massive increase in digital banking using mobile systems, as well as ride-hailing apps and deliveries through mobile services. So now farmers can send their produce directly to homes in the city. So instead of setting up infrastructure from what I've called the analog age, what technology has actually done is help bridge development cycles. So now communities can go from having none of these services to moving directly into the digital age with renewable electricity, digital banking, and organic farming. Now, the parallels with TB are actually quite similar. A few years ago, a patient with TB symptoms in Bika village would visit a basic health unit, which would resemble something like this. From there, a sputum sample would likely be sent to a district lab for microscopy. And eventually, they'll end up at a tertiary care hospital in cities where they'll have radiology and their specialist services. Now, technology and AI has changed this patient pathway and completely, and I'll talk a couple of ways in which this has been done. So the first is the use of digital X-rays read by AI software. Now, this is done through a technique called deep neural networks, and essentially this mimics how the brain actually processes learning and conducts process information and does learning. So essentially, these software have been trained like a radiologist, but the difference is that they've read millions of X-rays with a really strong focus on identifying TB lesions. And the way the software analyzes these images is really quite similar to the way radiologists look at the different aspects of the lung to come up with a conclusion in which a score is provided from 0 to 100, depending on the software, whether this patient has a risk for TB or not. We validated several of these software in Pakistan. We helped develop in-country guidelines, did lots of training for staff, and did community engagement work before rolling this out. And so what you can do is take a digital X-ray system, put it in a truck, have the software read X-rays, and then you can screen hundreds of people directly in the communities where they live, rather than for them having to visit any healthcare facilities. So it's really taking TB services directly into the community. We recently published a large retrospective analysis of this intervention from its first 5 years, in which we screened over 1.2 million people. But actually, since then, this has been really scaled up by the National TB Program, covering half of the districts, and really is now considered part of the routine programmatic activities of the TB program. Groups have actually taken this a lot further. So here you can see a portable X-ray, which can be put inside a backpack. It can go up a mountain, which is shown here. And it can help target a high-risk group such as coal miners. So you can see a typical coal mine here and miners working here. And you can directly do screening at the workplace and identify TB patients directly. We previously also identified that actually in rural communities, TB is not so stigmatized because it's actually quite common and it's curable. But in fact, the main problem women have is that they can't actually travel to a healthcare facility because they need permission or accompaniment by a male partner. So with these X-ray systems, you can go directly into the communities, help design interventions that are focused for women, such as adding MNCH services alongside TB screening services. Now, actually, these AI tools are the first example of an AI sort of product that's been approved by WHO, and there's actually several of these now that have been approved. And the Stop TB partnership has detailed guidance on this that's sort of shown here. So the second aspect I wanted to talk about was actually, like, now that we've done this screening, what we've identified is that in fact there's a large regional variation in the yields of TB that we're identifying. as well as a big variation within cities or within districts. So there's certain hotspots. So the distribution of TB wasn't actually quite uniform, and we wanted to find ways of optimizing this. So the approach that we, or the TB program has used is the use of this software called Match-AI. This has been developed by EPCON and KIT. And essentially what the software does is it divides the whole country into 10,000 population polygons, and it comes up with a risk of TB based on a whole bunch of contextual data. And then it applies modeling techniques. And essentially what it does is within each district, it ranks the highest predicted 10,000 population polygons for the risk of TB. So essentially you have a very granular understanding of where the TB cases might be present. So we evaluated the software through a large step-wedge cluster randomized trial in which we enrolled 30 mobile X-ray field units. And this trial was pragmatic. It was conducted within the routine activities of the TB program. We did this in 68 districts of the country, screening over 300,000 people and testing a large number of people on expert. And essentially the intervention in this trial was use of this software. So field teams in the intervention areas would primarily conduct their screening activities using sites identified by the software. And we would share the GPS locations of the highest risk polygons, and they would be instructed to do the screening activities at those sites. In the control areas, staff still use a form of targeting, but this was based on their previous experience and use of historical data, a process sort of shown over here. And these are the headline results. We identified that the use of the software in the per-protocol analysis resulted in a 32% increase in the yields of bacteriologically confirmed TB. There was also some benefit in the ITT analysis, but it was non-significant. But what was interesting was in the subgroup analysis, the software was actually really beneficial in rural districts, similar to the one that I showed earlier. And this suggests that the software is able to identify using AI previous hotspots that might not have been known to the field teams and based on their historical experience. So this software has now been adopted by the National TB Program as part of the routine activities, and it will also feature in an upcoming case study in the upcoming operational guidelines for screening by WHO, which should be out in the next few months or so. So hopefully what I've done is convince you that with AI, we can actually skip this analog age sort of infrastructure, which was providing potentially poorer quality of care. And with AI, we can move communities directly into the digital age in which we can provide them the services that they need, provide high quality care to the communities that directly need them. Now, this rollout of technology, as with any others, is not without certain problems, especially if it's done rapidly. So what we've seen is that with the scale up of these services, with AI-based screening, there's been a large increase in the number of individuals that are treated with bacteriologically unconfirmed TB, essentially on the basis of the X-ray or what the AI is saying. There's also potentially higher loss to follow-up among those who've identified from screening. And then, of course, vulnerable communities may still be missed, and the AI might not be picking up those individuals that need those services. Now, Hollywood essentially has molded our perceptions about AI, and essentially what we've learned is that AI is out there to kill all humans. But part two also teaches us that if programmed correctly, AI can also help save a lot of human lives. So with that thought, I just want to thank Mark and Neil for inviting me to speak here. I really want to thank my supervisors and a shout out to all the collaborators in Pakistan that were involved in these studies. Thank you, and wishing you all Eid Mubarak.
Good day, everyone. My name is Victory Adam, and at this World TB Day Symposium, I will be presenting some of our work where we are harnessing artificial intelligence to support pediatric TB diagnosis. Recent technological advances, particularly in digital imaging, big data, and artificial intelligence, are rapidly transforming the landscape of digital health, thereby creating new tools to improve health outcomes. In today's world, AI-based computer-aided detection systems can analyze chest X-rays and generate automated TB likelihood scores, with higher scores indicating higher certainty of TB prediction. This has the benefit of improving coverage, circumventing the challenges of intra- and inter-reader variability, thereby standardizing chest X-ray interpretation. A number of CAD products for chest X-ray analysis have demonstrated acceptable performance in adults, but they are also marketed for pediatric age groups, even though the WHO has not yet recommended their use in individuals under 15 years of age. This is particularly due to the limited independent evaluation data of their performance in this age group. To address this limitation, we conducted an independent retrospective diagnostic evaluation of the commercially available CAD for TB version 7. Chest X-ray images of a well-characterized cohort of 724 children under 15 years with presumed TB, recruited across 3 childhood TB studies between 2012 and 2022, were analyzed and classified as CAD-TB positive or CAD-TB negative based on the manufacturer recommended threshold score of 60. Using the microbiological reference standard of GeneXpert positive or culture positive or both, CAD for TB version 7 distinguished MRS positive from MRS negative children with area under rock of 0.7. It had a high specificity of 99%, but the sensitivity was suboptimal at 19%. We also performed the subgroup analysis of CAD for TB version 7 by age group and participant source, and we observed that the specificity of CAD for TB version 7 was comparable across the subgroups, but the sensitivity was higher in children aged 5 to 14 years compared to children less than 5 years, as well as in children who were referred compared to children who were actively traced. Since the microbiological reference standard is an imperfect reference standard for pediatric TB due to the paucibacillary nature of TB in children, we estimated the accuracy of CAD for TB version 7 using the Bayesian latent class analysis, and we observed that though the specificity was comparable to expert and culture, the sensitivity was just about 50%. Based on these findings, we recommended optimization of current CAD systems by further training with pediatric chest X-rays. This study was published in 2024 in the European Respiratory Journal. Recently, we carried out an independent retrospective diagnostic evaluation of the QXR CAD algorithm, which was further trained with chest X-rays of children. We used a library of 932 digital chest X-rays of children with presumed pulmonary tuberculosis who were recruited across 4 studies between 2012 and 2024. The children were classified as QXR TB positive or QXR TB negative based on the manufacturer recommended threshold score of 0.5. Once again, using the microbiological reference standard, we observed that QXR distinguished MRS positive from MRS negative children with an area under rock of 0.68. It also had a high specificity of 89% and a modest sensitivity of 41%. We went on to perform the subgroup analysis stratifying the study participants by age and source. We observed that the specificity of QXR was comparable across all the subgroups, but the sensitivity was higher in children aged 5 to 14 years compared to children less than 5 years, and higher in children who were referred compared to children who were actively traced. Once again, we conducted the Bayesian latent class analysis, but in this instance, we also added a human reader TB classification, which was strictly based on checked X-ray reports alone. We observed that QXR performance was better than the human reader, and it also had sensitivity that was comparable to GeneXpert, but the specificity was consistently lower than GeneXpert and culture. In summary, based on all our findings from the different studies, we could conclude that AI-based CAD tools have the potential to support detection of TB in children under 15 years of age, and current CAD models need to be further trained with pediatric imaging datasets in order to close the current performance gap that are observed in pediatric population. Now, this would be dependent on the development of comprehensive, well-curated pediatric chest X-ray libraries, which remain an urgent priority. Progress in this endeavor would require strong collaboration between academic researchers, clinicians, radiologists, AI developers, and TB survivors, with the ultimate goal of improving TB diagnosis in children. The work that I presented today was done within the multi-level childhood TB research group at the MRC Gambia at London School of Hygiene and Tropical Medicine, and our research explores artificial intelligence-based predictive modeling using structured machine learning approaches across the childhood TB care pathway, from diagnosis to treatment and post-treatment. The group comprised of PhD students and postdoctoral fellows who take advantage of the established multi-country research platform and industry collaborations. To conclude, I would like to acknowledge Prof. Thoyin Togun, the lead of the Childhood TB Research Group, our collaborators, colleagues at the MRC Unit, the Gambia, partners, and our funders. Thank you for your attention, and I look forward to taking your questions at the Q&A session.
Right, okay, so I think we would like to invite the speakers of this session to take chairs while we give them one more round of applause. Excellent speakers. Matt and Sacha. I think two will be joining online. And we have time to take questions from the audience and also from online.
Yes, I will be monitoring the chat.
Brilliant.
So are there any questions in the audience?
Mark.
I wish I were Matt Todd. So Matt, this is Mark Lippman here. Question for you. I mean, it's amazing what you do. How do you control the fact that someone's going to look at this and go, I can make money out of this? How do you do that when you produce a wonder drug?
Yeah, so that's, I mean, if that leads to a drug faster, then it's a win. That's the philosophy, right? So we're at university, we should be enabling everything. We, compared to a pharma company, we cannot possibly compete in terms of making a medicine. But we can do the risky stuff that they don't want to do. So a member of the SGC board is at Pfizer. And if he knows that a human protein is important for something like cancer, and he goes to his super boss and says, we need to do a project on this, he won't get internal funding for that. If he goes to them and say, we now have a way of making the protein, and by the way, we found a molecule that binds it repeatedly, and it's something we can optimize, and it appears to work in a cell, then he can get it. But up until that point, he can't. So we are essentially, showing the way towards something, but we opt out when we can't compete anymore. And I mean, that's basically what's going on here. The interesting thing about infectious disease, though, of course, is that the economics are different. So suddenly, it's not that clear that companies will be better placed to do this than some other structure, which would involve a different approach. And so I guess the idea behind the open source approach is that that's the different approach. It's the exact thing that industry can't do. And that's where maybe that kicks in. Antibiotics maybe is the same, right, in the sense that companies can't make money. So maybe there we should try something different, and that's a slightly different argument.
I actually have a follow-up question to you, Matt. You mentioned about, as a target, you're looking for proteins that has not been worked on already. But we know in infectious diseases area that it takes quite a lot of time to really establish or validate a target, like to know their structure, function, regulation, etc. So what is an advantage of looking into the protein that was not been characterized at all?
Yeah, I mean, it's trying to, Well, if we want to understand the cell or an organism, we have to understand all of the proteins. And the problem is that if there's some cool target, protein X, people tend to gravitate towards that because it's easy to get grant money on protein X because everyone thinks it's cool, right? If you pick the protein that no one's worked on, then someone's going to get your grant proposal and say, what the heck is this protein? Who cares? So there's a community incentive to work on, everyone to work on the same things. We're trying to use the funding to kickstart things on the underexplored proteins. I mean, really the things where you don't have well, we do have structures from AlphaFold now, but where you really don't know what the protein's doing. You may know it's important because you've knocked it out and something dies, but you don't know what the protein's really doing. And the aim is to try and kickstart that because we need to know that information too. Yeah, so underexplored is better. And there are, I mean, I should mention, there are community experiments in trying to come up with these lists of targets. So there's one done for malaria. The great and the good of malaria drug discovery got together and came up with the list of targets that are the most promising we should do now, some that are really good. And there's a list of 29, this is in the paper that came out last year, 29 targets, which everyone knows is important for malaria, and no one's touching, right? And you think, well, why don't we make them then? And try and find binders and kickstart that because it's obviously important. So and these things are happening. There's one in Parkinson's, the same exercise happening in Parkinson's. It'd be so great if the great and the good of TB research could get together and be locked in a room for a couple of days and then be forced to come up with a bunch of targets because we could then do them.
Thank you. Is there any question?
Yes, there's two questions online. I think they're both for Victory. So one is, how accurate are the AI-based CAD tools in detecting TB in children compared to doctors?
Can you hear me, right?
Yes.
Thank you. Thank you for that question. That's an excellent question. So in terms of the AI tool, we have to be cognizant of the fact that the AI tool simply uses chest x-rays, and the AI tool is not privy to information on the symptoms and other presentations of the patients, of the children rather. So in that instance, if we are comparing an AI tool that is just looking at chest x-ray.
Sorry about this. Continue, please.
But I think it would be an unfair comparison to look at an AI tool that is just looking at chest x-rays alone compared to a doctor that sees, has the whole spectrum, basically chest x-ray, GeneSPAT results, culture results, as well as clinical presentation. So I think in that instance, the AI tool would just strictly perform as good as a chest x-ray can perform.
Thank you. There's another question for you. In the Bayesian latent class analysis of CAD4TB, which tests did you include in the latent class models, and did you consider conditional dependence between them?
Absolutely, thank you. So we use two assumptions, basically. We considered independence of all the tests that were used. So in the first study that was presented, we basically looked at CAD4TB and GeneSPAT and culture results. Well, because at that time we did not have expert radiologist reports of the x-rays. But in the second study that was presented, we had expert radiologist reports of the chest x-rays. So we were able to model the performance of the second CAD algorithm using the CAD algorithm human reader interpretation of chest x-ray, GeneSPAT, and culture. And in both instances, we considered conditional independence as well as conditional dependence of all the tests. In the first instance, we considered conditional dependence of expert and culture because we used the same sputum sample for both tests. But in the second instance, where we had the human reader that would interpret chest x-rays, we considered conditional dependence between the CAD algorithm and the human reader, which both use chest x-rays. And then we considered conditional dependence of experts and culture.
Maria, can we take two questions from
Yes, please go ahead.
So one from here.
Thank you. This question's for Sacha. Thank you very much for that wonderful summary of the systematic review work you did, because I think we all love doing systematic reviews, don't we? So I think everybody was very interested in it. I wonder whether you have gone further or you just didn't say it in terms of just physically how much, if you include the time it took you, I mean, we're realistic in like getting the prompts right, validating it. What was the comparison in researcher time between the two arms? And then also, you know, how much did it cost you? Did you were able to do this on your 20 quid a month into ChatGPT, or did you have to go for an advanced plan? And then my third question is, what about reproducibility? I think this is, I mean, one of the nicest things here is it potentially makes living reviews a real prospect rather than being something we just stick at the end of we could do it again. But if you ran it again in a year's time, do you think in historic literature it will give you the same papers, or because the underlying model is actually changing, you're going to get a different answer?
Yeah, all really great questions, and I'm going to try to make sure that I cover all three of them. So in terms of time, I would say the majority of the time actually went into the development of the pipeline, so working between the systematic review team to make sure that our summary protocol was as accurate and clear as it could be. That required some back and forth and some prompting, some speaking to the LLM, so to speak. But the majority of it actually happened on the software engineering team's side. So they took a few days to make sure that those pipelines were optimized. But I mean, it's not instantaneous, but once the pipeline was optimized, once we had evaluated it and it met our specs, we essentially just had to let it run. And it saved an enormous amount of time compared to the time that it would have taken for the researchers to do so. The other thing is that an LLM doesn't get tired. And I'm sure all of us know screening papers is exhausting, and sometimes it can feel like the more that you do it, the less good you get at it because your brain will get tired. And so that was certainly one of the distinct advantages for our team, was that it alleviated some of that screening pressure as well. So it was definitely favorable, I will say. In terms of how much it cost, obviously there's a cost associated with paying the developer team as well. So I can't necessarily speak to that side of it, but we are using off-the-shelf LLMs. So this is not us building our own LLM. This is us accessing OpenAI GPT-5 and Gemini 3 and doing that, as I said, kind of through the backdoor route. I think the most expensive task will always be the data extraction because it will take more time and it will be more complicated. And if I'm remembering correctly, it was less than £1 per article for that, and much less than that when you came back into the full text screening and the title and abstract screening phase. So it would essentially, it's not terribly cost prohibitive, not shockingly so. But obviously that energy needs to go into making sure that you're building the pipeline in the way that it needs to be and evaluating it along the way. Otherwise, you're going to end up with AI slop, unfortunately. And that brings me well to reproducibility. So in terms of reproducibility, you have an interesting question about whether this would turn out different results a year down the line. And I think this was something that was of particular interest to us when we compared the two pipelines to one another, so OpenAI GPT-5 and Gemini 3, and they didn't perform exactly the same. They performed slightly different, and I think that was quite interesting for us to see because it led to the possibility that those little idiosyncrasies could mean that LLMs could be compared to one another in the future and not just be spitting out the same result. So I think that, you know, the models will learn and they will change, but all of the information was coming from within the papers and the prompts themselves. And so the only thing that you would want to make sure is that the LLM had a way of updating its inclusion and exclusion criteria. So as I said, because we did the umbrella review and because we know that there's tests that are well researched and endorsed by the WHO, a lot of the tests that had been previously appraised were in our exclusion criteria. And as those tests get updated, that will also need to be excluded in what the LLM is synthesizing by way of evidence. So you just need to make sure that you have that mechanism.
Great,
so
we'll take one question from there. Thank you very much. Really engaging session. My question is to Matt Todd. Shown like that, I guess some of the molecules that you identify will not be TB specific. They can also be potent for other bacteria or viruses, right? So the question is, how do you really confirm TB-specific potency for those drugs? I mean, I was thinking, have you thought about building a pipeline that also includes, testing in vitro efficacy and even further accounting for things like strain diversity that are often missed out? Thank you.
Yeah, sure. So initially you want selectivity within the organism so that you can figure out what the target's doing. And then there's a whole bunch of other stuff that you'd want to do as part of drug development if you wanted to make sure you're only hitting TB, for sure. That would be way downstream. Initially, it's just within one organism. I mean, one of the molecules we're working on for malaria at the moment is also potent against M. avium, according to results we got from UKHSA. And so, which is nice. It's a starting point for both, but eventually the molecule you want, way down the line, you'd want it to be specific, yeah. So eventually, when you've got something which is looking good, you would involve the phenotypic assay against the whole bug, and you've got to check for activity against more than one thing, yeah.
We do have one question. I have another question, but maybe just after.
Thank you. I've got a question for Professor Todd and Dr. Edom. Firstly, for Professor Todd, a comment and a question, please. Presumably in the futuristic model, we could combine this with to see if the molecule will bind any of the human proteins to predict toxicity. But I am very excited about the approach, so don't get me wrong in the question I'm asking, but I'm being a bit of a devil's advocate. Have you looked at, in retrospect, the drugs we are using for tuberculosis now? Would you have discovered them by your method? And I'm referring to isoniazid and trizinamide, which need to be activated by the bacterial enzymes. That's the question.
Yeah, likely not. Yeah, so I'm the biggest cheerleader for phenotypic drug discovery, believe me. It's a wonderful thing. And almost all of the molecules that we pursue as part of a parallel project called Open Source Malaria have come from that. And that's companies doing phenotypic screens, putting that in the public domain. And there you start with this glorious certainty that the molecule works. And then you've got to sort of figure out what it's doing. So in those cases, you discover those wonderful things. In this case, we're taking the other approach, which is to try and figure out what these targets are doing that we know are important, and they're essential proteins for the organism. And that's a different approach. But you're going to need both of those approaches, no question.
Thank you. Can I ask for Dr. Edom?
Sure, go ahead.
Yeah. Thank you. Dr. Edom, the question for you, the SCAD does not give very good sensitivity. And my question is, have you asked the question why?
So, Victory, have you heard the question properly about the sensitivity
Yes.
of that? Yeah.
Thank you.
Thank you.
Yes, please. Yes, please. I got the question. So there are a few suggestions that are already out there, which basically are around the nature of presentation, radiological presentation of TB in children, which is quite different from the radiological presentation of TB in adults. And yeah, there is also that, these catch systems have been shown to perform well in adults and are already recommended for use in adults. So you could say, or we could actually infer that most of the X-rays that were used for the training of these algorithms were mostly adults X-rays. So which is why we are advocating for use of chest X-rays of children for additional training, or basically building a card that is specific for pediatric population alone. So we could actually guess that the reason why this performance is variable, not as good as what is in adult, is because of the nature of the training set, and that is affecting the sensitivity of the CAD systems.
So,
I think, is there a question for
no,
Asad? I have a quick question for Asad, actually.
Okay, sorry, go ahead.
Asad, I think you are working on the ground and using AI for public health research. I mean, share your experience on how you access the public kind of personal data and how do you protect that? Because still my understanding is in South Asia and other countries where tuberculosis and other diseases are really stigmatized, so people don't come out and share there.
Well, I guess like our experience has been people have generally been quite appreciative of the service to begin with. So in a lot of these places, obviously, we're not targeting sort of the high-end people that go to private sector hospitals and so on. So these are people that don't have services or they're very poor quality services. And in most cases, if there's a fancy X-ray truck coming in and they're getting free treatment, they're getting a radiology film and they're getting tested, I think generally people quite appreciate it. I think the main challenge that we've had is what if someone doesn't have TB? And how do you redirect them to the healthcare system and develop pathways for that? So I think generally people are quite appreciative. Regarding the data, to be honest, so there's two aspects. One is the radiological image, and that in some cases does go to the software developers, depending on the agreements that they have within the country. In most cases, it actually just stays inside the X-ray box. Most of the other data is actually still paper-based, and there's a lot of effort been made in this trial to actually digitize it. We found it a little bit challenging to scale it up, but hopefully with the rollout of 5G in the country, that would be a little bit better. But to be honest, yeah, at the moment, the data is all paper-based. Mostly it's aggregate data that's reported. So I think patients are quite comfortable in sharing that.
Thank you, Asad.
Thank you. I think we are 4:30
close.
now.
Okay, great. So I think with that, we are bringing the close to this session. Thank you, my co-chair, Maria, and all the speakers. Give them another round of applause, please.
Thank you.
So 4:30, the only remaining role for us, the chairs for this session, is to hand over the microphone to Mark Lippmann.
Just while we're waiting to hook up, well done everyone for staying the course. I know it feels like 5 minutes, but it's been a few hours that you've all been here, so congratulations. Rishi's going to do the fun stuff. He's going to do some, I was going to be humorous, but it wasn't going to work. I was going to make some gag about it. Those of you who know what we're going to do now, each year for probably the last, 8-10 years, we've done a connection where we've joined UCSF and maintained the idea that World TB Day isn't just for us, it's for everybody. And sometimes what we can do in this setting is we can think about the issues in the UK, we can think about the issues globally, but often that connects with the research and the work and the experiences that we have, and it's always so important to actually link into other places. The UCSF School of Hygiene, UCL link started when Patrick Phillips decided that the weather were rather better in San Francisco than in London. I'm not sure he's right, but what it meant was that an amazing researcher from here went over there, and ever since we've kept that connection going. I'd like to think they've stolen some of our ideas, like the Turbo Talks. I'm not sure which way round they went. They also have an early career researcher event, and some of the research that they've been highlighting, you probably haven't seen the agenda. I know what they've been covering. It's very similar to the sort of things that we're doing here. So looking at the TB landscape, covering early career research. Funnily enough, they haven't really spoken about funding in the US and the impact of USAID cuts. That's perhaps not that surprising.
Hi, Mark.
Yes.
Can you hear me?
Yes. Can you hear us?
Yes. Can you see us or just hear us?
Definitely can see you both.
Oh, good.
Can you see us?
I can see you at the podium. Thanks
Lovely.
It's lovely to see you. And we heard your very nice things that you said about San Francisco. Our weather is nicer. Our science is stronger. No, I'm kidding. We're partners. I do have one announcement to make, which will be important for everyone, is that the possible strike has been called off, the tube strike. So we have extended our comments to an hour. I hope that's okay.
Well, I'm delighted to see you here because I genuinely thought I was going to have to be talking for about an hour, and I was running low on commentary. Yeah. So welcome UCSF, welcome Patrick and Payam. It's such a treat to see you online, and we've had a great day. As you know, our TB seminar this year was called TB in a Changing World. And we've reflected that both in terms of changing healthcare systems, changing paradigms of tuberculosis, tend to focus on pulmonary disease. We've talked a lot about extrapulmonary disease. We've had some amazing insights from people affected both by pulmonary and extrapulmonary disease. And of course, what's been brilliant is hearing from the early career researchers who were forced into giving 3-minute turbo talks, which was spectacularly good, because I don't believe I could have done it at that. Well, I'm not sure I can now, and I certainly couldn't at that stage. And looking at your program, it's fantastic. If you want to, I did a very sketchy outline, but please do tell us what the day holds for you.
With pleasure. So our World TB Day Symposium is being hosted at San Francisco General Hospital, which is our county hospital, our safety net hospital, which is where the TB clinic and the TB control program of San Francisco County is located. So it's wonderful because it's co-sponsored this year by the Center for Tuberculosis in conjunction with the San Francisco Department of Public Health, which brings the clinic employees and providers and nurses into the conference, as well as TB survivors. This year's title is Sustaining Momentum, Strengthening Community Partnerships in TB Research and Care. And we had a wonderful keynote delivered by Paula Fujiwara, who's a former scientific director at the Union, really trying to tie together the notion of leading by science, but powering our action through communities, and the power of that. And she wove in the One Health sort of, all of society approach to combating the disease, which I really found compelling. We did talk about funding, by the way, Mark. We haven't put our heads in the sand. We are struggling through very disruptive period with disinvestment in the areas that we all collectively work in and believe in. But I think it's been interesting to see the audience in the room, the resilience that's being shown, and the general sense of optimism that we can double down despite all the forces against us. But it was an excellent keynote. And then we have 5 sessions that I'll let Patrick tell you about.
Yeah, no, thank you, Mark. So we're beginning our day here. It's only 9:30 here. I know you're ending yours. Your reception is coming up. We have a couple of sessions coming up, so we have a break right now. The first session we have is entitled From Ideation to Implementation, Developing Research with Community Partners. And I can see that we have researchers and community advisory members from 4 different countries in sub-Saharan Africa, as part of a panel discussing collaborative partnerships and research. After that, we do have, as you've already told us, Mark, we have a session on early stage investigators, and we have actually representatives from all 6 of the NIH-funded tuberculosis research advancement centers across the US. So there are 6 sort of centers of TB research excellence funded by the US NIH, and we have early stage investigators from each one presenting across basic and clinical science. After lunch, we have 2 sessions led by our TB clinic here in the General and partnership with the California Department of Public Health. We have a number of TB survivors who'll be speaking and talking about their experience of receiving care in San Francisco. And then we have a couple of disease control investigators, TB disease investigation section chief of the TB branch, and a surveillance epidemiology manager from our TB clinic here in San Francisco, talking about contact investigation in TB prevention and talking about those activities here and the challenges in California. And then finally, at the end of our day, we have Lizzie Lovinger from Treatment Action Group, who'll be leading us in a session talking about advocacy. It's titled Fighting TB Together, Advocacy for All of Us. And I'm looking forward to that session. And then we have our our annual raffle drawing. Sophie Huddett, who's an assistant professor here at UCSF, she started a charity called Together Against TB, which raises money for TB survivors and families in San Francisco. And so there's the annual raffle. That's our sort of British sort of adoption here in San Francisco for that charity. And then we have closing remarks from Payam and Lisa Chen and Susanna Graves.
That sounds fantastic. It's, I have a feeling that in about 20 minutes there'll probably be a mad rush to go to the drinks reception here. But if not, I'll give them the link for the next 8 hours of your meeting. So really brilliant. And as always, fantastic to see you. And thank you so much to you and the team, all the people in the background who've made this all happen, because you know, it's great. We stand up and do this, but actually there's loads of people who make sure it all works at both ends. So brilliant to see you. Say hi to everyone, and I know you're going to have a wonderful day ahead. All the best.
Thank you, Mark.
Thanks for the panel.
Bye, everyone.
Thank you.
Right, Rishi, you got that joke ready? I'm going to hand over to Rishi Gupta. Why am I handing over to Rishi? Because each year, one person gets nominated with the joy of taking responsibility for organizing all of this. And this year, it was this man. So let's first of all give him a round of applause, because he's going to thank everyone else.
Thanks very much. Just before we get into some closing remarks, I think Catherine's going to come up and present the prizes from the ECR talk.
Will do. I'm actually not presenting any prizes. We will make arrangements with all of you to deliver prizes after the session over the coming days. But I would like to announce the winners of the ECR Turbo Talks. So in third place, from UCL, Shahida Rafique for her presentation, Riboswitches as Sentinels of Metabolic Adaptation in Mycobacteria Tuberculosis. In second place, Fatou Faal from MRC Unit The Gambia at LSHTM for her presentation, Differential Responses of M. tuberculosis Complex Lineages to TB Treatment Regimens. And in first place, Peter Velikovic from UCL for his presentation, Translational Pharmacology and Dose Rationale for imatinib and doramapimod. You can tell this is not my area, as host-directed therapy for treatment of pulmonary tuberculosis. So congratulations. And thank you again to all the ECR presenters and to our judging panel.
Brilliant. Thank you, Catherine. So closing remarks then. You'll all be pleased to hear that I'll keep this quite brief, but just wanted to share a few thank yous and then reflections as chair of the organising committee. So first, a few thank yous. It's been a really fabulous day. Thank you to all of our speakers, chairs and volunteers, along with Teresa and Abdul Makif for making sure that everything ran so smoothly. So thank you. A big thank you to our lived experience representatives, to Anja, Blessi, Priya. It was really amazing to hear your stories this morning, to set the scene for the day and really remind us about why we're all here. Thank you. Thanks to the sponsors, funders, so that was Bruker, Cepheid, Qiagen, Revity, and the Global Funds. We couldn't do it without you. A special thank you to Neil, Neil Stoker. Where are you, Neil? Please stand up. Doing such a fabulous job of coordinating the day. And to the rest of the organising committee, if I could ask you to all stand up, please. Big thank you to all of you. Please, sorry. For putting together a really great program, and a huge thank you to all of you for being here, all the questions and engagement throughout. It's been really fantastic. So some thoughts of reflection. So I'm not sure about all of you, but it really feels to me that the world around us is changing faster than ever. So it seems quite apt that today's theme has been all about TB in this changing world to reflect this. As a quick recap of the day, we began by thinking beyond the lungs, highlighting not only extrapulmonary TB, but also how TB really affects people, particularly in the context of multimorbidity, and therefore how we need to adapt our health systems to address those challenges. We then heard about the really big picture global trends, climate change, migration, disease definitions, and new treatment strategies such as long-acting injectables. Just before lunch, we had a really important discussion, important and difficult discussion, I would say, about our role as researchers in high-income settings and how we can really work in partnerships with the global south most effectively, most equitably, and most fairly. The early career researcher Turbo Talks was then such a fantastic whistle-stop tour to showcase the breadth and quality of research across UCL and the London School, led by our early career researchers, and so a big thank you to everybody who submitted abstracts. And then later this afternoon, we've had a really quite insightful discussion on the true potential for AI to accelerate our progress, and that's across scales, from drug discovery to evidence synthesis, to programmatic active case finding, and to early pediatric TB diagnosis, while recognizing our need to evaluate these tools and use them responsibly. And now, just to bring this all together, it does really feel to me that we can work towards addressing these huge challenges of TB in this changing world through the diversity of our research methods, through these equitable global partnerships, through developing, evaluating, implementing new tools responsibly, and by working closely with affected communities. And I'd just really like to highlight again, I think the UCL TB PPI group is a really great example of that, and so we're greatly appreciative of the work done by Conor and others to set that up. And so I'll end there with the most important announcement of the day, and that's that the drinks reception will now open in the foyer, in the lower ground level. So please do stay, enjoy yourselves, continue the conversations, and thank you all again.